At last, I want to show two cases of esophagus and gastric cancer. So in white light image, it looks like reddish, irregular mucosa. And in the central part, you can see some nodular change of the mucosa. And with NBI, you can clearly recognize extent of the lesion. And with magnification, you can identify irregular vessel within the clear demarcation line like this. And the periphery, you can see loop-like vessel. However, in the central nodular part, you can see non-loop vessel like this. So we can suspect this can be invade some muscularis mucosae or shallow submucosa like this. And of course, iodine chromoendoscopy clearly show extent of the tumor as an unstained area. And EUS show the lesion still preserve some mucosal layer beneath the lesion. So we perform ESD and confirm that the lesion still confined to the muscularis mucosae. And I would like to introduce latest video endoscopy system. So this is maybe very good for you outside Japan. This system is compatible with both 100 and 200 series. So you can use 190 scope and also you can use 200 optical zoom scope in this system. And recently it equipped texture and color enhancement mode. And maybe as you know, magnifying image, depth of field, depth of focus become very narrow. However, this system equipped expanded depth of focus. So I want to show some image. So this is a patient with atrophic gastritis and intestinal metaplasia. So color texture enhancement enhance the unevenness of the mucosa and the irregular color. And with NBI and somewhat similar to near focus mode, we can observe detailed microvasculature and the mucosal structure like this. And usually magnifying zoom endoscopy, we can see only very narrow area, but because of very expanded depth of focus, we can see clear image of microstructure and the microvasculature in this type of panoramic view. So this is my summary. In many aspects, such as risk classification, detection, differentiation, and staging of early-stage upper GI cancer, recent evidences support usefulness of image-enhanced endoscopy to improve diagnostic yield of endoscopy and to benefit clinical practice. So my last slide, but it is important to understand that sometimes people misunderstand that such kind of technology solve all problem, but it is not true. So technology does not totally take over human insights or technique. So this is also recent meta-analysis paper, and they show that the use of NBI improve detection of colorectal polyp, but with adequate or proper preparation, significance or usefulness is maximized. So such kind of basic preparation or basic knowledge or basic skill is still very important. And on top of that, if you use advanced technology, you can improve your clinical practice outcome efficiently. Thank you very much for kind attention.
Dr. Naresh, you are muted. Can you unmute yourself?
Can you hear me now?
Yeah, we can hear you.
Yes.
Yeah. Thank you, Professor Vedo. You've convinced us about the usefulness of advanced endoscopic imaging.
Yes.
I think I'll ask the panel first, is that in India, do we really have cancer esophagus or cancer stomach as important problems that we can pick up early lesions? Dr. Mohan Prasad?
Yeah, thanks, Naresh. That was a wonderful demonstration. I think we in India, we are very fast in our endoscopy. I think all the high-risk patients should be, probably posted on separate days. They should be sedated, properly prepared, and then if we start looking for, I'm sure we may be able to spot more cases. In our routine endoscopy workload, we may miss some of them, but nevertheless, we don't have that sort of early gastric cancer or early esophageal cancer as the Japanese see. We are just seeing them in the late stages. They don't come to us probably. That's why we just miss them out.
Saurabh, you are trained in the US. Your endoscopy training has been in the US, and now you're back in India.
Yes.
Do you hold the same sort of thing, idea that what Mohan Prasad has said, that perhaps we don't see them in the early stage? Why is that? Everything that is to be early will becomes late. I'm sure that's simple logic. So why do you think we're not picking them up, and what happens in the West?
Yeah, so I think in the West, I just have a corollary to colon cancer. And if you see, over time, we have detected polyps early. We have early colon cancer detection, and we know with screening colonoscopies, we've reduced the incidence of cancer. Historically, right-sided flat polyps were not considered polyps to begin with back in 20 years ago, but now we have soon over time realized that they are sessile-serrated polyps and that they are precancerous. And then over time, as gastroenterologists started recognizing it and removing those polyps, the incidence of colon cancer right-sided has gone down. So I think it's something similar to gastric cancer. It's the infrastructure that we have, the sedation, the amount of time that we can spend. I'm quite sure that we should be able to detect early cancers in India if we certainly follow protocols and screen the high-risk patients appropriately.
And we know that early gastric cancer precedes advanced cancer by at least 3 years. So we can gain 3 years by better imaging techniques at endoscopy.
Exactly.
I would also agree
Yes.
with Dr. Mohan Prasad that here we spend less time in the upper GI procedures, and probably we need to spend more time. And also, if we do the procedure under sedation, early suspicious cases, I think we should be able to pick up early cancers.
Dr. Paliswamy, in your unit,
Yes.
what is the present norm as far as magnification NBI? I'm using NBI as a kind of a generic term for any advanced endoscopic modality. What is your protocol? Do you use it routinely? Do you use it sort of selectively? How does it go?
We don't use it routinely, Dr. Naresh, and we use it only selectively. When we see a lesion suspicious for malignancy, then at that stage probably we use it. There is no protocol. First, some sort of research guide for a fellow, a DNB candidate. We do a research project on this imaging technology. Those cases, of course, we do regularly.
Mohan Prasad, what's your thing? Do you have again a screening thing? What is your screening protocol? You said high risk. So what, in your opinion, is high risk for upper GI cancers? We'll stick to upper GI because someone is talking on colon subsequently.
Yeah, actually, we find that squamous cell carcinoma is higher in all these smokers, and also, like Barrett's and going into adenocarcinoma. Those are cases, all those cases we just look with the NBI, but we have the 190 series, the Hexera 3 system. So we just spend time to look at all those. And again, the OG junction, we just focus. We just look at those, magnify and do targeted biopsies. All those we do. Of course, in the stomach, we really search for an early gastric cancer in all the patients. And if there is any, even the smallest suspicion of a small lesion, flat lesion or a protuberant lesion, we always do a magnification and then do biopsy. But the high risk patients, especially in smokers, and also family history of esophageal carcinoma, people with gastric cancer family history, atrophic gastritis, and all those patients where also we see intestinal metaplasia in the antrum. Those are cases where we concentrate more. We can just give a, right now, it's always helpful because under corona situation, we do the endoscopy, all the endoscopies under sedation. So we can take more time. We can even put on the cap and go and inspect. But this doesn't happen in a routine situation. We might miss out. So I think what the message that has to go to all the youngsters is, whenever you stratify clinically that this patient is a high risk patient, he should be allotted probably 30-minute slot and then should be sedated, properly prepped properly without mucus and all that, because I myself missed a obscure GI bleed case. I did an endoscopy and I missed a gastric ulcer myself, and I spotted it myself on capsule. We went back and saw there was mucus in that area. The preparation was not good, so we missed out that gastric ulcer on an endoscopy, picked up on capsule, again went back with the endoscope. So I think prepping the patient is very important and doing it under sedation. I think these patients should be stratified and separately posted, just like you post for therapeutic cases.
Okay, thank you, Bon. Let me ask Professor Vedo. Really, now Bon Prasad said you need to allot a lot of time. What is the recommended time for an upper GI screening endoscopy that is really needed?
So it's a bit difficult question. It really depends on the skill and the experience and also situation, like case volume.
How long do you take? How long do you take?
Usually one slot is 20 minutes, 15 to 20 minutes. And the actual procedure, we usually spend maybe 7 to 10 minutes. If we found some suspicious lesion, extra time, extra 2 or 3 minutes, but usually 7 something. And
so actually, it does not take a whole lot of time that people think that you'll be wasting time. It's actually not. Once you're trained, it's 7 to 10 minutes for a good examination.
I think so. Yeah.
Let me also ask you let me ask you a provocative question. All over the world, they talk about Japanese endoscopists, Western endoscopists, or non-Japanese endoscopists. What makes the Japanese endoscopist so committed and so much of a thing to be so perfect? And why is this attitude so different? Do we need to learn something from the Japanese endoscopists? Is it just patience, or is it the training, or all Japanese endoscopists like that? Or are there people who take shortcuts in Japan as well?
Maybe you meet some very selected patient, selection bias. You meet doctor attending a workshop or a congress, so maybe selection. I know not all, but.
So in your training, even when they start off without advanced imaging, without NBI and basic white light endoscopy, do you also sort of train them to take a lot of time and spend time and do?
But I think it's like if you do perform something routinely, you learn spontaneously. So basically, we use imaging enhancement NBI or something every time or every procedure, and we usually pick up some interesting case. So in a conference, we usually discuss and share the endoscopy image or something. So maybe routine practice so that the young doctor can learn spontaneously. So do it routinely is very important.
Saurabh, a last comment from you is, how would you train your residents now in India to do endoscopy now that you've seen the best of the West, you've been exposed to the best of Japanese endoscopy, and you now practicing in India. Saurabh? Saurabh, are you there? No. Dr. Palliswamy,
I would like to
would you
ask
like to take
question
that?
to Udo. Can this advanced imaging technology replace histopathology? That's the question to Udo. Can this advanced technology, imaging technology, replace the histopathology, biopsy?
Dr. Vedo,
Yes,
has advanced imaging replaced histopathology?
I think not totally, but in some part, we can say it looks really confident it is non-neoplastic or neoplastic compared to soul white light image. We can predict histological finding more accurately. So I think in some part, we take place histological finding like biopsy. Not 100%.
Naresh,
Do we have Dr. Suraj? Dr.
Yes.
Suraj or Dr. Gulshan
Yes.
on the screen? Suraj,
Yes.
any comments that you'd like to make? What are your challenges in advanced imaging in Imphal?
So, so this northeastern part of India is quite different from the rest of India. So unlike the rest, we have a lot of GI cancers, and definitely we have a lot of esophageal as well as stomach cancer. So we have started screening these high-risk candidates, like persons who have a chronic history of alcoholism.
Yeah, Mohan Prasad alluded to that. So
yeah,
what are your challenges?
and then like we are starting to pick up patients with early gastric cancer, and we do ESD. One of the challenges, our hands are, as already being detailed, our hands are all full. Like we are doing a lot of procedures like US ERCP. So we need more time to dedicate for image enhanced endoscopy. And one more thing is like the issue with this scopes and instruments, they are a bit costly. So this is not only for me, but for entire India, where these Zoom scopes are like, they're specialized and they're very costly, and there are cost issues with this. And then we need a lot of time for these patients so that we can pick up early like GI cancers.
Dr. Gulzan from Kazakhstan, are you there?
Yeah, she is not there.
He's not there? Okay, any comment from Mohan Prasad, last comment, and then we wind up?
Yeah, actually, I wanted to answer the question that you were asking. The Japanese, right, for decades have been trained to look for early gastric cancer. Because when I visited Kyoto and Chiba way back 40 years back, I used to see every case they used to spend at least 20 to 30 minutes in normal endoscopy. Everything, I'll ask the professor, what did you see? What is this? Was there something? And he'll say, no, this was normal. Then why did you take 30 minutes? But we very meticulously look for early gastric cancer. I mean, that sort of thing, as you start seeing more and more of early cases, then your eyes get trained. We, in our own endoscopy institution, we have spotted early squamous cell carcinomas, early gastric cancers. We have done ESD, EMR, and removed them. I also had presentation earlier on that. So I think it is possible to train one's eyes to look at those with more care and also with more training.
Thank you. I think we'll end this session. Thank you, Professor Vedo, for being with us on this Sunday evening. And thank you, Dr. Palliswamy, Mohan Prasad, Suraj, and Saurabh. Thank you. And back to you, Anil.
Thank you, Dr. Naresh. I am extremely thankful to Professor Udo, Dr. Naresh, and the whole team of expert panel members who are discussing about the recent advances in image enhanced endoscopy. We may have lost a battle with Japanese in terms of early detection, but we, as Dr. Mohan Prasad said, we are the fast runners in endoscopy. At least we have won some battle in athletics, if not in the endoscopy, without realizing that on long-term basis, we are the losers. So if we take one lesson, I think it is high time we take some good time to screen every patient rather than trying to characterize and categorize the subgroup of the patient, especially with smoking and gutka chewing habit being rampant, at least in north part of India. We, I'm sure, must be missing out large number of cases which we diagnosed early. As Dr. Naresh said, majority of these start with smaller cancer. At some point of time, somebody has to pick up the early cancer. With that, we come to the formal end of the first session. maybe switch on to the second session. That is another interesting problem of colonic polyps. As Dr. Vivek Kaul told us yesterday, at least 3 million colonic polyps are picked up by the US gastroenterologists in a year. This is the bread and butter of most of the colonoscopies all over the world. Earlier, the issues were very simple. If it is a large polyp, give it to the surgeon. If it is a small polyp, you remove it. But with image-enhanced endoscopy, you are able to characterize the polyp even without doing a biopsy. Depending upon the size of the lesion and the concomitant modalities like EUS, NBI, you are able to not only categorize the lesion, but also make all attempts to get out. Other than the fact when it is purely malignant on basis of image-enhanced endoscopy, you have people like Mohan Ramchandani who will do all efforts to do it colonoscopically. Dr. Mohan Ramchandani is going to present us his approach to diagnosis and management of the colonic polyps. He may have to play a double role of being a moderator as well as Dr. Rajesh Puri may be joining us late. Dr. Mohan Ramchandani.
Dr. Puri is in.
Yeah, okay. Dr. Rajesh, if you are there, can you introduce Dr. Mohan Ramchandani?
Yeah, am I audible there?
Yeah. You have to come closer to the mic. Yeah.
Am
and
I
remove
audible
your
now?
mask. We are away. You can remove your mask. We are far away from you.
Am I audible?
Yeah.
So Dr. Mohan Ramchandani is a dear colleague and he's a director interventional endoscopy at Asian Institute of Gastroenterology. I think he's a multifaceted man who is not only doing the ERCPs but single balloon, third space endoscopy and the NBI. So he don't need any introduction in the Asian countries. So I hand over the mic to the Mohan Ramchandani to talk about the colorectal polyp diagnosis and the treatment. And I've seen Dr. Noria Udo was also there. And I have learned, and many of my colleagues who is a panelist in this, they have also learned from Professor Noria Udo. Good evening, Professor Noria Udo, and thanks to Dr. Anil Arora for giving this opportunity.
Rajesh, can you please see to it that we stick to the timing? 20 minutes of talk and 15 minutes of discussion.
Yes.
Just to maintain the record.
Okay, so thank you, Dr. Anil, at the outset for giving me this opportunity, and Dr. Rajesh for your kind introduction. I think after Professor Vido's talk, it is so difficult to fit in that standard, but I will try my best to categorize and diagnose and treatment what is available in present scenario about colorectal polyps. So straight away coming to diagnosis, I think I'll be very precise, and this is the first step towards endoscopic treatment when a group of international surgeons, pathologists, and endoscopists sat together, and then they described the superficial morphologic, the superficial cancers, which are also known as type 0 cancer, which are endoscopically resectable, and they are limited to mucosa and submucosa. So this classification is very, very important for all of us to learn. And this type 0 classification, which is for superficial cancers, as I told, is divided into polypoidal and non-polypoidal, and you have to be very, very careful in classifying these cancers, because if a cancer is polypoidal, it has a lot of significance, and I will be speaking to you about that. But those polyp like pedunculated polyp or sessile polyp, they are the 0-1 type of polyp, and how to differentiate between the flat polyp, which is slightly superficial elevated, is by the closed biopsy forceps. If you close the biopsy forceps, which is height is 2.5 mm, and if the polyp is going above that, that means it is more than 2.5 mm from the surface, it is known as type 0S, that is sessile polyp, while others are known as flat polyp. So I'll be coming to that. So this is the pedunculated polyp or a sessile polyp. Rest is called as flat. The flat, which is usually around 1.3 mm in height, not like more than 2.5 mm in height, they are now classified as slightly elevated, flat, or slightly depressed. So depressed is always bad. So it brings depression because it is associated with more submucosal invasion. So type 3 are excavated. Majority of colonic polyps will be discussed in polypoidal or non-polypoidal in type 2 variety. So why it is important to understand Paris classification? Because if you're dealing with polypoidal lesions, that means they are elevated, the cancer rate is very, very less, 1%, 2.5%. But if you come to non-polypoidal, that is flat polyps, then the cancer rate increases to 7% to 6.6%. While if you come to the depressed lesion, as I told specifically, then you can see how much cancer it is. Almost 50 to 60% of the patient will be harboring cancer. So by mere looking at the superficial, not even going into the image enhancing in endoscopy, you can decide whether you're dealing with a bad polyp or a good polyp. Further, now this is another classification which came in 2008, and that was to describe laterally spreading tumor. Now, what is laterally spreading tumor? So the laterally spreading tumor is when the lateral growth of lesion is at least 1 centimeter. The polypoidal growth grows vertically upwards, depression growth goes vertically downwards, while laterally spreading tumors are those which spreads laterally and their vertical component is least. They are classified as granular. So G for granular and G for good. So granular are good, and they can be like homogeneously granular, or you may have another big sessile component which increase the nodularity. So this becomes mixed nodular type, and I'll come back to this. And those which are non-granular, they are bad because they are associated with more submucosal fibrosis, as has been shown this. So these are laterally spreading tumor, these are non-polypoidal, and they have, if they are homogeneously granular, as I told, granular is good, the cancer rate is 0.5%. But as there is evidence of dominant nodules within this homogeneity, they become mixed nodular, and that is the sessile component, that is 1S component is adding to 2A, that is 2A is flat, slightly elevated, then the cancer rate becomes higher. So now still we are just seeing the endoscopic view, not even seeing the image enhancing, and then this is non-granular. As I showed, to begin with, only the rate of cancer is high in non-granular, but non-granulars are associated with depression, like type 2C. So when they are associated with depression, the cancer rate further increases. So now we know that by Paris classification and by LST classification, we can say whether there is submucosal invasion or not. Then comes the role of image-enhanced endoscopy. Now, image-enhanced endoscopy studies the mucosa very well. Now, if you see this colonic mucosa, which is demarcated like a pentagon, when there is a crypt and then there are subepithelial capillary network which divides into them into various pentagon, and there is a round crypt orifice here. Now this pattern is because of these crypts which empties into the mucosa, and these crypts are lined by goblet cells, and these crypts also changes when there is development of tumor. So the pattern of mucosa, the crypt pattern and the vascular pattern changes as soon as there is development of cancer. So why not to study this surface pattern and vascular pattern to describe whether we are dealing with a hyperplastic polyp, which is very safe, versus adenoma, which can be resected endoscopically, or deep cancer. If we diagnose them by endoscopically, we can send them directly to surgery. So how to differentiate them? So this is a nice classification, that is NBI International Colorectal Endoscopic Classification. Now coming to type 1 and type 2, you have to basically see the color, vessel and surface pattern. If you can see here, the color is almost same as that of the surrounding. And here the color is slightly darker than that of surrounding. So this becomes adenoma and this becomes hyperplastic polyp. And if you can see the vessels here, the vessels are slightly dilated, and here these are lacy pattern. So if you see a polyp which has got same color as that of background mucosa, you are dealing with a hyperplastic or sessile serrated polyp. And if your color is darker than surrounding, you are dealing with adenoma. Then if you don't see any vessels on the surface, or you see isolated small lacy pattern, you are dealing with hyperplastic polyp. While if you are dealing with thick brown vessels like this, with surrounded by white structures, you are dealing with adenoma. And again, the surface pattern. We saw that the vessels, we saw the color, and then surface pattern. If you have these dark spots surrounded by white spots, this is hyperplastic. While if you have a tubular, branched or oval white structures surrounded by brown vessels, it is adenoma. So this is how the NICE classification differentiate between the hyperplastic polyp, where you need to follow these patients, while type 2 needs to be endoscopically resected. And if this vascular pattern become irregular or surface pattern becomes amorphous, then it becomes a type 3 invasive cancer, and these patients should be referred for surgery. And this is how the study has shown that if I diagnose type 1 cancer with a good confidence, 95% of the time I will be correct in diagnosing hyperplastic polyp. While if I diagnose type 3 cancers, I will be 93% of the time correct that it has gone deep into the submucosa. But type 2 is still a problem, because here there are two things. One is tubular adenoma and one is submucosal cancer. So type 2 still is not very good in classifying whether, so we need some improvement which can tell us whether it's a real benign adenoma or it is invasive, superficially invasive cancer. So this is a drawback of NICE classification. What else if we can do is, what we saw during Paris classification and combine the NICE classification, like if you see type 1 or type 2, and then additionally there is a depressed area, then you know that submucosa will be infiltrated. While if you have a type 3 cancer and that area is pedunculated, then yes, it still can be endoscopically resected because there is pedicle. So if you combine the image enhanced criteria and Paris criteria, you will be in a better position to say whether it is endoscopically treatable or surgically treatable, or you need further studies. These orange dots are for further studies when you have when you are still not clear. So NICE classification is not 100%. So how it can be nicer? If type 1 can differentiate it further into sessile serrated adenoma, which is common, as Saurabh was talking to us, that previously it was not paid attention much, but now it is very common. So NICE classification does not have a separate sessile serrated adenoma, and also the low grade dysplasia versus high grade dysplasia. So then came use of magnification. So NICE classification, you do not require magnification endoscopy. If it is there, it's okay, but if it is not there, still you can classify. So that is the situation in India also. So if you have a magnification endoscopy available, then you can divide this type 2 into type 2A and 2B, where we can say that whether we are dealing with low grade dysplasia and it can be endoscopically resectable, or it's a high grade dysplasia or shallow submucosal invasive cancer, where we'll be more careful. So this is Japanese NBI expert team classification, which took the help of magnification endoscopy along with NBI to further classify the type 2 into the low grade and high grade. This is the example you can see here. This is same color, black dots, dark spots, white spots. It is hyperplastic polyp. But if you see more carefully in a different polyp, you can see here again, this is very important. You barely see a polyp. And then you go closely and you are seeing these white, thin, lacy pattern of the vessels. The color is same. And then you are doing the magnification to further characterize this. And you are seeing now these dilated branched vessels, which are very, very thin still. And you are seeing this dilated crypts. As soon as you see this, you classify this type 1 into sessile serrated adenoma. So now with Japanese classification, we are classifying type 1 into hyperplastic or sessile serrated. This is type 2A classification, where we can see this is adenomatous polyp. There is no irregularity. Everything is regular. But if you see here in a different polyp, here there is a mix of two polyps. There is one regular pattern, and central there is a depression. And in the depressed area, if you apply the magnification endoscopy, you can see the irregular vessels, which is suggestive of submucosal invasion. So now we are more if you use magnification endoscopy, use Japanese criteria, then you will be able to diagnose in a much better way, as shown by this study. Type 2B, again, the problem here is you are able to diagnose type 2A, that is low-grade dysplasia 100%, but type 2B still is a problem. Type 2B means you are saying there is a superficial cancer, it is not correctly identifying it. So there needs some more thing, which I'll not go into details, but it will make the discussion more complicated. But in nutshell, if you have some doubt that type 2B or there is some deep invasion, you have to study the surface pattern. And surface pattern can be read by doing chromoendoscopy. And if you find the invasive pattern on the surface pattern, that means those patients whom you diagnose type 2B or in Sano type 3A, which are doubtful whether there is a deep invasion or not, and you are not able to 100% say that, you have to do additional chromoendoscopy, which will be required in 5% cases. 95% of the cases you will be able to diagnose by step 2 only. So now we have diagnosed that this patient has adenoma or high-grade dysplasia, and the submucosal invasion is not that deep. You can go for endoscopic treatment. While if there is a deep submucosal invasion, you have to go for surgery. So this is the criteria, because as the cancer invades beyond 1 millimeter in the submucosa in colon, there is lymph node metastasis, which is beyond acceptable limit. So so that is why 1000 micrometer is cut off in colon. Similarly, 500 micrometer in stomach and 200 micrometer in esophagus. So for colon, it is 1 millimeter. Now we have another kid on the block, that is cold snare polypectomy. The advantage is that it does not cause submucosal damage. And that is why the post-delayed bleeding, post-polypectomy delayed bleeding is much later. But the good thing is that you have to not use cautery, but you have to use a dedicated cold snare polypectomy. So these are shield shape. You have seen many shields. This is a shield shape. The loop is 9 millimeter. The wire is 0.3 millimeter thick, and it is monofilament. It is not like braided, and the sheath is very stiff. So these are the 4 characteristics: strong sheath, monofilament, loop 9 millimeter, wire thickness 3 millimeter, 0.3 millimeter. So that makes this ideal for cold snare polypectomy. And the cold snare polypectomy presently in the consensus is developing that it is good for less than 1 centimeter polyp. 10 millimeter polyp, it is good. So you have to press the sheath down and then just mechanically remove these polyp. And you can do as many as you want. People have now also used for sessile serrated and also for adenomatous polyp, which are more than 2 centimeter, but data is still accumulating. But majority of the 10 millimeter polyp or less can be managed easily by this. Resection rate is good. Residual polyp are equal to the hot snare polypectomy, but the advantage is there is no delayed bleeding. And you can see the 0% delayed bleeding. So those patients who are on antiplatelet, anticoagulant can be treated by this. Another method of treatment is EMR. And in EMR, you need to elevate the polyp by injecting saline. And you can achieve an en bloc resection if the polyp is less than 2 centimeter. You have to do a piecemeal resection if polyp is more than 2 centimeter. I'll just skip this video. I'll just show you elevation with glycerol or long-acting solution is good, and you have to use a conventional snare, and then you have to do this piecemeal polypectomy. So this is a very simple procedure, very quick procedure. The question is when to use this and when not to use this. We'll talk about that. So this is EMR. I'll take 5 minutes because I had to. I have some 5-6 slides, Rajesh. I'll take 5 minutes. Okay. So EMR, the problem is recurrence, 16% recurrence, but ultimately you will be able to treat many because these patients will come for surveillance colonoscopy, and during surveillance colonoscopy you can tackle these. But the problem is why this recurrence? Because you are doing piecemeal resection, and if you are doing piecemeal resection, there is no way you can assess the margins. So this is the meta-analysis which has shown that multivariate analysis, only that if you are not able to achieve an en bloc resection and you are supposed to do a piecemeal resection, that is the only cause of recurrences. Coming to the last one, this is the ESD. Now, what is the difference between ESD and EMR? We'll talk about that. So in colon, we are talking about colon, the ESD is first option if the lesion you are treating is non-granular or depressed, or the lesion is more than 20 millimeter. So this is the first you have to do ESD. There is no question about that. While you can do an EMR if you are having a granular tumor, you can do as big as granular tumor, you can do a EMR, piecemeal EMR, no problem. Or if the non-granular, non-depressed, less than 2 centimeter. So that is the European guideline. But Japanese are more strict. They say that those tumors which are mixed variety, like those which are, as I told, mixed nodular variety, those who are showing pseudo-depressed type, those who have invasive surface pattern, or those patients who have chronic inflammation such as ulcerative colitis and they are developing those localized tumors, those patients who have local residual early cancer after resection, these are having severe submucosal fibrosis. So these patients should also be treated by ESD. So Japanese say there are many other indications of ESD. ESD is a procedure where you have to inject the saline to separate the layers of the muscle and the tumor, and then there will be a submucosa, and then this needs to be en bloc resected. So this is the tumor. You have to peel it off from the muscle layer in this dissection plane, which is the dye being taken up by submucosa fiber, and this is how you do ESD. And in this video also, a mucosal incision followed by submucosal dissection. Careful submucosal dissection. You keep on dissecting this submucosa and removing this tumor completely. So this is ESD. The problem with ESD is that the good thing about ESD is that you get a full tumor, the margins are clear, and then you have a full en bloc resected specimen which is properly oriented, fixed on a rubber or a cork plate or thermocol, and sent for histopathological examination to tell us whether there is a lateral margins are free, deep margins are free, how is the submucosal invasion. So this is the best way of doing a complete oncological resection. We have problems with ESD like bleeding, perforation, and surgical treatment requirement, which can be now easily managed by, you can see here the perforation cost can be easily managed by hemoclipping. And this is a very good therapy, because if you do ESD, the recurrence rate at 3 years is only 2.4%. 5-year recurrence rate is 2%, even at high-grade dysplasia. So this is as good as surgery. And that is why proper diagnosis, the tumor localized to the submucosa, superficial submucosa, and proper selection of ESD can give us phenomenal results. And I'll end up with this talk. I'll not go into this table, but I will say that EMR and ESD are equally effective, provided that you follow those guidelines, which I have told, European guidelines, Japanese guidelines. If you select your patients proper for EMR, EMR is as good as ESD in colorectal polyps. Thank you very much.
Thank you, Mohan, for excellent lecture. And I will going to share the screen. I have 3 questions from Dr. Mohan, and I welcome Professor Noria Udo. Professor Noria Udo comments also. Is my slides are visible?
Yes.
Okay. So first question to Mohan. What is the role of chromoendoscopy when you have got a NBI? Number 1.
Yes. So
do you think artificial intelligence is going to remove the NBI technique done by the performer? And number 3, specimen handling. I think the most important thing is all of us are doing EMR, ESD, but I think specimen handling is very important. Which is proximal margin, which is the right lateral, which is the left lateral. I think there's how do you handle the specimen? 3 things to the audience, if you can give, and then we can discuss the case and the video discussion we can do it.
So all 3 questions are very, very important, Rajesh. First question of whether the chromoendoscopy is important or not. As I told, 95% of the cases can be easily diagnosed correctly without the use of chromoendoscopy. And in fact, NBI is nothing but electronic chromoendoscopy. It is causing, the enhancement of colors of vessels, and then there is a contrast, which is nothing but chromoendoscopy. But chromoendoscopy per se, the dye-based, is cumbersome, so we always try to avoid it. But if you are dealing with type 2B cancers, or if there is a doubt of deep submucosal invasion, then you can take a help of chromoendoscopy to say whether the surface pattern is invasive type of surface pattern, and then you can direct this patient directly for surgery rather than doing endoscopic treatment.
So JNET type 2B, where the chromoendoscopy might help in differentiating. Is that right?
Yes.
Then artificial intelligence?
Artificial intelligence is coming in a big way, especially polyp detection. And you can see here, the adenoma detection rate is much, much higher when you are having a computer-aided, the detection of the polyps. But still, I think it will not replace the human brain. I think human has to decide how to use artificial intelligence in its best way. We cannot get complacent and lose our technique because of the artificial intelligence. The artificial intelligence is here to help us, is not going to replace us. That is for sure.
The specimen handling?
I think that is very, very important. And as soon as you get the specimen, in fact, you should mark while doing the ESD itself, you can make 2 dots proximally to say that this specimen, this end is oral side, and 1 dot on the anal side, so that once the specimen is out, you will be knowing that this is oral side specimen, this is anal side specimen, this is right margin, this is left margin. So this is how we orient it, and it should be laid flat on a thermocol, because we don't have the rubber thing and other, we use the normal.
Any comment from Professor Noria Vedo, if he is there, or Professor Michael Wallace, they want to comment something on the specimen handling?
Yes, Michael Wallace, can you hear me here?
Yes.
Yeah, we can hear you.
Yeah, specimen handling is most critical when you suspect superficial submucosal invasion, as Mohan correctly pointed out, because this is where en bloc resection with negative margins is curative. But if you cannot accurately assess the margins, we cannot be certain that it's curative. So anytime you see this type 2B lesion or a very irregular surface pattern, I agree with Mohan that you should resect it en bloc and orient the specimen.
Okay. So can we shift to the case and the video discussion? I think we are already 10 minutes late. So as Mohan has already discussed the detail of the Paris classification, JNET classification. So I will keep the case limited and to be precise. And we have a esteemed panelist. My slides are not moving.
Rajesh, can you come closer to the mic, please?
Yeah, my slides are not moving. Yes.
Rajesh, you can use this arrow.
Is I'm audible now?
Yes.
Yeah.
So we have a esteemed panelist, Dr. Monish Chabra from Chandigarh, Mohali, Dr. Varun Gupta, Dr. Arun Khanduri, Dr. Sanjay Sharma, and Dr. Suresh Dubey. So I will keep the discussion very short because we have only 10 minutes left. There's a signal from Dr. Anil Arora to keep it brief. So I'm going to discuss a case, 33-year-old male. He presented with a history of bleeding per rectum from last 2 months. He underwent colonoscopy somewhere else, which shows 3 centimeter polypoidal lesion in the anorectum. Biopsy taken, which shows tubulovillous adenoma with the focal high-grade dysplasia. So my first question to Dr. Manish Chabra, if you look at the colonoscopy report, 3 centimeter polypoidal lesion in anorectum, is this description is sufficient? Number one, and how you are going to proceed in this case? Is this information is sufficient? Would you like to do the NBI? So how do you proceed in this case?
Thank you, Dr. Puri, for your question. And thank you, Dr. Arora, for your invitation. So this 33-year-old gentleman who had a colonoscopy had a polypoidal sessile lesion in the distal rectum. And the most important thing here is a treatment guide for the optimal treatment of this lesion. And we need to answer the most important question, is it amenable to endoscopic resection or we need to refer him to a surgeon? So for this, we need information regarding the depth of invasion of this lesion. And for this, as Mohan said, the description is not sufficient in this particular case because we need more macroscopic characteristics on high definition white light endoscopy with Paris classification on surface morphology. And there are other features of macroscopic thing on white light, like firmness of the lesion, hardness, any demarcated depressed area seen within the lesion, surrounding mucosa showing chicken skin appearance, which can tell us that it has a submucosal invasion. And then by using image enhanced endoscopy like NBI with vascular and surface pattern, you differentiate these lesions into NICE and JNET classification, which gives an basically optical diagnosis of histopathology. And rarely, as Mohan discussed, that in JNET type 2B, sometimes you have to use crystal violet for chroma endoscopy to differentiate superficial from deep submucosal invasion. So after doing these things, you classify as non-invasive and invasive and take a call whether the patient requires a ESD, EMR, or a simple polypectomy, depending on the size of the lesion.
So excellent, Dr. Manish. I think you rightly said we should give the morphological classification, that is Paris, and we give the NBI and the JNET classification to know about the depth of invasion, and we can plan, does this patient require endoscopic removal or does this patient should be subjected to the surgery? So if you look at this patient, this is the retroverted view, a large sessile depressed polyp. Will you describe, Dr. Manish Chabra?
Yeah, on white light endoscopy on Paris classification, this appears to be 01S lesion with a central depression. And I would say that it could be the central depression could be a 2C component here along with the 01S. And
so my next question to Dr. Varun Gupta. You have seen what is the Paris classification in this? Dr. Varun? Is Dr. Varun there?
Am I audible, Dr. Puri?
Yeah, you are audible. So can you describe the Paris classification on this?
So as Dr. Mohan showed in his first slide, so we divide, when we talk about Paris classification in GI cancers, early GI cancers, so the first thing we need to keep in mind whether you feel it's a polypoidal lesion or it's a non-polypoidal lesion. The first impression which comes to me with this video is that it's a polypoidal lesion, definitely. And of course, there is no peduncle. So I will keep as type O1S, the first possibility. It's a sessile one. We can't appreciate any peduncle. It's very close to the anal verge and dental line. And I will not agree with the Dr. Manish on 2AS because I feel that height elevation of the lesion, so of course, 2AS, if we don't know whether we need to closely again examine through NBI and all to give a wording about 2SC. But it's definitely 1S according to me.
Okay, Dr. Michael Wallace is there. Dr. Wallace?
Or clearly the lesion is, it's not pedunculated. So this, in a pedunculated lesion, these are removed by simple polypectomy, even if it's an invasive cancer. If it's a sessile or sessile lesion with a depressed component, we know even sessile alone in rectal lesions, large bulky sessile lesions are more likely to harbor invasive carcinoma, and rectal lesions as compared to colonic lesions are also more likely to harbor invasive carcinoma. So I think this is clearly a bulky 1S lesion. There's some slight disagreement if there's a 2C component, but in this case, the surface pattern is also irregular. It's oozing slightly with blood. So I think this is suspicious for superficially invasive carcinoma. And for me, I would remove this by en bloc resection, likely ESD.
Okay, so in my opinion, this is type 1S and 2C because if you look at the depressed area, this is sessile, no doubt about it. But you not only look for the sessile nature, you have to examine the entire polyp, and morphologically, there is a central depressed area and the elevated margin. So if you look at the Paris classification, in my opinion, we keep the diagnosis of 1S, 2AC. And to Dr. Arun Khanduri, he has listened to a nice classification given by Dr. Mohan. What is the, on NBI, according to you, which nice is a nice 1, 2, 3? What is your opinion?
The first thing which I notice here, we have to notice the color. And I think the color is darker brown. So this doesn't appear to be a hyperplastic and it is so large lesion, so it's unlikely. With the brown color, now we have to see the vessels. And the vessels here are, again, you can see they are brown vessels and they are surrounding the white structures very regularly. At least the portion which is marked here, they are seen as surrounding the white structure regularly. So this is the vessel pattern. And if you see the pattern of the surface, you again see that there are white areas. And these white areas are tubular, not oval, but tubular. So this fits into the type 2 of the NICE classification, at least this area. But I must say, Dr. Puri, the depressed area also has to be seen, as Dr. Mohan did point out. But here, I would place it as type 2 of the NICE classification according to the NBI.
So I agree with Dr. Khanduri because if you look at this depressed area is not very nicely examined by us, or it may not have been taken the photograph. So it is a nice type 2. So when we do the JNET classification, the question to Dr. Sanjay Sharma, what kind of JNET this is, type 2A or type 2B? Dr. Sanjay? Is Dr. Sanjay there?
Sanjay, can you unmute yourself? I think maybe he has got disconnected.
So Dr. Munish Shabra, I will ask Dr. Munish Shabra because he has a fantastic knowledge of this. Dr. Munish, will you say what kind of JNET classification in this polyp?
You see, the area which you marked was JNET type 2A, but we have to see very closely at some point, it seems that it could be type 2B also. I'm not sure because the near focus part.
Can you look at here?
The image on the left, this image is basically JNET type 2A, very regular vessels surrounding the glands. And if you see a picture on the right, which is from a different area, is JNET type 2B.
Yeah. So we keep the diagnosis of JNET type 2B in this case, although the image may not be completely representative. but there were the variable caliber irregular vessels, and the surface at the depressed area was irregular and the obscure, and that's why we thought this is a type 2B. Now for the description, this was a lower rectum. Size is around 2.5 to 3 centimeter. Paris is 1S2, 1AC, what we have kept. The surface was irregular, vessels was not so irregular, nice type 2 and JNet type 2B. So this was our description, and I would like to request all the gastroenterologists, when they describe the polyp, I think the description should be like this, rather than a one line written that there is a polyp situated in the anorectum. If you write this type of classification, anybody can identify what kind of therapy this patient will be subjected to. We did an MRI because we subjected JNet2B and there was no lymph node and it was limited to the mucosa only. Now, therapeutic option, question to Dr. Saroj Dubey. I know the cold smear polypectomy is out, hot smear is out. The question comes between endoscopic submucosal dissection versus surgical resection. So this question to Dr. Saroj Dubey, what is your preference, surgery or ESD?
Thank you, Dr. Rajesh, and thank you, Dr. Arora, for inviting. It's a wonderful case discussion. So, Dr. Rajesh, based on whatever information we have, it's a large, around 2.5 to 3 centimeter lesion with the Paris class, maybe 1S, and nice 2 JNet 2B, lower, it's a lower lesion at the anorectum. So, EMR would not be a very good option in this case because end block resection would not be possible. And since there is a dysplastic component, we'd like to go for an end block resection. And I would not like to subject the patient to surgery because I feel in expert hands like yours, ESD would be a better option in this case. That is
So
my
any difference of opinion, because he's a young male, we suspected JNet type 2B.
Moreover, the surgery will be very, morbid. It will be like a permanent stoma almost. So that is why I think we should attempt an en bloc ESD and then assess the margins, assess the submucosal invasion, and then decide.
I have one question for Dr. Rajesh and Dr. Mohan. There was some blood and all. So does it indicate that it is sort of friable? And is it in the reach of per rector? And can we should we also look at the surface, whether it is indurated and whether this will help sort of into the older findings? Not
the
the
question to Dr. Mohan: if you do a transanal excision,
yeah, that will be like ESD.
ESD?
Yeah, that is like ESD. So that is not surgery. Surgery means we were talking about invasive open surgery versus TME is equal to ESD, I think, done in a different way. Whole aim is to get an en bloc resection.
Dr. Velas, any opinion about you, surgery versus ESD? Young man, JNet type 2B.
I agree with all the panelists. I think surgery should really be reserved only when there's very clear evidence of a deeply invasive cancer. There's always some uncertainty here, but an ESD or en bloc EMR could be performed here. And it's been shown now that even if the final pathology shows a more deeply invasive lesion, that does not significantly interfere with subsequent surgery. So I would favor the less invasive approach here.
So this case was discussed with Professor Norio Vedo, and he planned to do the ESD, and in this patient, the ESD was done. So because of the shortage of the time, just I would like to say the incidence of the submucosal invasion, morphology, and the size, more than 2 centimeter, 1S is around 30%. Submucosal invasion, and if the patient has type 2C and more than 2 centimeter, the submucosal invasion will be 87%.
I think, Rajesh, we have to answer Dr. Khanduri's question regarding the easy friability. Does it carry any significance now? Or?
So I think in this case, it was not friable. This was because of the scope trauma. This was not easily friable. This is just washed away. There was a small blood and it was in the anorectum. When the patient tried to pass the motion, he exerted the pressure and there's a little bit of the stress related to blood. It is not a friable disease.
Rajesh, Sanjay Sharma is back on the panel. Can you just involve him?
So I think I will ask Sanjay Sharma a different question. We did an ESD and post ESD after 3 months. This is the NBI image which shows no recurrence of disease. Now the question comes, my question, my problem is young man with the possible submucosal invasion, which are shown on the biopsy, how you are going to follow this patient. Question to Dr. Sanjay Sharma, how you are going to follow this patient. Is this the one-time cure? How you are going to follow this patient that there's no recurrence of disease or there is a lymph node? Do you think doing the endoscopic ultrasound
I would
going
like to do a surveillance colonoscopy maybe after 3 months and followed by radiological imaging like MRI pelvis. Am I audible? I'm sorry.
Yeah, you are audible.
Yes, Sanjay.
So these are the things I would like to do because I'm not very sure. She's a young patient and with this JNET2, the chance of recurrence is not very low. So I would go with the regular surveillance colonoscopy maybe in first year 3 monthly and then and MRI pelvis or radiological imaging sideways.
So Professor Wallace?
Rajesh, before Professor Wallace comes in, I think I'll ask you, because as you told how we report polyps in endoscopically, histologically also, we should have a very nice report of a polyp, means where is that invasion, how deep it is, how much micrometer of submucosa is involved, what is the vertical margin, what are the lateral margin, what is the differentiation, what is lymphovascular invasion. So these are the things which they are all negative. That means it is a curative resection and we can leave this patient alone. While if we find some, red flag signs, we should bring oncologist and multidisciplinary, it should be discussed.
Okay. Professor Wallace is there?
Yeah, I agree with Dr. Mohan. I think first we need to assess pathologically the risk of nodal disease. In addition, whenever there's an invasive cancer, even superficial, we should assess for microsatellite instability or mismatch repair defects. In a young patient especially, we're concerned about genetic syndromes like Lynch syndrome. Assuming those are negative and the risk of lymph node metastases are low, we would surveil the patient. And I agree with the panelists, there's various recommendations, but typically a relook at 3 months and then extending the interval. But these patients need to be followed for 5 years with imaging and colonoscopy to exclude recurrence.
So with this, I'm going to complete this session and thank Professor Michael Wallace, Mohan, Dr. Arun Khanduri, Dr. Munish Shabra, Dr. Sanjay Sharma, Dr. Varun, and thank you, Professor Anil Arora, for giving this opportunity. Any questions from the audience? If we have a time, we are ready to reply. And if we are already, I think we are 5 minutes behind. We have 5 minutes already past the time. Dr. Anil is there?
Yeah, Rajesh, yes, I think we have taken more time. We can answer the questions on PDF format later on.
Okay. Thank you, Dr. Anil. Thank you.
Thank you so much, everybody.
Thank you, Rajesh. Thank you, Dr. Mohan, for excellent presentation. And if in one-liner we have to submit what Mohan has told us, if you want to be really nice, look at the color of the polyp, look at the surface and the vascular pattern. If you want to be nicer, use magnification endoscopy. And if you want to be the nicest as he is, then use a chromoendoscopy. Is that right? And finally, the type of therapy is to be decided by these 3 components, and the type of lesion which he has taken out, which has showed us live, one cannot distinguish whether it has been removed by Dr. Mohan Ramchandani or G.V. Rao. That is a tribute to him. With that, we come to the formal end of the presentation of the second session. And I thank all the speakers, panelists, and the moderator.
Thank you.
We switch on to the third session of the day. See, when most of us at our age had started learning the gastroenterology practice, we were taught how to do ultrasonography, how to do an endoscopy. But somewhere down the lane, 10 years later, early in mid-19th, there was a marriage between endoscope and ultrasound. And we had a birth of a new super speciality called endoscopic ultrasonography. We had the doyen of EUS, Dr. Robert Hayes and Dr. Shyam Vardharalaju, who had been regularly visiting India. And initially it looked to be pretty cumbersome and non-rewarding procedure. But down the lane, over the last 2 decades, it has become the integral part of practice of gastroenterology. And now we realize how is it that we learned gastroenterology without learning EUS. To take us through the journey of EUS, especially the recent advances over the last 2 years, we have none other than Professor Michael Wallace, who is the leading EUS expert in the US, and Dr. S.S. Rana is going to us to take through the journey of EUS, the recent advances. Dr. S.S. Rana, please.
Thank you, sir. Good morning, Mike, and good evening to all the audience here in India. It's indeed a privilege and honor to moderate a session by a leading expert, Professor Michael Wallace, whom as we all know as a chief editor of GI Endoscopy. He is Fred C. Anderson Professor of Medicine and Director of Digestive Diseases at Mayo Clinic in Jacksonville, Florida. He has served as an associate editor of gastroenterology, and he has a number of laurels and awards to him. He has more than 350 peer-reviewed publications, and he's going to speak to us on recent advances in diagnostic EUS. Although we have been learning a lot about interventional EUS and how it is making big strides in the field of GI endoscopy, but diagnostic EUS also silently has made bigger strides, and it again has a major role to play in future in the practice of gastroenterology and endoscopy. With these few words, I hand over the mic to the Mike Wallace, who is going to speak on recent advances in diagnostic EUS.
And Dr. Surinder, may I again request you to please stick to the time for the other speakers to be
sure.
sticking to the time.
Yeah.
Very good. Thank you very much for that very kind introduction. Can you see my slides now?
Yes.
Yeah, we can see your slides, yeah.
Okay, very good. So I will focus largely on the last few years of development, but history is also very important. And I'll begin with the very beginning of endoscopy. Over this next 20 minutes, I'll cover the increasing role of EUS in screening for pancreas cancer, recent advances in EUS tissue acquisition with improved needle designs, other advances in enhanced EUS imaging. I'll focus on some recent work in elastography. And lastly, we'll turn to a very exciting area of the role of EUS in liver disease, including both traditional methods like liver biopsy, variceal therapy, and a very recent addition, the use of portal vein and hepatic vein pressure measurement, allowing really a comprehensive evaluation of the liver. So in the beginning, which was actually more than 40 years ago now, the first 2 reports in the world of an endoscope married to an ultrasound device were reported, one from Japan and one, I'm happy to say, from the Mayo Clinic in Rochester by the famous pancreatologist Eugene DiMagno. As you can see, the instrument was very difficult. It was very blunt. And both of these investigators determined after these initial studies that EUS would never become a useful technology. And this instrument was put in the closet for more than 10 years until it resurfaced with smaller endoscopes. And most importantly, as was highlighted in the introduction, the advancement of needle-guided EUS or EUS-guided needle procedures really was the major breakthrough that brought EUS into the mainstream. So I'll turn now to several topics, beginning with pancreas cancer. The most common indication in our practice, and I think throughout much of the world for EUS, is for tissue biopsy. And particularly focusing on pancreas cancer, up until perhaps 10 years ago, there was some debate if we needed to do a biopsy at all. If someone had a pancreas mass and malignant obstructive jaundice, they needed to go to surgery. But that has changed in the last 10 years. We've really shifted our treatment for pancreas cancer, and in fact for several other cancers, to a neoadjuvant therapy where the patient gets chemotherapy before surgery. And to get chemotherapy, you have to have a biopsy. And that has driven much of the demand for endoscopic ultrasound. In addition, several other diseases which can mimic pancreas cancer have also surfaced, most notably autoimmune pancreatitis. And it's often a tragedy to see a patient with an enlarged head of pancreas go to a Whipple resection when the final pathology is only autoimmune disease that could be treated by simple corticosteroids. In aggregate, patients who present with pancreatic masses, about 10 to 15% of these are not surgical disease, emphasizing the need for preoperative endoscopic ultrasound and biopsy to characterize what disease they have. Also, in very recent years, the ability to do very focused genetic sequencing of tumors has opened up a new area of precision therapy. And these can now be performed on standard EUS-guided needle biopsies, particularly with the new specialized needles for biopsy, which I'll cover in just a moment. We now have many different needles available. They generally fall into two categories: the traditional fine needle aspirate needles and the new fine needle biopsy needles. And we're currently in our third generation of biopsy needles. And really, this is where we've seen the most dramatic change. The first two generations of needle biopsy instruments were largely small incremental change and difficult to use. However, in this third generation, which involve at least 2 or 3 prongs at the tip of the needle, this allows large tissue acquisition very efficiently, often with only 1 or 2 passes, and allows gaining sufficient tissue for histology as well as molecular classification. This is one of the early reports from our group about 4 years ago, a case control trial in 156 patients who were sampled with the so-called shark core or fork tip needle. These were compared to a matched group of 117 patients. You can see here the difference in the concept. The standard FNA needle has a single bevel, and the tissue, some of it goes into the needle lumen, but much of the tissue slides along the outer surface of the bevel. With the new Francine or fork tip needles, the tissue is funneled into the needle lumen, and so a much larger specimen is obtained even for the same size of needle. You can see here some of the bulk specimens on the right. You get true histology with these, so you can perform all of the normal histological staining. And in this study, this is the one that I mentioned, we've shown that we can reduce significantly the number of needle passes, typically from 4 to 2. And in many cases, actually with the larger needles, like a 19 or 22 gauge needle, only 1 needle pass is necessary to obtain a sufficient specimen. Overall, the yield for histology is significantly higher with the fine needle biopsy. This is on a single pass. 95% of samples had histology versus only 59% with traditional FNA. And you can see the very bulky specimens that are obtained, which are easily amenable to supplemental studies such as immunohistochemistry and molecular profiling. This is a nice study from Shyam's group in Orlando, Florida, a randomized trial of the 2 currently available Francine or fork tip needles, one from Boston Scientific, one from Medtronic called Shark Core. And overall, these are largely equivalent. In this trial from Shyam's group, you can see the total tissue area, the total tumor area, the tumor to tissue ratio, and the desmoplasia all were very similar between the 2 types of needles. So I think both of the new currently available FNB needles work very well and are quite comparable between the 2. This is a recent study that our group completed, a randomized trial of FNA versus FNB with the fork tip needle. The order was randomized, but all tumors were sampled with both needles. They were evaluated with a standard histological score, and then we performed DNA quantification for whole exome sequencing on the samples. What you can see is that there was a significant increase. Now, 92% of FNB samples had histological quality specimens versus 42%. This is very much in line with our retrospective case control study. Overall parameters for tumor cellularity also strongly favored fine needle biopsy with more tumor cellularity. A common commercially available genetic sequencing assay called Foundation 1 was also 78% of samples on a single pass. We could perform this genetic analysis. And also the final biopsy. Now, both samples were very good for final biopsy. So we can get a biopsy-proven cancer with either needle. It's these supplemental materials that are most helpful. You can see also the DNA yield was significantly more. This is in nanograms per microliter, almost 6 nanograms per microliter of DNA with the FNB needle, which is about twice that with the FNA needle. And now actually with modern sequencing, both of these samples can be subjected to DNA sequencing technologies. Let me now turn to screening for pancreas cancer. We focused much of our screening efforts in the GI world on colorectal cancer, as well as esophageal squamous cell and adeno, and to some extent on gastric cancer. But pancreas cancer has not traditionally been one that we screen for. However, there's an emerging opportunity to screen for this very, very fatal disease. In the United States, at least, only 9% of individuals survive the diagnosis of pancreas cancer. And the survival is, like other cancers, very dependent on stage. However, unlike many other solid cancers, even stage 1A and 1B disease have very high mortality. You can see in these survival curves that less than half of even stage 1A patients will survive out to 6 to 5 years. So we really must diagnose pancreatic cancer at its very earliest stage, ideally at stage 1A, or even better, high-grade dysplasia. How should we do that? Well, we know from other cancers that we first need to define a population at risk. This should be done with less invasive or non-invasive tests such as blood biomarkers, stool biomarkers, or family history. This is followed by an enrichment phase, and this is where EUS is most valuable, using EUS and MRI, followed by a biopsy confirmation. Does this work? Well, there's an international consensus for cancer of the pancreas screening called CAPS. It's enrolled a large number of patients looking at this model for screening for pancreas cancer with the goal to detect T1N0 or high-grade dysplasia. Patients were enrolled who were at high risk based on family history or known genetic syndromes or cystic lesions of the pancreas, and they were screened with MRI and endoscopic ultrasound. The yield was quite high, particularly for cystic lesions. Almost 40% of these 225 patients had cystic lesions, and about 1.5% had solid tumors. These are really the ones we're looking for, as well as the high-risk cystic lesions. So yield is relatively high. If we look overall, do these patients then progress to high-grade dysplasia? And the answer is yes. About 7% overall progressed, or about 1.5 per year. This is, for example, substantially higher than the rate of progression in Barrett's esophagus. And importantly, about 93% of lesions had detectable lesions without worrisome features before their diagnosis of cancer. And if you look at the survival, this mimics other diseases that we screen for. If we catch them at this very early stage, high-grade dysplasia, we can cure the vast majority of these. Even the invasive adenocarcinomas that were detected during surveillance had substantially better survival than those that were detected based on symptoms alone. So I think we do have emerging evidence that we can screen for pancreas cancer and potentially make an impact. Let me now turn to some of the emerging technologies for early detection and classification, and I'll focus on EUS elastography for purposes of time. We now have multiple methods that enhance our image with endoscopic ultrasound, and one of them that's available on many of the modern EUS instruments is called elastography, and particularly a form called strain ratio. Since we cannot estimate the absolute tissue stiffness, what we do is we typically compare the stiffness of a region of interest, for example, the tumor, to the stiffness in an adjacent normal area, which can either be adjacent normal pancreas or the wall of the intestine. This very nice study from the group in Italy, published a couple of years ago, shows substantial separation between the strain ratio between malignant lesions, neuroendocrine lesions, and inflammatory lesions. So I think although this will not replace biopsy, it will help us distinguish this very difficult question we sometimes face. Is this an inflammatory mass, an autoimmune pancreatitis, or a malignant lesion? So to summarize how we're currently screening for pancreas cancer, first we identify individuals at increased risk based on family history or genetic testing, also new onset diabetes in a patient who's not gaining weight. We can identify those at intermediate or high risk. Those at intermediate risk get further enriched by MRI, blood, or stool tests, and at high risk for endoscopic ultrasound and MRI. And it's really in this high risk group where we have good evidence now that we're making an impact in identifying patients who have curable disease, unlike those that present with symptoms and a large mass. I'll touch briefly on pancreatic cystic lesions. These have been very well studied over the last few years. There's a few new diagnostic issues which are important. This is a typical patient, a middle-aged female who presents for a CAT scan for other reasons, and they identify this cyst in the body or tail of the pancreas, and you're asked as a gastroenterologist, should we sample this? Unfortunately, the guidelines and dilemmas are still quite significant. We ask, is this mucinous, serous, or non-neoplastic at all? Is it malignant or likely to become malignant? And how should we manage it? Should we resect it, observe it, ablate it, or do nothing? The patients often are very worried. They hear about a pancreas neoplasia and they think this is cancer, and they know that that's a fatal disease. So they're going to ask you, should we just reassure them, or should we really tell her what is probably the truth? We really don't know what is the major risk, although our knowledge is gaining very rapidly in this area where we can define that risk. Unfortunately, we also have multiple guidelines that are somewhat conflicting, although they generally do agree on the highest risk lesions. The highest risk lesions that require invasive sampling and potentially surgery are main duct disease, especially main duct over 10 millimeters. Intermediate risk would be main duct 6 millimeters or more, a jaundice patient, or anyone with a solid mural nodule, or an FNA that shows suspicious or malignant cytology. Pancreatitis or other symptoms are a relative indication for invasive evaluation, and cysts greater than 2 centimeters also are a relative indication for invasive evaluation, such as US FNA. Also, increasing size and a threshold value has been set at 2 millimeters per year. Serum elevated CA19-9 is controversial, but in some cases may be helpful, especially if it is rising. So just to summarize the current data on cysts, the current guidelines all have fairly limited accuracy when compared to surgery. Surgery in EUS FNA can find up to 12% of patients with missed high-grade dysplasia or cancer because of the somewhat modest sensitivity of our current imaging and even biopsy. But most of these lesions are high risk and can be followed expectantly. However, there is a small subgroup, particularly those I outlined before, such as the larger cysts and main duct cysts or mural nodules, that are high risk and should be followed very closely or offered resection. There are a couple of new methods for diagnosis of these lesions. I'll focus on the through-the-needle microforceps. The data on confocal is still somewhat controversial in my view, and pancreatoscopy is sometimes reserved for distinguishing a benign dilated main duct versus an IPMN main duct lesion. These are new forceps that are currently available. They've been studied for the last couple of years. They do significantly increase the yield of tissue. These are passed through a 19-gauge needle, and you can now get histology with these through-the-needle forceps. And they have been shown in cohort studies to increase the overall diagnostic accuracy compared to fine needle aspiration alone. However, there is a significant risk of bleeding and pancreatitis. I'll now turn to a new field, US hepatology. And in my last area, I think this is really an exciting area given the very high and rising prevalence of liver disease throughout the world. I think US can play a central role in the diagnosis of liver disease because it really offers a one-stop option to evaluate almost all components of liver disease, from liver biopsy, elastography, contrast enhancement, ascites aspiration, paracentesis, and even most recently, portal vein sampling. So compared to our current approach, where we typically do a diagnostic endoscopy for variceal assessment and other radiographic or interventional radiology assessments for fibrosis, measuring portal pressures, diagnosing lesions, paracentesis, endoscopic ultrasound allows us to do all of these procedures in a single step, offering significant convenience and efficiency to the patient. We've been able to do liver biopsy for quite some time. It's especially useful in the very obese patient where percutaneous liver biopsy is often not feasible, but it's really quite feasible in all patients who need liver evaluation. We have very good evidence that we can obtain high quality liver biopsy specimens, especially with the newer needles. We can get the large samples, 2 to 3 centimeters in length with a large number of portal triads. This was a meta-analysis looking at the overall yield of liver biopsy, which showed it to be quite effective. You can see the overall pooled rate of successful histology of about 94%, a pooled rate of insufficient specimen of about 10%, and a pooled rate of adverse events of about 2%. This histologic yield is likely actually higher than this with the newer type fork tip needles or Francine tip needles that I showed earlier in the pancreas. We also now have emerging, in fact, established evidence that we can treat gastric varices through US guided interventions. This is likely preferred to blind cyanoacrylate injection, and particularly the advent of coil therapy or coil therapy combined with glue is a major recent advancement. This was a randomized controlled trial of 60 patients who underwent coils alone or coils plus glue. There was a significant improvement in all parameters, including immediate disappearance of varices, a significant reduction in rebleeding, and a significant improvement in reintervention rates. And a further systematic review of this topic again showed very high efficacy of coil plus glue. And I think this is emerging as the treatment of choice for large gastric varices, particularly the isolated fundic varices. In the last slides, I'll turn to the most recent advancement in diagnostic EUS-guided portal pressure measurements. This was first reported in 2017 with successful portal pressure gradients measured in 28 patients. The readings are taken from direct 25 gauge needle puncture of the portal vein and hepatic vein with a direct difference or gradient calculated as opposed to the estimated gradient, which is obtained from hepatic vein wedge pressures. There have been no adverse events reported in this series, and the time is relatively quick, less than 30 minutes for these procedures, and they correlated very well with traditional measures of portal hypertension. This is the technique count. Now, this device was just recently approved in the United States. We puncture the left hepatic vein or middle hepatic vein from the GE junction. It's a 25 gauge needle with a pressure transducer. Then secondarily, we puncture the portal vein and measure the pressure in the portal vein and calculate the true portal pressure hepatic vein pressure difference. This is the small pressure transducer, which is just hooked to the back of a standard US needle. We just started performing these in our hospital. It's quite simple and safe for people with experience with EUS-guided needle puncture. So just to summarize, EUS is a well-established method of choice for pancreatic tumor and cyst biopsy or FNA. It has emerging roles of supplemental methods such as elastography, cyst fluid biomarkers, cyst microforceps biopsy. We now have good evidence that the new fine needle biopsy devices are superior to fine needle aspiration for histology and DNA yield, and an expanding role for screening patients for pancreatic cancer. And I think there's a large potential for expansion in the EUS hepatology area. Thank you very much.
Thanks, Mike, for an excellent presentation and an updated overview on recent advances in diagnostic EUS. And as you have rightly said, it's an upcoming field. There are a lot of great advances happening, and diagnostic EUS is going to stay in clinical practice with these advances in place. So we have a panel with us who is going to take through us in the next 10 to 15 minutes. We are going to discuss your talk and the recent advances in diagnostic EUS. So we have Dr. Ajay Bhalla with us. Is he there? Yeah, he's there. Okay, yeah. So as Mike talked about the role of EUS FNB needles, and FNB needles seem to be much better than FNA needles in all the aspects. So do you think that FNA needles are obsolete? They don't have any role in clinical practice, considering the cost factor, especially in developing countries like ours?
Yeah, I think Professor Wallace has already kind of driven the point home, but the EUS tissue acquisition is constantly undergoing development. There was a time when FNA was considered the gold standard, but currently with the approach that we need to have, where we need to acquire better tissue, the tissue acquisition is poorer in fine FNA needles. And also, if you do not have rows available, rapid on-site evaluation, which is not available in most of our centers, I think FNB would be far more superior. And it has been proven that third generation, the one with the crown at the tip, have fewer passes. The duration of time is less. Also, the diagnostic yield, the histological specimen is far better. So I don't think, earlier what was thought to be as a salvage therapy, that if FNA fails, then you have to think of FNB. But I think now it will be primarily the first line technique, FNB, for all solid lesions. It's still not there, but I think it's going to come very soon on record as the one which is going to provide us the right tissue.
Okay, thanks, Dr. Ajay. Mike, what do you think? Is FNA needles now should be put laid to rest, and it's all FNB all around? No role for FNA?
Well, clearly for cystic lesions, there's no advantage of the FNB needles, and they're about 1/3 the price of an FNB needle. So for cystic lesions, we're still using traditional FNA needles. For routine lymph node biopsy, we also still use FNA needles, unless we're concerned about lymphoma,
That's right.
where histology is particularly valuable. But if I'm just trying to determine if a node is a metastases from a pancreas cancer, a traditional FNA needle is sufficient.
Yeah, I agree. I think the cystic lesions and lymphadenopathy, other than lymphoma, FNA needles still may be used considering the cost factor, but other places, FNB needle is probably is better than FNA needles. Next is Dr. Sanjay Gupta is there. Yeah, he's there. So Dr. Mike talked about image enhancing techniques like contrast, EUS, and EUS elastography. But considering the fact that majority of times we'll have to acquire the tissue, do you really think that these techniques are of any clinical utility? They are not just fancies, they really help. What do you think is your experience or your recommendation based on practice in India?
Actually, I am not doing this elastography and contrast EUS in routine. But I feel that these have a role definitely if the lesions are small, particularly between 1 and 2 centimeters. So if the lesions are small, the needle need to be, the directed biopsy need to be taken, and I think that is one of the best. Specifically, if we have got a failed FNB earlier, then also it is wise to take this one. But because of the logistics, the cost involved, additional cost involved in the procedure, this cannot be. First of all, this cannot be practiced as a sole procedure, and subsequently, and the other thing is biopsy is still needed, and these procedures still not been, they've been not been quantified to be the sole diagnostic modality without a biopsy. So therefore, they should be restricted and should be used only when they are required in our setting. But yeah, now the cost of the contrast is actually coming down, so we can use it more frequently.
Right. Thank you, Dr. Sanjay. Mike, what do you think? Is it just colors and fancies? Do they really add on to the clinical utility? Because, as you have rightly said, doing an elastography and contrast doesn't need any special training. It just softwares are needed. But do you think that the cost is worthwhile, subjecting the patient to these investigations in routine clinical practice?
Yeah, I would classify these as emerging technologies. They're not yet really established. I think the potential areas where they're useful and where I use them in these screening patients that we don't know that they have a tumor, often there's some subtle findings of chronic pancreatitis, even a small lobule. You'll see a 5 or 6 millimeter lobule, and I'm unsure if it's a lobule in chronic pancreatitis or is this a 5 millimeter tumor. Those are the cases I've been using, particularly elastography. Also, sometimes there's a small nodule within a cyst, and I'm not sure if it's a globule of mucus or is it a true mural nodule. And in those cases, seeing that there is flow with contrast material can distinguish between a mural nodule and a mucin globule. So those are very niche applications, but at least for me, some useful areas for these technologies.
Yeah, and maybe to add on to, sometimes in gallbladder you find some small polyps, or whether it's a sludge ball, there also probably the contrast may help you in differentiating between the two. But I agree with you that these are emerging technologies, and we still need to do a lot more before they can be firmly established in clinical practice. Dr. Ashish, you heard Michael Wallace talking about a lot of advantages of EUS guided liver biopsy, that in one go you can do so many things, but we still don't find that EUS liver biopsy is doing so well in clinical practice in India. What do you think is the reason? One obviously is the cost of the needle, and very limited people do the procedures. But do you see any significant hindrances in bringing EUS liver biopsy into routine hepatology practice?
Thank you, Professor Arora and Professor Rana. Definitely EUS guided liver biopsy, we have certain advantages over that conventional liver biopsy technique, like its diagnostic yield is comparable, even superior, and we can biopsy focal lesion in a better way because of better quality of image. Patient comfort is better, recovery time is shorter. So overall, conceptually, it's a better option than previous techniques available. Real problem is cost. We are working in a government setup, so if we compare that percutaneous versus US guided liver biopsy, so it's somewhere between 10,000 in percutaneous approach versus 20,000 in US guided approach. 20,000, why I'm saying, because we are using it as a patient we are doing in a conscious sedation, not doing in a general anesthesia, and we are reusing the needle biopsy, FNB needle, we are reusing it, FNB needle. If we are, and along with that, we always plan to do screening endoscopy at the same go. So if we have planned for the screening endoscopy in the same go, and in that case, it can be comparable cost effective, comparable cost. And a study have shown if we add this endoscopy, another endoscopy procedure along with the US guided liver biopsy, then cost is relatively comparable. And in our setting, still there is a gap between the percutaneous liver biopsy cost and US guided liver biopsy. But cost can be reduced if we use the conscious sedation and if we reuse the needle, which is actually usually do in our country, unlike the West.
Thank you. Mike, what do you think is the reason that US guided liver biopsy, even at the best centers in the world, is not being commonly performed? It is still, if you look at the papers, last 2 years, only the number of papers have gone up, but still it is not being seen as a frontline modality for obtaining liver tissue in hepatology practice.
Yeah, I agree with Professor Jha's comments that if your only purpose is to perform a liver biopsy, a percutaneous is a less costly, less invasive way to go. However, the way we see this is a typical liver patient is going to radiology to get an ultrasound in the elastography, and in some cases a biopsy. They're going, in some cases, to interventional radiology to get a hepatic vein pressure. And then they're coming to endoscopy to get a variceal assessment to see if they have large esophageal or gastric varices. The major cost advantage here and efficiency advantage is we can do all three of those things in a single conscious sedation procedure. So the patient really can get a comprehensive evaluation of their liver in a reasonably cost-effective way. We do need more evidence that this is truly cost-effective, but I think this is likely the pathway that we will go forward. We've just started in our liver program to offer this service of a single upper endoscopy EOS biopsy, and if needed, in fact, a patient who doesn't have large varices, we will do a portal pressure measurement to see if they're at risk for developing large varices.
Yeah, that's right. And in your practice, do you use a 19 gauge or a 22 gauge third generation FNB needle for liver biopsy?
We use either a 19 or a 22. I think the 25 gauge needles are a little bit too small to get a good specimen. I do prefer the 19 gauge. There's some evidence that it gives a superior specimen, but this is not completely resolved yet. And
do you sample both the lobes or one lobe?
Yeah, we sample both the lobes, so there is good evidence that there is better yield for fibrosis and inflammatory markers if you sample both the right and left. So we do the left from the just below the GE junction, and we do the right from the duodenal bulb.
Thanks, Mike. We have Dr. Pradeep with us. Just one question. I was just wondering, artificial intelligence is making such big headings in all the field of endoscopy. We were listening to the previous lectures where they were talking about polyp classification, NBI magnification, and how AI is making a big difference there. Do you think AI is going to make any difference in EUS?
Well, sir, thank you for having me, sir, into the discussion. Good evening to you all, and good morning, Dr. Michael. Sir, I mean, whenever a marriage is there, I would like to put in that manner, the offspring usually come out a bit late. And, as the children grow up, they go into different fields. Same is the word with artificial intelligence. The subset is basically, machine learning. And the another subset of this is basically the amount of deep learning which you can have it. Artificial intelligence cannot replace a human brain because it has been again made by the humans only. So we definitely learn, keep on learning new things. It will definitely help as a synergistic application, in aiding you whenever you are confused somewhere. Like, if the duct is not clear, the intramural nodules are not very much clear. If you have got a cystic and a solid lesion, together where you are not able to find out what exactly it could be, that will aid you side by side, but it can never, ever, replace a human brain. So it is our brains, which have definitely done it. Now I've been doing, these cases for last around 5 years, after learning for 5 years continuously. So we realize that every day is a day of learning. So we need to, artificial intelligence is definitely good, but it cannot replace. Like, FNA needle cannot be replaced because just for cystic lesions. FNB definitely gives you a good yield of biopsy.
Thanks, Dr. Pradeep. Mike, what do you think? There were a few papers, I think, in last 6 months where AI was used for differentiating between GIST and leiomyoma, and then EUS AI for focal hepatic masses. So do you think AI and EUS is future?
Yeah, I have no doubt this will be the case. We've seen the AI companies first went for what we call the low-hanging fruit. The low-hanging fruit are colon polyps because this is such a large market. However, the fruit that is going to come next, I think, are all the other imaging fields, including endoscopic ultrasound, even ERCP, pancreatoscopy, cholangioscopy, and certainly all of the radiologic fields are moving quickly towards AI enhancement. We're already seeing, as you mentioned, US AI assistance in GIS. We actually have 2 papers that are going to be accepted soon in GIE related to liver lesions and pancreas lesions. So we're already seeing this coming. Any image that can be classified by a human, we can use AI to assist that. The most likely targets are going to be the things that are difficult right now, distinguishing low risk from high risk mucinous lesions, distinguishing chronic pancreatitis in its early forms, and even liver lesions that are sometimes difficult to classify.
Thanks, Mike. I think we are just finishing time. I just have one question from the audience. One has asked that, do you do a EUS guided liver biopsy in moderate to severe ascites?
In moderate to severe ascites, by definition, this patient has cirrhosis and significant portal hypertension. So it often is not necessary unless you're trying to understand the cause of the cirrhosis. We already know that they have cirrhosis. It is feasible to do it in ascites because often the ascites, there's minimal ascites in the gastrohepatic ligament area. So you have maybe even a better window for biopsy than a percutaneous, but only in the setting where you need a diagnosis of the type of liver disease. Is it PBC or PSC or alcohol or fatty? Because we already know they have cirrhosis.
So in that situation, would you prefer a transjugular or an EUS liver biopsy if you have a, say, severe ascites?
I think right now the standard of care probably is transjugular, but we are seeing this emerging role of EUS, and I think it'll likely continue to emerge as a significant role.
Right. Thank you so much, Professor Michael Wallace, for an excellent presentation and participating in this discussion. And I thank my co-panelists, Dr. Ajay Bhalla, Dr. Ashish Jha, Dr. Sanjay Gupta, and Dr. Pradeep Agarwal for participation in this panel discussion. Thank you so much. And I hand over back to Professor Anil Arora.
Thank you.
Dr. Arora, you have to unmute it, Dr.
Thank you, Dr. Surinder. I am grateful and thankful to Professor Michael Wallace and all the expert panel members for having taken us through this journey of diagnostic endosonography. The live-in relationship which started between the endoscope and ultrasound about 30 years ago has blossomed into an excellent, well-settled marriage. Now, believing that gastroenterology can be practiced without EUS is making a fool of yourself. And I'm really impressed with the way Professor Michael Wallace has given us that in a patient in hepatology practice, if you just have one tool, it has to be EUS, because in one tool, you can make a diagnosis of fibrosis in the liver, you can look at the varices, you can look at the portal pressure, and who knows in future, you may be able to do a TIPS using an EUS guided procedure. With that, I thank all the panel members and the moderator and speaker for the excellent presentation. With that, we move on to the fourth session of the day. That is the therapeutic uses of endoscopic ultrasonography. We know once the ducks have given birth to ducklings, ducklings have something to do. They'll start fishing for their food, they'll keep roaming around, and for their own survival, they will look for something which is different from their mother who has given the birth. So once Dr. Vipul Rai Rathore has established the basics, nuances of endoscopic ultrasonography, We have the birth of Dr. Vinay Dheer, who have crossed all the boundaries and taken us to a greater heights of intervening into the hepatobiliary region, not for diagnosis, but being a competitive person for the surgeon. So with that, I'll hand over the proceedings to Dr. Vipul Rai Rathore, please.
Thank you very much, Anil. And it was a great honor and pleasure to see a wonderful conference going on and great proceedings. Thank you very much. As you have mentioned well, that the natural progression of endoscopic ultrasound was intervention and therapeutic. And when we talked about intervention, we talked about initially tissue acquisition, and that's where we started our journey. And we now are in the era of serious therapeutic EUS. So today we have none other than my friend and colleague from Mumbai, Dr. Vinay Dheer. For his introduction, I would like to say he's one of the prominent leaders in India and across the world in endosonography, and he is currently the director of the IDL, that is the Institute of Digestive and Liver Sciences at SN Raheja Hospital in Mumbai. So Vinay will be taking us through the journey of therapeutic interventions and the newer horizons. To join us on the panel, we have Dr. B.K. Agarwal from Patna, a senior gastroenterologist. We also have Dr. Sandeep Sidhu, who is a professor and head of the Department of Gastroenterology and Liver Transplants at Dayanand Medical College and Hospital in Ludhiana. We have Dr. Bharat Bhushan Gupta, a dear friend and a senior gastroenterologist from Jammu. We also have Dr. Sharad Chandra, who was at PGI Chandigarh and now has located himself in a place called Jhansi. And we have Dr. Satyarth Chaudhary, who is also a leading gastroenterologist, young, dynamic gastroenterologist who have learned the ropes of EUS and has been actively performing interventional procedures. He is well trained in all aspects at PGI and other institutes. So I welcome all my panelists on board today, and I would invite Dr. Vinay Dheer to start his proceedings, as we are already about 20 minutes behind the schedule. So please, Vinay, can I have you, Vinay, on board?
Yeah, Vipul, can I again request you at the cost of repetition to just stick to the time?
Yeah.
Thank you, Vipul, for that kind introduction. Thank you, Anil, Dr. Anil Arora, for giving me the opportunity to be with you all this evening. This has been a fantastic conference, a really high value, high educational output conference. And congratulations for the great success, not only this weekend, but the previous weekend also. So my job is to talk about therapeutic EUS, and if I may share my screen. Can you see my screen now?
Yes. Yeah, we can see.
Okay. So therapeutic EUS, as you all know, is going on slowly from last 2 decades, but has picked up speed really in this decade. And this decade can be called as a golden era for therapeutic EUS. Not only because we have got lots of new tools to work with in therapeutic EUS, but also there have been some excellent publications in the field. So with this wonderful mix of therapeutic endoscopy and interventional radiology techniques, therapeutic EUS has really taken strides and has established a niche for itself in all advanced pancreatobiliary units across the world. It has really changed the way we manage certain disorders, and that is what is the scope of my talk today. We will discuss areas where therapeutic ES has already caused a fundamental shift in our approach to management in the past few years, and we will review a few important publications in this regard. So this was a review we published almost 6-7 years back, and these are the indications, potential indications for interventional EUS. Indications remain more or less the same over the past decade or so. ductal drainage, bile duct and pancreatic duct, drainage of fluid collections, pancreatic fluid collections, perirectal collections, liver abscesses, cancer-directed therapy like alcohol ablation, radiofrequency ablation, brachytherapy, and then of course, celiac plexus neurolysis, coil injection for gastric varices. Mike just now discussed about gastric varices. It's a very important area which I will not discuss for shortage of time. What is the evidence that we have accumulated for all these indications? For PFC drainage, we have a level 1 evidence now. For biliary drainage, we have a level 1 evidence. For celiac neurolysis, yes, we have level 1. But for others like pancreatic duct drainage, RFA, coil and glue, perirectal abscess drainage, probably we need more evidence before we can confidently say that there is a paradigm shift in the management because of EUS guided therapies. So apart from the techniques which have evolved, the technology has been a major boost to us. The companies have been making all kinds of new stents to help us give better patient cares and better outcomes. And this has been a real change in the last decade. So not only is the technique evolving, the technology also is evolving in parallel. And I think that makes the procedure very exciting, and the outcomes are improving. And of course, the most important things that has happened in the last 7-8 years is the development of what we call as lumen opposing metal stents or biflanged metal stents. These are small dumbbell shaped stents with wide flanges, and these have really changed how we look at various things like collections or even crossing boundaries from the stomach to the jejunum, bile duct. So things have really evolved because of the availability of these technologies. Let us discuss a few areas in this. So before EUS-BD came on the horizon, EUS-guided biliary drainage, a patient who failed ERCP would go for PTBD. That was the standard situation. But that paradigm has shifted. At expert centers, if you fail in ERCP, now you just change your scope and you do attempt an EUS-BD first. And we are very confident in doing this because a good literature has appeared in the past 5 years. We have a level 1 evidence regarding efficacy and safety, and comparative studies of EUS-BD, not only with PTBD, but also with ERCP. So a quick video for you. You all know, so this is dilated biliary radical. We evaluate, this is the segment 3. We go in, see, you find a good radical, and then after doing the Doppler, you puncture. This is a good scope position, check the scope position. Then once you puncture, you see, aspirate that you are in the bile duct. Once you have aspirated, then inject contrast to know where you are. And then you pass a thin guide wire, a Terimo or a VisiGlide. So you see that this is how the duct is going. So it's a subhilar stricture, and we are trying to pass the wire. And once you are able to pass the wire, pass a cystotome across. So after we coil the wire here, we pass a cystotome. And once the cystotome is in place, we can then direct the wire across the stenosis. So the wire goes across the stenosis into D2, and then the cystotome follows, and we change the wire. So these are all things we have learned from our radiologist colleagues. They do exactly the same thing. They have been doing it for decades. Now we are doing it with an endoscope. So learning from our colleagues in radiology. So this is a Soindra dilator, a 10 French Soindra dilator going through the stricture. Stricture is very tight. Once we have dilated, then it is easy to place a stent which we use for ERCP, an uncovered expandable metal stent. So using both endoscopy as well as interventional radiology techniques to help the patient and place an expandable stent. So this is called as antegrade procedure. There are many other procedures within EUSBD, about 17 or 18. I will not go into the details of all, but suffice to say that we have now a good technique available to us, not one, several techniques. So we were shown by this meta-analysis from the New York group, Sharaya, 9 studies with 483 patients. And while the success rate of EUSBD and PTBD remains the same, EUSBD has fewer adverse events and lower rates of reintervention. Not only this, there were 2 randomized trials which showed the same thing, that there is similar success but higher rates of reintervention and adverse events with PTBD. So wherever you have expertise available, shift from PTBD to EUSBD in patients with failed ERCP. Patients who have duodenal stenosis or post-surgical anatomy fall in the same category. You should use EUSBD before you refer your patient for a PTBD. In 2015, we published this first study which compared EUSBD and ERCP for distal malignant obstruction, and we showed that there was no difference between the efficacy and adverse events of the 2 procedures. Following that, initially it was a very, I got a lot of letters on this, but later on you see in 2018, 3 randomized controlled trials have come, which have shown us that the success rate of EUSBD and ERCP for distal malignant obstruction is comparable. There is no difference in the adverse events, except in the Korean study, where paradoxically ERCP has a higher adverse event rate. We believe that ERCP and EUSBD are comparable. I would not say EUSBD is superior, but they are comparable for distal malignant block. And as of today, we use ERCP as the standard approach, and we use EUSBD after ERCP failure. EUSBD only becomes the first line in patients with post-surgical anatomy or where there is a significant duodenal stenosis. So this is a paradigm shift that Therapeuitc EUS has brought in the field of biliary drainage. Let's come to pancreatic fluid collection drainage, and we already know from papers published by Sham in 2007 that EUS guided approach is superior to a plain endoscopic approach. With the availability of lumen opposing metal stents and biflange metal stents, we also have got good evidence that these stents allow for necrosectomy of Vaughan. And although it remains controversial, by and large, it is accepted then that when you need necrosectomy, you should plan for a lumen opposing metal stent or a biflanged metal stent. And the paradigm that has changed is that before all these stents were available, what we would do is place 1 or 2 plastic stents, and they would be there in the body for 3 months, 4 months, 6 months, or maybe longer, because there was a paper randomized study from the Belgium group in 2007 by Arivantikis, which showed that if you remove the stents early, there is likely to be a very high incidence of recurrence because of disconnected pancreatic duct syndrome. That paradigm seems to be changing. A quick video if we can. So this is a nice homogeneous collection. You evaluate, look for the vessels, see the distance from the stomach wall, measure the cyst, and then use a 19 gauge needle. I'll go through fast. Pass the needle, pass a thick wire, 035 wire, and then dilate with a cystotome and a 6 mm balloon if needed, and then place a stent. Straightforward technique, should not take much time, and the outcome is pretty good. The procedure is pretty fast, and this is a real change for those of us who have been living with the other methods. We have done the endoscopic method. This is pretty easy and more effective in drainage. So this last year, there was a randomized study published by Shyam Varadarajulu in gastroenterology, which compared, a very important study, compared EUS guided drainage versus minimally invasive or laparoscopic PFC drainage, and they showed that the adverse events were significantly higher in the surgery group. And the length of stay and length of ICU stay was also significantly longer in the minimally invasive group. So this shows us that EUS guided approach should be the procedure of choice for pancreatic fluid collections requiring drainage. So this has been a landmark, very, very important paper. Before this, we were the first to show, this was an article published in GIE, that it is not necessary to leave the stents for 3 or 4 or 5 months. In fact, you should remove these stents early. So this was our first study which showed that you should remove these biflanged or lumen expanding stents at 3 to 6 weeks of time. And this has become a standard approach. So that was a paradigm shift. We don't keep the stents for very long inside. Then we did a prospective study. This was published in Endoscopy. We wanted to see the impact of disconnected pancreatic duct syndrome on the recurrences, 88 patients, and we showed, in contrast to the other studies published before, that the prevalence of disconnected pancreatic duct is very, very high. It's not low. So probably before this, what was being done is that we were picking very few disconnected pancreatic ducts. In this study, we did MRCPs and ERCP in all patients. And we found that disconnected pancreatic duct is much more common than what has been suggested. But a pancreatic duct stent placement does not help, and recurrences are not very high in these DPDS syndrome. We classified them into 4 types, and we also discussed that it is probably not reasonable to expect that a permanent indwelling plastic stent placement would help in any of these situations except probably the type 3. It will not help in the other 3 situations. A month back, a large study from Asian Institute of Gastroenterology, AIG, Basha et al., published in Gut, has confirmed what we had said in 2018. This is a much bigger study, 2,074 patients. You see, 73% of their patients had disconnected duct, while we had 61%. You see the recurrence. So you would expect that 74% of these patients would have recurrence because they have disconnected duct. But the frequency of recurrence is only 13.2%. Of course, it was significantly higher in disconnected pancreatic duct. But the thinking based on these two studies is that not all patients with disconnected pancreatic duct need a permanently indwelling plastic stent within the pancreatic fluid collection. Now that is likely to be a paradigm shift. Again, we are changing the way we have been thinking. Quick things on gallbladder drainage. It's not very commonly done in India because our surgeons are very aggressive, but the procedures are the same. You use an Axia stent, don't use a Nagi here, and it's a straightforward 5-minute procedure. We do it from the duodenum, not from the stomach. And we have enough studies to say that EUS guided gallbladder drainage has good outcome and is superior to percutaneous gallbladder drainage, which many of our surgeon colleagues follow if they cannot operate patients with acute cholecystitis. So this is another change that is being brought. We are replacing percutaneous drainage with EUS guided drainage in the field of gallbladder in patients with acute cholecystitis. I'm going a little fast because I think I have to cover one more area that is a very exciting area of EUS guided gastrojejunostomy or gastroenterostomy. We published this study in Gut of 20 patients, showed very, very good results. And after that, so there are multiple ways of doing EUS guided gastroenterostomy. I'm just showing you a freehand technique. So you see here, there is a stenosis here. You pass a catheter with a wire, pass the wire deep beyond the DJ flexure, then remove the catheter, place a 7 French nasobiliary drain, And with that drain, you pass a liter, 500 cc's to a liter of water with methylene blue, so that you can see which of the loops is closest to the stomach. So see here, now you are seeing a loop here, nicely, very close. And after that, you use your axios to do a free puncture. See here, this is a free puncture, and deploy the stent. Not very difficult. I will not say it's a very easy technique, but not very difficult. What we have been doing is we have been using the e-pass tube, which was developed by Professor Itoi, to improve the safety profile of our patients. But this freehand technique also is quite good. So this is a new development. You are making an anastomosis between two different areas of the gastrointestinal tract, between a stomach and a jejunum, or a stomach and a distal duodenum. Very exciting prospect. Small number of studies available. You have patients 10, 20, 30, but you see there is a 74 patient study in 2018. Very high success rate, technical success rate and clinical success rate. There are adverse events, about 10%, 10 to 12% of patients. Most commonly is if there is a perforation, and the patient may require surgery in rare cases. But this procedure is getting established at high output centers, and I believe that we will get studies in the coming few years, and we will be able to offer a very good alternative to a surgical gastroenterostomy. This is fast, this is efficient, and the patient gets discharged the very next day. So a lot of advantages of EOS guided gastroenterostomy. I'm not touching a lot of other areas. Maybe you guys, we can discuss it during the discussion. Portal vein, gastric varices, embolization coil, and other things. RFA is another exciting area. Maybe we can leave it for the discussion. So thank you very much, Vipul. You can take over from here.
Yes, thank you very much, Vinay, for an excellent overview of some of the established techniques of interventional EUS. I would like to invite my panelists, and I don't see any of them. Are we? Oh, Dr. Chaudhary is there. I'm happy to see you, Dr. Chaudhary. And we have with us Dr. Bharat Bhushan as well. And we have, I don't see, is Dr. Sudeep there? And I don't see any. So anyway, we'll start with Dr. Bharat Bhushan first. Dr. Bharat Bhushan, if I have to ask you a question on a pancreatic fluid collection, you practice in Jammu. So how often you feel that this is the modality now completely replacing the conventional laparoscopy or surgical intervention or plain endoscopy intervention compared to what you used to practice in the past? So is it a routine procedure now because level 1 evidence is out? What is your take on that?
Dr. Vipul, thank you very much for asking me the question. The problem at Jammu is that we do not have an endosono and we do not have a therapeutic endosono man here. Yeah. So that's a problem. But otherwise, endoscopic drainage we were attempting. And as you know, as has been told by Professor Dheer also, EUS guided approach is superior to endoscopy report. And in endoscopy approach, we had few patients, but then the success rate was very low, and then the infection rate was very high. But somehow, maybe people are not investing, our younger generation is settling in metropolis. So we have a problem that we do not have a therapeutic EUS here.
So this is a genuine challenge, Vinay, as we can see here, that vast majority of even big cities in India are still not having interventional EUS facility. And this, we need to keep this in mind. And I think this only tells us that we need more centers in India. Coming to Dr. B.K. Agrawal, I'm sure at Patna, Dr. Agrawal, you also deal with patients with all these pancreatic fluid collections. So what is your approach in terms of treating them? How would you select a patient for this is for the interest of our upcoming gastroenterologists and trainees and endosonographers who have just started. So what would be your approach? How would you decide this patient needs treatment or this patient can be observed? So what is your protocol on that?
Thank you, Vipul. Actually, earlier we have been doing with the endoscopy and showing the large bulge in duodenum or stomach. And on ultrasonography, we can make out whether there is enough space in between the gut loop and the pancreatic cyst collection, the pancreatic fluid collection. Then we could go ahead without endosono. But with the availability of endosonogram, I think things have become very easy. And now the chances of entering any blood vessel is very minimized, and we can know very clearly that how much is distance between the fluid collection and the lumen of stomach or duodenum. I think with this approach of endosono, I think the things have become very easy, and we can put a stent also very easily. Thank you.
So you would say as a senior gastroenterologist that a conventional endoscopic approach should be avoided if there is an endoscopic ultrasound equipment available in your town or city or some center.
Definitely.
Yeah, so I think this is very important because I have had a few suggestions in the past where people have said that we can still do with a bulge and we can do the needful. So coming to Dr. Satyarth Chaudhary. Dr. Satyarth Chaudhary, welcome. I'm sure Vinay has gone through some interesting details on EUS guided interventions in the biliary tract. What are your preferred approaches and why? So if you talk of a technique of EUS biliary drainage, Vinay mentioned about rendezvous, mentioned about antegrade stenting, about choledochoduodenostom and so many other. What is your preferred technique of EUS BD and why? I can't hear you. You have to unmute. You have to unmute your mic, yeah. I still cannot hear you. Can somebody unmute Dr. Chaudhary? Yeah.
Pranav?
Yeah, you can. I can hear you now. Yeah. Can you hear?
No, it was me.
Oh, I'm sorry, Anil. Yeah.
Dr. Satyarth, can you hear us?
Sir, can you please hear me?
Sir, now he's okay. He can speak now.
Now we can hear you. Yes, we can hear you. Yeah.
No, again, your voice has gone. Can you not use headphones?
Remove your headphone from the laptop and
yeah, you can directly speak into the mic of the laptop.
Okay, sir. Can you now please hear me?
Yeah,
audible, sir.
We can hear.
Yeah. So the most preferred approach where I use the cases where the ERCP is unsuccessful, then I go ahead with the Hepato-Biliary approach.
Okay.
That is the most preferred for me. And apart from that, the duodenum is also a site which is most preferred and easily accessible. But I have noticed that most of our cases, the duodenum is also involved and aegis is the favorable approach.
Vinay, can you comment on this? What is your preferred approach of EUS BD given a choice?
Yeah. So what we believe, and this is because probably I am a little old from the older generation, that transpapillary drainage is still better than transluminal drainage, although there is no evidence to show that transluminal drainage is in any way inferior. So I would give my first option to either a rendezvous if the duodenum is accessible, or to an antegrade procedure, because in both these cases, in both these procedures, the stent comes out through the papilla. However, if that is not possible, then I will go to hepaticogastrostomy or choledochoduodenostomy, depending on what level of block it is. If it is distal block, I will go for choledochoduodenostomy. If it's a little proximal block, I go for hepaticogastrostomy.
Right. So coming to Dr. Sharad Chandra, one of our panelists, I would like to ask you, Dr. Sharad, that if you have a patient who has a very proliferative tumor in the ampullary area, but it is periampullary lesion, but you can access the ampulla, would you prefer an endoscopic transpapillary stent, metal stent, or you would prefer a USBD?
Yeah, actually, in this situation, if we do a USBD, corticoduodenostomy, we are not traversing the tumor.
Yes.
What has been shown that the survival rate, instead the patency of the stent is longer if we go transmural. If we go through the papilla, the chances of tumor ingrowing into the stent and blocking the stent are higher. So I think in this situation, I would go for a transmural drainage corticoduodenostomy.
Okay. Do you feel that for all lower CBD blocks and proliferative tumors, EUSBD may become a norm than some cases? What is your opinion on that?
Actually, the number of procedures which is being done, except in high volume centers, are not much. So at present day, I think I would still go with transpapillary stenting. But over maybe in a few years, once the expertise and the number of procedures which I do increases, then I definitely would go for the other option.
Okay. I think you answered your question fairly well. I would ask Vinay one more time. I will keep going back and forth with Vinay. So Vinay, tell me, what is the learning curve for EUSBD drainage to secure a complication rate comparable to ERCP?
That's a very, very good question, Vipul. We assume that people who venture into EUSBD are already good at ERCP, are having a success rate of 90% and above. So we are assuming that the basic skills of endoscopy ERCP are there already. And with that, there are studies which have shown that about 40 procedures, 40 EUSBD procedures are what you need to bring down your complication rates to acceptable, that is single digit levels. But now when you say 40, there are different EUSBD procedures and each of them have a different technique. Choledochordiostomy is different, hepaticogastrostomy is different, rendezvous is very different. So I would say probably 40 is when you start feeling confident about your scope position and that you will manage. But to be very, very good, I think you would go to around 80 to 100. Then you are good.
So if you want to do 40 to 100 EUSBD, how much time a trainee needs to spend in a unit and in a busy unit?
Oh, that is very, very difficult. So
we are touching some of the nerves.
Yes,
there are challenges, and it's very exciting and very, very glamorous. We all know that. Coming to Dr. Sharad again, Dr. Sharad, we heard very eloquently from Dr. Vinay about gallbladder drainage. Do you have any experience in your practice of gallbladder drainage? And which are those conditions where you feel it has salvaged the situation?
Actually, gallbladder drainage is indicated acute cholecystitis in patients who are very poor surgical candidates, either as a bridge to therapy or as a destination therapy, where the life expectancy is not much and the patient cannot undergo definitive surgery. So usually in our practice, actually, if we convey them that it is a bridge therapy, usually the patient don't accept it as the drainage procedure. Whereas those who are frail and unlikely to undergo surgery, they definitely, yes, they do agree for this procedure. Besides this, other indication is anybody already having a percutaneous cholecystostomy, we can internalize it with the gallbladder drainage. And as an alternative to EUS-biliary drainage, if you cannot do a CDS or a HJS, this is an alternative modality for drainage.
Right.
We do gallbladder drainage.
Right. Well, as Vinay mentioned very early in his talk in gallbladder drainage, with improved anesthesia and perioperative care, and we all know in leading hospitals and even in smaller towns with good ICU backup, the indications for gallbladder drainage, I think our surgeons are still holding on to laparoscopic cholecystectomy or percutaneous drainage. So these are some of the areas where we have, as gastroenterologists, endoscopists, have challenges to convince our colleagues. And I'm sure this is across the board of all our panelists today. Coming to a question, is Dr. Sidhu online? Is Dr. Sidhu? Can Dr. Sidhu come in?
I don't think he has joined.
He has not joined.
Not joined yet. He has not joined yet.
He has not joined. So I will go back to Dr. Satyar Chaudhary regarding a question on gastrojejunostomy. So Dr. Satyarth, how easy or how difficult you feel is gastrojejunostomy EUS guided? For our young participants today, I want you to share your experience from your perspective.
Again, there is a problem with your voice, Satya.
Please remove that. Please remove your wire.
Can you please hear me?
Yeah.
We can hear you.
So I have a brief experience of 4 to 5 cases of gastrojejunostomy done, and it is an excellent technique, but there are certain points which need to be remembered by the initiators. For example, if a person who is doing the US guided GJ, that he has a very good experience on the biliary drainage first, rather than directly jumping to the GJ, which is itself a difficult procedure in terms of the placement of stent, how to release the stent successfully. I feel that is a crux. And secondly, to know the indications, because the recent articles, if you go through them, to me, practically, these are the malignant biliopancreatic obstructions which are causing the gastric outlet obstruction. So there it is actually required, because such patients with high comorbidities, they cannot be the good candidates for surgery. So I feel it is exciting and it is going to develop in such particular subgroup of patients.
I think I'll go back to Vinay on this. Vinay, would you suggest a needle-guided approach to placing a gastrojejunostomy stent, or you go direct with hot axios? What is your preference and why?
So we are using a hot axios directly, because initially we tried with a needle approach and we thought that it actually hampers the placement of a stent properly. So we have given that up. We don't keep, because if you place a wire, you feel safer, of course. But then the jejunum is a very mobile organ, and with the wire, the jejunum tends to go away. So we have, over the last 15 cases, I have done a hot technique directly without a wire.
And when would you not do a EUS GJ?
One case we had to give up because there were obstructions beyond. So some of these patients have carcinomatosis, peritoneal carcinomatosis. So if there are multiple levels of block, your CT should be able to tell you. So actually one patient I took on the table, passed the thing across and then injected, and I saw there was another block immediately beyond. So we came back. So that is definitely one thing where you should ask your surgical colleagues to find if they are able to do a better job than us. Other than that, you need some, at least a 5 French space to pass your catheter or to pass anything. If it is a complete block and you're not, which is a very rare situation again, probably that will be one area where we will find it difficult to place an EUS GJ.
So we all know that with this kind of obstruction, patients have massive ascites. Is ascites a hampering factor for EUS GJ?
No, you can drain the ascites and then do the GJ. No problems with that.
Fine. So coming back to Dr. Sharad, we will now go to another area where probably on infected WOPN, we talked about EUS guided drainage or pancreatic fluid collections, and I'll come back to that in specific of EUS guided treatment of infected WOPN. What is your protocol in your unit? Dr. Sharad, are you there?
Sorry. Yeah. Not all WOPN needs drainage. First of all, one needs to be sure that there is a definitive indication for drainage, which is if there is infected collection or there is a refractory abdominal pain, biliary or gastric outlet obstruction, or there is failure to thrive. So once we have definitely established that this patient needs drainage, then we need to decide, we need to evaluate what is the assessment of the percentage of the necrosis inside the cavity.
Right.
That will decide whether we can manage with plastic stents or we need to use large caliber metal stents. This is a very important that indication and what type of stents. Normally, if there is significant necrosis, we always use self-expandable, that we use a large caliber metal stent, either Nagi stent or Axios, the other option which is available. But if the necrosis is small, we can go ahead and use plastic stents. Although studies have shown that both plastic stents and metal stents, both of them lead to resolution of the WOPN. But still, most of the endoscopists, we prefer to use large caliber stents with the content of necrosis is high, because it helps us in doing intervention, necrosectomy if required, and there's early resolution of the cavity, and the procedure time is short.
Have you ever encountered bleeding doing EUS guided necrosectomy or EUS guided puncture?
Yeah, actually bleeding is
Doppler.
Yeah, actually bleeding is a complication which can occur anytime. Although we always get a CT angio before the procedure, and we look into the cyst cap, the WOPN nicely with a Doppler evaluation, but still we can have small vessels which we can miss. So everybody encounter bleeding during the procedure, but usually what I have encountered is it was a minor bleed, and we kept on doing the procedure, and it stopped. With metal stent, usually there's no problem, because with the size of the stent, it presses on the adjacent vessel if it's at the entry point. Right. Whereas if you use plastic stent, then we use balloons for tamponade effect, and subsequently we continue the procedure if the bleeding is not much.
Dr. Vipul, sorry to interrupt. We are running short of time, so can you
just give me 2 minutes now? Okay. I will conclude. One last question to Vinay. Vinay, what is your wish list for a therapeutic EUS indication getting established with 1A evidence, level 1A evidence in the next 2 years?
So I as I discussed, my top indications, and EUS GJ is something which I believe is very, very important, and EUS gallbladder drainage. We have good evidence for gallbladder drainage, so it should definitely replace percutaneous interventions. But EUS GJ also, with my personal experience and the experience which has been published, I believe it's a very, very good procedure and should replace surgical or laparoscopic GJ. And these are all major indications, because this will really help lots of patients who are undergoing gallbladder surgeries or GJs for various reasons. So these are.
You still feel that the RFA and other ablative techniques and all these vascular interventions, apart from coils and for varices and all, are still investigative techniques in EUS?
Yes, they are exciting. They are very good techniques, but I am a man of evidence. So till we see a few good studies published, especially for example, gastric varices, I know in India, there is a lot of excitement about coil and glue for gastric varices, but we have a very good simple method of using a simple gastroscope and we have been using it for 20 years. So I need to see that this method is superior
than the conventional
gastroscopy. Then I will be very happy.
So I once again would like to thank you, Vinay, and all our panelists for joining us in this exciting therapeutic EUS. I'll just summarize in 2-3 sentences. I think therapeutic EUS is the way forward as far as EUS is concerned. We have exciting applications coming up. And the only problem, as I see, I'm sure all of expert panels panelists and our viewers will also agree, that we are still trying to do therapeutic EUS with endoscopy accessories and ERCP accessories. And this is a major hurdle. So we need a dedicated platform for only EUS guided intervention. And I think this is the need of the hour. If I have to expand more indications in therapeutic EUS section. Coming to the last point, I want youngsters especially, do not compromise learning ERCP skills at the cost of EUS, thinking that EUS BD is the future, because you need to master ERCP skills to continue your lot of biliary intervention as well as pancreatic interventions, and then supplement it with EUS guided intervention. I hope more and more level 1A evidences emerge in the next few years for upcoming applications and indications. With that, I hand over to Dr. Anil Arora. Thank you very much for giving this opportunity.
Thank you, Vipul. I am very thankful to Vinay and all the expert panel members for taking us through the journey of the recent concepts and the recent status of therapeutic endobiliary procedures. If I have to summarize the talk in one sentence, I think as Vinay very rightly put in, you have to be very good at ERCP, you have to be good at EUS before you venture into this field. Knowing very well that ERCP per se has a 5% chance of complication. So the incidence of complication is almost 3 times that of ERCP. So before venturing, please think and rethink. Unless you have a cool, mature head on a strong shoulder, like what Vinay has, please do not venture into it. I think it will take time before you become competent in it. With that, I am thankful to all the panel members, moderator, and the speaker for taking us through this journey.
Thank you.
Thank you.
Anil, thank you. Thanks a lot. Thank you, Vipul. Thanks, all friends.
With that, we move on to the 5th session of the day. Traditionally, during our anatomy training, we were told that there were only 2 spaces in the human body. The one was the luminal surface, which really excited us, and that is how we landed up in gastroenterology. There was a space of peritoneal cavity, pleural cavity, and the pericardial cavity, which was not accessible to the physicians, and most of us were not interested in doing the surgical procedures. But thanks to the recent concepts of getting a 3rd space, and we are lucky to have the innovator of the 3rd space yesterday with us, Professor Pankaj Pasricha, who gave a very elegant talk of the way he thinks about the innovations in the procedure. And to bring it from the bench to bedside, we had none other than Dr. Amit Medev. I still remember about 6-7 years ago during his ISG presentation, he made the first presentation of poem in ecclesia cardia, when most of us at that time had been doing a pneumatic dilatation. I still remember that he presented that 20% of these patients do have pleural effusion, maybe requiring chest drainage. So I thought, who will ever venture into this procedure? But I've been proven utterly wrong, and today 3rd space endoscopy is the need of the hour. To take us through this journey of 3rd space endoscopy, may I request the leading 3rd space endoscopist from Ahmedabad, Dr. Nile Sharma, to take the proceeding forward. Dr. Nile, please.
Yeah, thank you, Dr. Anil Arora. I do agree with you that initially we all were skeptical about 3rd space, but now it has become part of our advanced endoscopy. And I think it's the last decade has been very exciting, especially for us endoscopists, because of the 3rd space, US interventions, and also ESD. Without wasting much time, I will ask Dr. Maidev to tell us more about 3rd space endoscopy. I think everybody knows him. He's a great endoscopist, and I would say he's also a great teacher, because I've learned my advanced endoscopy under him. Dr. Maidev, please go ahead and deliver your talk.
Yeah, thank you, Nile. Can you hear me?
Yes.
Yeah, we can.
Okay. I would like to again thank Dr. Anil Arora and his whole team at SGRH for having this superb meeting spaced out over 2 weekends. And as was said earlier, most of all the lectures which have been presented and the discussions have been very lively and very enlightening. And so today the topic which has been given to me is 3rd space endoscopy, which again is very close to my heart. Because just before this, I finished a webinar on glue injection, cyanoacrylate glue injection in variceal bleeding. That was again very close to my heart. And to talk about 3rd space endoscopy, as was told to you by Dr. Anil Arora, all of us traditionally as endoscopists know about luminal endoscopy. That's what we have been taught. But according to me, 3rd space endoscopy is the new field which has taken all of us by storm. It has taken endoscopic surgery, therapeutic endoscopy by storm. And 1st space is luminal endoscopy. 2nd space, according to me, is endoscopy attached to the ducts of the lumen, that is bile duct and the pancreatic duct, that is cholangioscopy and pancreaticoscopy. And 3rd space is actually not a space, but it is a space which has been created by us, because it is a space which is within the layers of the gut wall, which is actually also called as submucosal endoscopy, or it is also called as intramural endoscopy. So if you look at this diagrammatic representation or cartoon, you can see this is where the 3rd space is located. You can see that this is the muscularis propria, this is the muscularis mucosa. So this space in between is the third space. Now, what is third space? Third space is nothing but submucosa. So submucosa is the third space. So what is there in the third space? So what is there in the submucosa? What is basically there is a loose areolar tissue, and then you have blood vessels. So where are these blood vessels coming from? Blood vessels are basically coming from outside. It's the esophagus. They are coming from the mediastinum. And these blood vessels are basically coming and supplying the blood to the mucosa. So they have to traverse the third space. They have to traverse the submucosal space. So when you are going in the third space, in the submucosa, you are going to encounter these blood vessels. In addition to that, all that is there is only loose areolar tissue. So you have to create the third space to be able to pass the endoscope inside. As was rightly said by Dr. Anil Arora, this person here, Dr. Jay Pashrija, was actually the first person to bring this idea to the forefront, because he did the first animal experiment you see here on the pigs. And along with him, you see here, before him, just 1 year before, this concept was sort of promoted by Chris Gostout from the Mayo Clinic. And both of them, they conducted some animal experiments on living porcine models. And it was Jay Pasricha who first showed that if we create a tunnel in the submucosal space of the esophagus, and we cut the muscle inside the esophagus, the muscularis propria, and then you come out and close the mucosal incision, then all these pigs survived. So that actually gave birth to the third space endoscopy. And today, if you go to see the current applications of third space endoscopy, some of them may not be very really applicable, but there are almost 8 applications of third space endoscopy. First is, of course, peroral endoscopic myotomy or POEM. And then we have got the gastric peroral myotomy, which is also called as GPOEM. Then we have got submucosal tunneling endoscopic resection of submucosal tumors, which is also called as STIR. Then we have got submucosal tunneling endoscopic submucosal dissection or ESD, which is done by using the tunneling approach, also called as STESD or pocket ESD. Then by utilizing the third space, we can also improve upon the results of septotomy in Zenker's as well as esophageal diverticuli, which is also called as DPOEM. Then we have got submucosal tunneling endoscopy myotomy plus fundoplication, which is called as POEM-F. And then we have got submucosal endoscopic myotomy and then removal of tumors beyond the lumen, that is beyond the esophagus or beyond the stomach, which is called as extraluminal tumor dissection, which is called as EXTER. And of course, another procedure which is used for treatment of Hirschsprung's disease, which is a per-rectal endoscopic myotomy for this condition. The beginning of third space endoscopy took place because of the invention of POEM, which was done in 2010 by Haru Inouye. And since the time it has been invented, there have been more than 400 publications on POEM and more than 10,000 procedures of POEM performed all over the world. I still remember when I did the first POEM procedure in our country in October 2012, and then I started talking about it everywhere. It was met with a lot of skepticism. Nilay will also remember I'd gone to Ahmedabad, I'd gone to so many different cities in the country, in gastroenterology meetings, in surgical meetings. I tried to sell this idea that POEM is going to make a big impact and third space endoscopy is going to stay. And today you can see what has happened. Actually, third space endoscopy has become a part and parcel of interventional endoscopy. All of us know how POEM is performed. Basically, 10 to 15 centimeters above the OG junction, we make a mucosal incision and then we enter inside the submucosal space by creating a fluid cushion. And then we make a long tunnel in the submucosal space, go across the OG junction for a few centimeters, and then through the tunnel, we cut the muscle fibers of the muscularis propria, either full thickness or a partial thickness, and then just come up and close the mucosal incision. Well, people perform POEM procedure in different methods. Some do in the anterior way, some do posterior, some do partial thickness or full thickness myotomy. And this is how the POEM procedure is performed. If you want to see what is the current status of the POEM procedure, you can see here there's a meta-analysis published in 2016, 36 studies, 5 database studies. Clinical success of POEM is 98%, significant reduction of LES pressures, IRP, and the time barium height column. You see here the only problem of POEM is post-procedure GERD, abnormal acid exposure around 50%, but symptomatic GERD around 8 to 10% of patients. What about further evidence on POEM? POEM versus laparoscopic Heller's myotomy, another systematic review and meta-analysis. Only 486 patients, 196 in POEM, 290 in lap Heller's group. Overall, not too much of a difference. But again, GRD is more common in POEM as compared to lap Heller's myotomy. What is interesting is very recently, there was a randomized controlled trial in a multi-center study in 8 European centers recently published in NEJM. 221 patients randomly assigned, POEM 112, lap Heller's myotomy with DOR in 109. You see here clinical success, POEM 83%, as against lap Heller's myotomy 81.7%. Serious adverse events also in POEM were quite low as compared to lap Heller's myotomy, but reflux esophagitis, of course, all grades of reflux were included in this, grade A to grade D. And at 2 months, POEM was 57%, lap Heller's 20%. 24 months, this reduced. POEM 44%, lap Heller's 29%. And a few years later, in fact, this reflux esophagitis or esophagitis in general appears to be almost similar in both the groups. So POEM is not inferior to lap Heller's myotomy and DOR. This is very interesting because in lap plus DOR, you're actually adding a fundoplication. POEM, you don't do a fundoplication, but in spite of that, a randomized control trial tells us that POEM is not inferior to lap Heller's myotomy. Reflux esophagitis is significantly higher in POEM, but we do have some things to treat it. Very interesting study from a thoracic surgery unit from United States. You see here from Demister's unit, 35 patients. And the final conclusion of this paper was thoracic surgeons with an interest in esophageal diseases are encouraged to adapt the POEM procedure. Now, this was in 2016. So even surgeons now are advocating the POEM procedure. Well, this gave birth, as I told you, to other submucosal channeling or third space endoscopy technique. Classic example was removal of subepithelial or submucosal tumors by underwater swimming type of a technique. A relatively simple procedure to do, provided the tumor is big enough so that you can visualize it inside the tunnel. Here, unfortunately, my video is not running, but what we do is we make a cut here in the few centimeters proximal to this tumor, and then by doing a submucosal channeling technique, we can go inside, we can actually see the tumor, dissect out the tumor from all the different directions, and then actually take the tumor out through the mouth by catching the tumor out by using a snare. What is the evidence as far as the submucosal tunneling resection of submucosal tumors is concerned? Systematic review, meta-analysis, there is no randomized study here, but there are 28 studies included in this meta-analysis. Complete resection rate is almost 98%. You can achieve a reasonably good en-bloc resection rate. There are a few simple, small complications which are not very serious adverse events. There is no mortality and no significant morbidity associated with this. Then the next procedure is, of course, GPOEM or gastric peroral endoscopic myotomy. The basic principle here is in those patients who have got either idiopathic or a diabetic gastroparesis, or more importantly, post-surgery impaired gastric emptying because of the cutting of the vagus nerve in patients who have gone resection anastomosis of the esophagus. And here you can see that if you do a simple thing like peroral endoscopic myotomy of the pylorus, you can achieve a good result. But this has been only in a few studies. This is not what our practical experience states. And what is basically done here is a few centimeters proximal to the pylorus, we make a fluid cushion. Then we go inside and we make a tunnel going all towards the pylorus. And once we reach the pyloric ring, again, I will try if the video is working, but if it doesn't work, yeah, fortunately it is working. So you can see here that we are making this fluid cushion. And then after making the fluid cushion, we are going ahead. We keep on dissecting ahead by using any type of knife. And then as we reach the pyloric ring, you can actually see the ring fibers over here. This is a pyloric ring. Now, as against a POEM procedure, in GPOEM, we don't continue the dissection beyond the pylorus because the mucosa in the duodenum is very thin. It is very close proximity to the muscle layer. If you try to dissect it, you can open up the mucosa. So once this ring is identified by using a special type of a knife here, using the IT knife here, and by a pulling direction, we can cut the muscle fibers of the pylorus and also some fibers of the antrum. So this is an antropyloromyotomy. And by doing this, we hope to achieve a reduction in the impaired gastric emptying. There is only one multi-center study which was published on this particular technique. 30 patients only from various centers. They have reported a technical success of 100%, good clinical response is 86%. But from my personal experience, when we perform a GPOM, in spite of doing a proper selection of the patient after doing nuclear studies to show and to prove that there is impaired gastric emptying, in spite of doing a GPOM, we have not found predictable results. So in fact, we have found them to be predictably unpredictable results. And even if you do a wonderful job, these patients continue to have symptoms and continue to vomit. A very important advance in submucosal tunneling is the utilization of the tunneling technique for ESD. All of those who do ESD know that those who perform ESD, sometimes it's very difficult to do a proper ESD. The main reason is we cannot achieve a triangulation by using the normal single channel endoscope which we use. We cannot retract the specimen side, and therefore we have to go inside it and try to dissect it from below. It keeps on flipping around and it becomes difficult, and sometimes such a large lesion, if you want to resect by ESD, it can take a very long time. The first idea that we can perform an ESD by using submucosal tunneling was sort of shown to us by Yamamoto, where he called it as the pocket ESD technique, what he called it. And by using this, you can make the same ESD procedure faster, safer, with a shorter learning curve. I hope these videos can run. You can see here, this is a submucosal tunneling ESD performed in the esophagus for a very large early squamous cancer in the esophagus. Here, of course, when the squamous cancer is engulfing almost 3/4 of the circumference of the esophagus, what we have to do is, it does not suffice to do only one tunnel, but we can make multiple tunnels going towards the gastric end, starting proximally, going distally, and then by dissecting the whole tumor inside through the tunnel, all that we have to do is after the dissection, we have to join the edges together, and thereby we can achieve a complete resection of the tumor. So here you can see here that the tunnel is now in progress. I'm just going ahead with this video. And the advantage of this is that you don't have to actually catch the area of the tumor, and you don't require a triangulation because you're going inside the tunnel. The cap actually acts as a pushing of it pushes the tumor away from you, and you can actually see the area of the muscle. You keep on dissecting towards the muscle, and then as we proceed further, we can achieve a very good dissection. And if you have a large tumor, you do multiple tunnels like this, and then all that we have to do is join the tunnels, and we can achieve a complete resection. So here you can see how you can do a good resection. Similarly, you can do also for the stomach. Now here you can see this is an early gastric cancer in the stomach. First we are doing the marking, and then proximally we make a cut and we enter the tunnel, and we keep on dissecting below the tumor, and the cap usually is used for retraction. So the specimen side automatically gets retracted, and to make sure that you reach the proper area, then you make the distal cut a little bit later after you have already made the tunnel, and then you continue through the tunnel until you see a transparent area, and after which you can do a complete cut. And finally, you see here, after doing the resection, you can achieve such a nice en bloc resection of the tumor. Of course, DPOM and utilizing the third space for making the septotomy more complete has been a relatively recent development, and this is what we do. Some people may argue that this is unnecessarily making a simple procedure complicated, but the only advantage of this procedure is that by making the submucosal tunneling septotomy, we can do a complete septotomy and thereby prevent recurrence of the dysphagia which can occur. Here you can see that this is the septum. Then you clean the area of the diverticulum as well as clean the area of the esophagus. Then once again, we make a fluid cushion a few centimeters proximal to it in the pharynx, and we enter inside with the endoscope to which a cap is attached. You keep on dissecting ahead until you start visualizing the septum muscle fibers. Now here, because we are in the submucosal space, we can dissect and cut the septal muscle fibers right till its base until you don't see any septum any longer, and then just come out and apply clips on the pharyngeal area. This procedure, it looks a little bit easy, but it is not as simple as it appears, because sometimes when you go inside the submucosal tunnel, you may not be able to locate the septum, especially when you're utilizing this technique for epiphrenic diverticuli. Because it is in the pharynx, you can easily locate the septum. And another issue is a lot of blood vessels. So it is a very vascular area in the pharynx. And in the esophagus, the problem is to locate the septum. Second issue is in the pharynx, the mucosa is very thin. So when you do a tunnel and when you go in and do a dissection, usually the mucosa separates out very widely and it becomes very difficult to close it. One of the papers is our own paper published very recently in Endoscopy. You see here operative technical tricks and 12-month outcomes after a diverticular DPOM in esophagus, epiphrenic, as well as Zenker's diverticuli. It's a single center prospective study with only 25 patients. Clinical success was 80%. Median hospitalization was 5 days. We did have some problems like odynophagia in 20%, chest pain in 16%, and vomiting in 8% of patients. But none of these patients we had any serious adverse events. More importantly, we did not find recurrence in any of these patients. Coming to it, what we are headed towards, we have already now started doing various procedures in the third space. Very likely in the future, because of advanced technique and better instrumentation, we will be slowly be able to enter into the fourth space. Already there are some procedures now which are being invented, where even if you have tumors outside the esophageal lumen or outside the stomach lumen, outside the wall, we can make a tunnel, go inside, make a full thickness myotomy, then enter inside the mediastinum or enter in the peritoneum and take out these tumors which are outside the organ. Well, this is the video of the same type of a procedure. You can see here that we are making the tunnel, we go inside, and then we go out, and here we have dissected out a tumor which is just below the GE junction. So the tunneling was started in the esophagus, and we cut all the muscle fibers, a full thickness myotomy, went out in the peritoneum, and this tumor outside in the peritoneum, which would dissect it out. Just to touch upon fourth space endoscopy, another thing in fourth space endoscopy, or what things you can do in the peritoneum, is a per oral endoscopic myotomy with fundoplication, a technique which was described by Inouye here. And here you can see that just at the OG junction, you do a full thickness myotomy, and then you start cutting after you have cut both the muscles, you see the subdiaphragmatic fat pad, which is seen here. You keep on dissecting that fat pad, and once you dissect the fat pad, you go beyond it and enter the peritoneum anteriorly. The most important part is to do a POEM with fundoplication. We have to do an anterior myotomy compulsorily so that you enter the peritoneum. And you have to remember that when you enter outside the muscle wall, you should not be proximal to the diaphragmatic crura. Because even by mistake, if you go proximal to the diaphragmatic crura, and if you have not identified the diaphragmatic crura, you will enter inadvertently into the chest, and that will cause collapse of the lung. And then this patient will require a chest tube. Here you can see an endoscopically done fundoplication by using the POMF technique. This is another ultra thin scope which has been passed in the stomach. And here you can see how well the fundoplication is. Well, coming to instrumentation, very soon there is going to be a new type of an endoscope which is likely to be introduced into the market. Already some clinical trials are going on, and that will be the multi-armed robotic endoscope. Now just imagine that if you have this multi-armed robotic endoscope and you utilize it through the third space, or maybe even utilize it in the fourth space, just imagine the possibilities what we have. And along with this, we will also have a triangulation with us. And fortunately, just beginning of this year, before the lockdown started, before the corona pandemic engulfed our population and the whole world, I was exposed to this multi-armed robotic endoscope on which I took particular training. And you see here, this is an unbelievable instrument where by using this robot, this is of course the doctor's console. You also have the patient console. And by putting this inside the third space, our possibilities of performing procedures in the submucosal tunnel or maybe beyond the tunnel are going to be limitless. Thanks for your attention.
Thank you, Dr. Mahadev, for the overview and your take on third space endoscopy. It was an excellent talk, sir. Thank you. After listening to this talk, I would like to discuss certain points with my panelists. And we have Dr. Sunil Dadich from Jodhpur. We have Dr. Deepak from AIMS, Delhi. We have Parvi Rai from Lucknow, SGPGI. We have Dr. Seth from Brooklyn, New York, and Dr. Mukesh Kalla. I don't know. I don't see Mukesh Kalla over here. Is Mukesh over there? Mukesh?
Mukesh could not join for medical reasons.
Okay. Sunil, we used to do dilation for POEM and for ecclesia cardia, and I still do sometimes dilatation. Do you think dilatation is absolutely out and we should be doing only POEM?
No, I think pneumatic dilatation still plays a role in patients with ecclesia cardia, because whatever we are doing so far, we are not curing it. We are just relieving the pressure at the level of G junction and letting the things out of esophagus easily by breaking the LES fibers. So by using pneumatic dilatation, since it has got equal efficacy with any other procedures in type 2 ecclesia, it is widely available and it is low cost. It is technically less challenging. Then it is having less procedural time, equal short-term response, and the immediate complications are also equal. The only problem with the pneumatic dilatation compared to other techniques is the long-term response, which is a little bit less compared to the other ones. So I would say in type 2 ecclesia cardia, my procedure of choice would be first to go for pneumatic dilatation. In all other types of ecclesia like type 3, the choice of procedure would be POEM. But in type 1 and type 2, if you go ahead with the graded version of pneumatic dilatation, you can go away with the symptom. Since there is no cure for this disease, we are just relieving the LES pressure. So I think PD is still going to stay for some time more.
Yeah. Dr. Maide, what do you say? Do you do dilatation? And if you are doing, yes. And if you are not doing, why no?
I'm sorry, Sunil, but I don't agree with you. because see, I'll tell you what, that I personally feel after doing POEM procedure, I feel if you compare POEM with pneumatic dilatation according to me is uncontrolled tearing of the muscle fibers of the esophagus. You don't know what you're tearing. You can't see what you're tearing. And even if you think you have done a good dilatation, suddenly you may have a full thickness perforation. There have been a randomized control trial comparing pneumatic dilatation with POEM, classically demonstrated and clearly demonstrated in literature that it is far, far superior to pneumatic dilatation. POEM, if at all it is compared, it should be compared to a Heller's myotomy because it is like a complete cure for the procedure. I mean, for the problem. I agree with you. It is a palliative procedure because we are not treating the myotic complex of nerves, and the problem is going to persist. But once you have cut the muscle fibers, the patient is not going to have dysphagia again, unless the dysphagia occurs because of rejoining. You have not done a complete POEM, or if there is reflux esophagitis and that causes a stricture. So I don't agree with you. In fact, type 1, type 2, type 3, all three are suitable indications for POEM. For type 1, we do a small esophageal cut. Type 2, we do a medium cut. Type 3, we do a long cut.
Dr. Deepak, I know you started doing POEM probably 3 years back. But when you started, see, why am I discussing it? Because in the audience, not everybody would be doing POEM. And when you start, you have certain difficulties. So when you start, what are the levels where you will have difficulty? Means at what stage you will have more difficulty as a beginner?
So I think initially when you are a good endoscopist, you have, I think you have performed in animal model. It is not too much difficulty, but in POEM at every step when you are at learning phase, you have some difficulty. Like in first step when you are creating a bleb, when you are learner, it's very difficult to create a bleb also. Okay. Then second, when you are nicking up the bleb, sometimes there will be blood vessels coming through it, it will cut, there will be bleed. Then initial stage, you got panicked. What is happening? Why there is a bleed? But when you get trained, you feel, oh, that's minor bleed, there will be no problem at all. The third problem, when you are entered into the submucosal space, it's very easy for everyone to just go through the tunnel very fastly. But at G junction, when there is a very tight G junction, then sometimes it takes your patience very, very good way, because when it is tight, and it is very difficult to differentiate between whether it is muscles or mucosa, so it becomes difficult in tight G junctions to cross the G junction. And at G junction, when you are crossing G junction, in gastric side, there are very vessels, these are very thick vessels, and if you will not take care of that good vessels, that's large caliber vessels, if it is bleeds, so an initial phase when I was learning, we think, oh, this is esophageal vessels, it will easily tackle. But in gastric side vessels, if it is bleeds, it's very initial phase, it's very nightmare for you. So please take care of the vessels when you are crossing to the gastric side. So if there will be no bleed, you will be happy. It will be, I mean, very easy to do the, and myotomy is easy to do. It's not a big problem. And third problem is that when you are closing the myotomy side, mucosal incision site, if it is not clean incision, sometimes it is very difficult to approximate the aegis. So it should be clean so that you can easily close it.
Dr. Mahadev, do you want to add on to something? I think even after sometimes having a clean incision, closure is difficult. Like, 3 days back, I had one poem. On one side, there was previous esophageal tuberculosis, so I did anterior poem, and it was a hell of a difficult closure. And of course, then I switched to Cook the clips, which are more robust, which we usually don't do it. But can you just share your experience just for the beginners?
See, as rightly said by Deepak, for a beginner, at every level you will face a problem. You try to make an incision. Sometimes the incision, you don't know whether you are going deep enough. Sometimes you're too superficial. You're not even cut the muscularis mucosa. So it's important right from the beginning, make a good bleb. Second, after making the bleb, when you make the incision sufficiently. You have to cut the lamina propria. You have to cut the little whitish tissue below the mucosa. Only then you can enter inside. Then when you make the bleb, when you make the cut, in the initial cut, you have to wedge it. You have to make ledges below the cut. Otherwise, you will not be able to enter the submucosal space. You'll keep on pushing, you'll not enter, you'll just tear open the mucosa. And inside the tunnel, I'll tell you what, for a beginner, don't just cut any vessel you see coagulated with a coag grasper. The safest for a beginner, so that you don't take any chances. Don't try to cut it with a knife and be bold that you will coagulate with a knife and cut it. No. And if you find it is too tight at the OG junction, cut the muscle fibers a little bit. If you cut the muscle fibers below, that whole thing will open up, and then you can make the tunnel better. So these are a few things. If you can't close the mucosal incision, I'll tell you what, if it is very, very difficult to close, you just apply clips and attach the mucosal edge to the muscle which you see below, and keep the patient NBM for a few days with nasogastric feeding. It will heal remarkably. The esophagus heals remarkably. And because you have cut open the OG junction, there is no distal obstruction. There's nothing is going to remain over there, and there will be a good mucosal healing which will take place. But the learning curve is there. At least 60 patients you should be able to do on your own or with somebody standing behind you without any problem. But initially, you will find a lot of difficulty.
Parveer, Dr. Parveer, Dr. Mahadev has touched upon reflux part a bit. So the biggest criticism of poem, so everybody agrees that poem is a great procedure, excellent results. You can do it any type of achalasia, type 1, 2, but the biggest criticism was reflux disease. Personally, I don't think reflux is such a major issue, but would you like to comment on it? Will it kill the procedure, or what's your take on it?
Yeah, I think the most important complication that is talked of for POEM or side effect is a gastroesophageal reflux disease post-procedure. So this procedure is just a decade old. We have 10 years since this procedure started. And if you see, there are now several meta-analyses, leave aside this large case series, but several meta-analyses which do suggest that the symptomatic reflux, gastroesophageal reflux disease is to the tune of up to 20%, that is 8 to 20%. If you see the erosive esophagitis, that is to the tune of around 30%. And if you see the abnormal acid exposure with 24-hour pH metry, that is from 40 to around 48%. So these are very high. The issue is right now when we are managing patients and they complain, give this symptomatic reflux, we prescribe them PPI and they do very well. Majority of the patients don't have any problem. But the issues are, we don't know how long to continue this PPI. We don't know whether these 24-hour, the esophageal exposure will lead to stenosis in long term, whether this will lead to Barrett's esophagus, whether this will lead to esophageal cancer. Till date, we don't have reports of either Barrett's or esophageal cancer because of this severe esophagitis. But again, the long-term follow-up of these patients will reflect that. So I strongly feel that right now this is a concern, but it is, since it is adequately managed with PPI at this point of time, we are not much bothered, but we definitely need long-term studies to be sure that we don't land up having these important complications.
Yeah, coming on to that GPOM, and I agree with Dr. Maidev that not only the results are predictable. See, I've been seeing at least 50 patients every day for years together. I've never come across such a great gastroparesis, except for post-operative phase, where you really need to do something. But I think it is very commonly done, not commonly, but very more frequently done in USA. So can I ask Dr. Seth his take on indications of GPOM, whether it is very much common in USA, and what's his take on the entire procedure as Dr. Seth, please.
So first off, Amit's talk was excellent. He really touched upon, some of the key elements of all different types of POEM, but specifically to GPOEM. I think from an endoscopist point of view, if someone's proficient with esophageal POEM, they could easily apply those skills to GPOEM. I think the biggest challenge is, as pointed out, is patient selection. We still don't have a good way to identify those patients that are ultimately going to do well. The other thing I think that's lagging is the data. We have robust data for esophageal POEM to the point where we're on the horizon of getting reimbursement by insurance companies for esophageal POEM. But GPOEM is lagging a little bit in terms of us being able to better determine which patients are going to do well. I think that the different centers that do perform esophageal POEM, they are starting to, increase the number of GPOEMs, but it's not being done at the same level annually as we see with esophageal POEM. And we also need those trials, comparing GPOEM with whatever the gold standard is, which is obviously quite limited for gastroparesis, endoscopic and surgical management. So I think it's coming along, but I still feel we're a few years away to say that this is a standard approach.
Sunil, how do we make a diagnosis of actually gastroparesis clinically prior to the procedure, and how would he see the response? Because that is the most important thing.
Actually, gastroparesis, you start with the clinical symptom, and we have a index for gastroparesis, which is GCSI, and it's a constellation of many symptoms, and they are scored from 0 to 5. And based on this index, you diagnose a person as having gastroparesis. Apart from this, you can do a gastric retention test. If you the more than 20% of residue is present in 4 hours, then you diagnose it. The predominant symptom for which GPOEM is considered are nausea and vomiting. It is less being done for bloating and abdomen pain as an indication. Then the gold standard test is gastric emptying scintigraphy using the colloidal sulfur colloid technetium-99 radionuclide scan. This is the gold standard for testing for diagnosing the gastroparesis. The other test can be used is a pyloric manometry using pyloric planimetry to assess the area of the pylorus. And the another new technique is endoflip, endoluminal flip technique, where you diagnose where you see the surface area of the pylorus as well as the distensibility of the pylorus pre and the post procedure. So with these techniques, you diagnose the gastroparesis, and after doing the GPOEM, you repeat the same GCSI index to look for the symptomatic improvement. Some people also recommend emptying testing to look for the improvement. But I think the flip and other new techniques are, I think, used only for the experimental purpose.
Yeah, Dr. Maidev, can you tell us in GPOM whether you will do a vertical incision, transverse incision, anterior incision, posterior incision, any advantage? And we have to be very fast because I think we have only 2 minutes now.
Okay, so posterior incision, number one. Number two, always vertical incision. We do not do a horizontal incision because it is much easier to close with clips. Because if you do a horizontal incision, you have to always close it with a suturing device. Posterior is better. Why? Because it is much easier for dissection because you're going along the greater curvature of the stomach. And another very important trick in GPOM is don't be too far away from the pylorus. Because as I told you in septotomy, you can miss the pylorus and go left or right. So try to be only 2 to 3 centimeters proximal, enter the tunnel, you'll see the pyloric ring immediately.
And this is a question for both Parveer and Deepak. Suppose we see only 2 types of gastroparesis most of the times. One is diabetic gastroparesis. The second one is post-operative. So do you do GPOM in diabetic gastroparesis? Are you comfortable doing GPOM in diabetic gastroparesis for both of you? Parveer first.
No, it's okay. Highlighted by both Dr. Maidev and Dr. Said that patient selection is very important. And I think one study has shown that diabetic gastroparesis has less response. However, that's only a retrospective study. But I feel that in diabetic gastroparesis, if you doesn't have a good diabetic control, because that is origin of its pathogenesis, merely only cutting the pyloric rim, as Dr. Maidev has also highlighted, that symptoms does not correlate with the outcome. What the patient has symptoms, even if you do pyloromyotomy, the patient doesn't have too much relief. So patient selection is very important, I think.
Parveer, what's your take? And you have to demute yourself.
Yeah. So I think we have just done 2 or 3 cases, and I strongly believe that with the current evidence that is available for GPOM, as have already been highlighted, it's not a very, very rewarding procedure as POM. So selection obviously is very, very important, but I think we possibly need more evidence before we start recruiting all patients of diabetic or idiopathic gastroparesis.
And last question, Dr. Maidev, about the stir. We do stir mainly in the esophagus and sometimes in the stomach or at the G junction. But many a times I've seen people doing it for small leiomyomas. So can you tell us the real indication of stir?
See, first of all, once you have diagnosed that there is a leiomyoma or any tumor in the submucosal space on EUS, we don't even have to take a FNAC or FNAB. Because only by the EUS morphology, the characteristics, the eco-texture, you can come to know what it looks like, from which layer it is arising. If it is a very tiny leiomyoma, and if it is not giving the patient any symptoms, you don't have to remove it. You can just leave it alone. You can just keep the patient on surveillance, keep a check if the patient develops symptoms. So stir should be done only if the patient has symptoms, number one. Or if you feel that the tumor is not homogeneous, and it is likely to maybe lead to a malignancy or develop malignant transformation, then you should remove it. Normally, the size, what we keep it is around 5 to 6 centimeters. But even larger tumors can be removed, theoretically speaking.
Yeah. Symptomatic tumors, or there is a possibility that this could lead to a potential malignancy, it should be removed. Hello?
Yes, I didn't get you.
Yeah, so I agree with you that only symptomatic or
Yes.
potential malignant tumors should be
Yes.
removed with stir.
Exactly.
Not every
Exactly.
tumor you see in esophagus should be, because most of the times they are leiomyomas. If they are asymptomatic, just observe them. You do.
Yeah, it could be even a lipoma, or it could be even a cyst. Yeah, Nilay, I think your signal is frozen.
I think, Nile, are you able to hear us?
Yeah, now I think my internet connection had it had gone for a minute. I think we should now close this session, and I thank all the panelists as well as Dr. Maidev for giving us this very important information on third space endoscopy. Thank you very much.
Thank you so much.
Thank you.
Thank you, Nile, for excellent moderation of the session and trying to elucidate what are the initial difficulties in doing the POEM procedure and what are the limitations of the procedure. I'll also try to concur with Dr. Parveer that we do not still know the long-term implications on doing this procedure. And I'll also agree with the other panelists to know what are the proper indications for gastroparesis, because we are still looking forward to have an ideal case which will be benefiting with so-called G-POEM. But I am thankful to Dr. Amit Medev for having brought it from bench to bedside. The very concept of POEM has generated a new field of third space endoscopy. So after digressing from gastroenterology to hepatology to EUS to liver transplantation, now we will have subspecialty of third space endoscopists will be just exclusively doing this. We look forward to that. Not forgetting what Pankaj Pasricha told us yesterday, that there is still unmet need both in G-POEM as well as in POEM to look at the neurohormonal problems which cause motility disorder. So rather than just chopping and cutting the muscles, it is high time we also understand the neuropathology. That is what Pankaj told us yesterday. But meanwhile, he has given us good evidence of opening up a totally new field, which I'm thankful Amit has brought very well to India. With that, I am thankful to all the panelists, moderator and the speaker for making this session very useful and lively. Thank you very much.
Thank you. Bye.
With that, we move on to the penultimate session of the day. This is a new technique called endoscopic submucosal dissection. Till recently, any polyp which was large, which was stuck up to the submucosa, which required a definite surgical intervention, certainly has a competitive edge now with endoscopy. This new technique of endoscopic submucosal dissection is one of the most difficult therapeutic endoscopic procedures to be done by the gastroenterologist. And we are in face-to-face competition with the surgeon. And we have the pioneer of ESD in India, Professor Amol Bapai, who is going to talk to us about the nuances of the basic technique.
Yeah.
We have everything again here in Israel.
Yeah, I saw. It's a tough time.
And with the and the.
So we don't know what is going.
May I request Professor Phillips Matthews, who is incidentally the president of Society of GI Endoscopy of India, to please take over the proceeding and introduce Professor Amol Bapai.
Thank you, Dr. Anil Arora, for this kind invitation. And are you able to hear me?
Yeah, we are able to hear you.
Yeah. And we have got, we were listening to the wonderful talks, and I think, at another procedure in the third space, and that too is actually picking up very fast in India. OM has picked up very well, and even this ESD has started late, but it has come up in a big way. And we have a very good speaker on this, that is Dr. Amol Bapai, who doesn't require any introduction. And he's presently the chief of therapeutic endoscopy at Dinanath Mangesha Hospital, Pune. And he'll be talking about recent advances on endoscopy submucosal dissection procedures. So Dr. Amol Bapai, can you share your slides now? And we have got a group of excellent panelists, which I will introduce later during the panel discussion. Dr. Bapai.
Thank you, Matthew. And thank you, Dr. Arora, for this invitation. Are my slides visible and am I audible?
Yes, you are.
Okay. Excellent meeting as usual, Dr. Arora. Now, as you've rightly mentioned, recent advances in endoscopic submucosal dissection is the topic that has been given to me. And let me start off by saying that ESD in itself is a relatively new advance. It is less than 2 decades that ESD was developed as a procedure in 2004. But let us start off with what ESD means. And ESD means it is an en bloc circumferential resection of pathologic mucosa by peeling it off from the middle or the deep submucosa in order to resect the lesion completely and lift it up from the muscle layer. And what it basically does is it provides us tissue for accurate pathological staging. And ESD can be a diagnostic or a potentially therapeutic procedure, depending on the final pathology report. And before that, it is always only provisionally therapeutic. That is what we need to understand. And the flow of events, we need to screen these patients for early cancer using a variety of image-enhanced endoscopy techniques. Then we perform the procedure, either a mucosal resection or a endoscopic submucosal dissection, EMR or ESD. Nowadays, more and more popularity is, ESD is gaining more and more popularity. Then the specimen is subjected to special histopathology in a special technique where multiple sections are taken. And then the final diagnosis is made, wherein we can decide whether the patient requires only a follow-up or whether it requires additional treatment. So the steps of ESD are, as you can see, that we have to mark the lesion all around circumferentially. Then we inject in the submucosa, we inject several types of solutions that are available. Then we incise the mucosa either on one side or circumferentially. And then we dissect the submucosa in order to lift the lesion up sequentially, and we complete the resection by completely dissecting the submucosa and lifting the lesion up. So that is how it is. This is, here you can see a video which I will just run through, because this is mainly because of the purpose of this talk is not to demonstrate videos, but just for those who may not be so familiar with ESD technique. So that is the submucosa, which is the glistening, and the muscle layer is seen underneath over there. The blue stain is on the mucosa, the submucosa, and the muscle layer looks white. And then we use a multitude of knives and we lift up the lesion completely, and then the dissection can be completed. That is how it looks. In a moment, once the lens is cleaned, you will see a better image. So that is the final defect, the mucosal defect, wherein you can see that the entire lesion has been resected. So, as I mentioned, it's less than 2 decades old, and traditionally it has been considered as one of the most daunting and difficult procedures with a long learning curve, and several challenges have been identified. The first one being a decision of whether the patient should be subjected to EMR or ESD. Then overall, there have been limited opportunities for ER till the last few years, wherein early diagnosis was limited to few centers and lack of availability of image-enhanced endoscopy was there. Then ESD as a procedure does involve precise cutting, dissection, excellent control on instruments, efficient retraction, and maintaining the submucosal cushion, and training has been challenging. We were fortunate to report the first case series of 5 patients in India almost 8 years ago. So the learning objectives of today's presentation, we need to see what has changed in the last decade regarding ESD. And I'm not going to discuss about the early diagnosis improvements because that has been taken care of earlier. I'm going to talk a little bit about the improvement in the decision making. I'm going to talk something about the technical and technological improvements. And I'm also going to talk something about the training opportunities and platforms. So we start off about 5 years ago when the ESG came out with these guidelines for lesions wherein one could perform either an EMR or an ESD. And this is what you can see over here, that ESD was considered as the first option for squamous cancer of the esophagus, for gastric cancers, and colorectal, non-granular or depressed lesions more than 2 centimeters in size. And for the rest of the lesions, particularly Barrett's, for gastric lesions less than 10 millimeters, for the duodenum, and for colorectal non-granular lesions or non-depressed lesions and less than 2 centimeters in size or granular ones, EMR was considered to be the preferred option. Now, a few things have changed in the last 5-6 years, and more popularity and more people are offering and they're preferring ESD over EMR because finally en-bloc resection of the lesion is the primary endpoint that all of us are wanting to do. And the recent most guidelines from the Japanese society, which was published just this year, give us a much more clearer message when we are talking about decision making in colorectal lesions, whether we should perform EMR or ESD. So all lesions for which endoscopic en-bloc resection is required, which means that if you feel that the patient has a high grade adenoma wherein en-bloc resection is required, then ESD is the way to go. Unless the lesion is very small, maybe less than 20 millimeters, then probably you could still do an EMR, but make sure that it is an en-bloc EMR and not a piecemeal EMR. Then a snare EMR or a piecemeal EMR is difficult to apply, particularly the LSD non-granular type and also the pseudodepressed types. Lesions showing a type 6 pattern, which becomes a very high-grade adenoma, and even cancers with a shallow T1 or a submucosal invasion, large depressed type tumors or even large protruded type tumors, which may harbor cancer in the depths, and this includes the granular variety as well. Mucosal tumors with submucosal fibrosis, either because of previous attempts at biopsy or at previous attempts at EMR. Also, lesions in conditions like ulcerative colitis, wherein there is a significant submucosal fibrosis, and local or residual recurrent cancers after EMR are all these are the tumors wherein ESD is mandatory, and even others wherein a piecemeal EMR is the way to go. Then probably if one wants to do an en-bloc resection, ESD is the way to go. Coming to gastric lesions, it is a little bit easier because gastric lesions, anything beyond 10 millimeters, EMR cannot be performed and an en-bloc EMR cannot be achieved. Therefore, for all en-bloc resections for more than 10 millimeters, we need to perform an ESD. What is important to understand in the gastric also is we should not let go and we should not forget about that surgical treatment is also a possibility, not just for gastric, for all others as well. But however, endoscopic resection is absolutely indicated in these types of lesions, which are intramucosal differentiated cancers less than 2 centimeters, and macroscopically it does not matter, but there should not be any ulceration or scarring. However, with the expanded indications now, differentiated cancers even larger than 2 centimeters and ulcerated lesions under 3 centimeters, and even undifferentiated cancers up to 2 centimeters can be resected using an ESD technique. And the indication of ESD versus EMR depends on the histopathological type, the size, the depth of invasion, and whether there is ulceration present or not. What is important to understand is curative resection. When do we consider the resection to be curative? Is when en-bloc resection and has been performed for a 2 centimeter or a smaller lesion, and it's a predominantly differentiated type, and ulceration and lymphatic or vascular invasion is negative, and negative surgical margins have been confirmed in the pathological specimen. So as I mentioned, pathology is the final indicator that the resection has been completed or not. For gastric lesions, another important point to remember is PPIs should be prescribed to these patients post ESD or post EMR to reduce the incidence of bleeding, as well as H. pylori eradication is recommended for all positive patients. For esophageal, one can see over here that the curative resection is lower for a focal EMR and also for an extended EMR. And when we perform an ESD, the curative resection is to the tune of 99 to 100%. And therefore, ESD is preferred, although there are problems like stricture, bleeding, or perforations. And stricture formation is a particular problem in the esophagus that needs to be handled very carefully. Coming to the next part of the discussion regarding traction techniques and improvement in the techniques. So there are traction, as we all know, those who have all those who are performing ESD in the panel as well as in the audience. So several methods have been described for improving traction during ESD. One of them, Dr. M.I.C.E mentioned about the tunneling ESD technique, wherein we can perform a tunnel as we perform in a POEM procedure. Also, one of the most traditional methods is the clip and line technique, where a clip along with a string attached or a dental floss attached, I will come to that later, can be used for retraction. There are also special clips available now, which can provide retraction, like the SO clip, and the pocket creation method, which actually has revolutionized the way we are performing ESDs in majority of our patients now. So the clip and line technique, which is the most simplest and the most inexpensive method, what we do is we just bring out the scope and we load the clip outside the patient. And this is a dental floss which is tied to the tip of to one of the flanges of the clip. And then the endoscope is introduced into the patient with the string hanging by the side. And this is how the procedure is performed. We've performed a circumferential incision. And now the clip is fired onto one lip of the resected specimen. And now the string is attached, the string is lifted up or pulled. And we can see that the submucosa opens up so beautifully. And we can wield our knife so easily in the submucosa to create a really rapid dissection. And that is very effective, and the procedure time really shortens significantly. So this is how it is performed. So what is important about this study is that in this study, what they were trying to do is they did a propensity score analysis, and what they showed that although the treatment outcomes were similar, procedure times were significantly shortened from 118 minutes to 82 minutes on an average, and this was significantly reduced, and that is the beauty of this procedure. The second method is the pocket creation method, as Dr. M.I.C.E had referred to it in short. So in a conventional ESD, what we do is we perform a circumferential mucosal incision. However, in pocket creation method, what we do is we create a small pocket and then we inject in the submucosa and we dissect underneath to lift the lesion up, and then the mucosal incision is completed at the last as a last step of the procedure. And what Professor Yamamoto's this paper demonstrated is that the completion rate, particularly for colorectal neoplasia, was significantly higher on an intentional to treat basis as well as on a per protocol analysis, and this was significant, and that is what is the beauty of this paper. And pocket creation has also been used for gastric neoplasms, and the advantages are very clear. It prevents leakage of the injected solution. It provides a good retraction because the submucosal tissue is stretched. It also gives us a better angle of approach for dissection, so that a vertical angle or a 90-degree angle is prevented and a more tangential angle can be achieved. And the fourth thing is that respiratory movement, which is often a problem in the stomach, is minimized because the scope and the stomach moves together. So this is a short video of the pocket creation technique. So here we are performing a mucosal incision. And here we have entered into the pocket now. That is a muscle layer, that is a submucosa, which is fibrotic. It was a very large tumor, almost circumferential, and this is the pocket that has been created. And now we are extending the mucosal incision on one side, and then the other side. And then the pocket may be extended further to join the the complete dissection. And then this is the proximal incision which is being taken in a retroflex manner. and that is the final dissection. So one can see which will deliver the specimen. That is a complete defect, and that is the specimen. So let us look at some of the efficacies and the efficacy of some of these traction techniques. So in the esophagus, what it shows is that the dissection speed, the procedure time, as well as the en bloc resection rates are all improved using traction techniques. Not so much the en bloc resection rates as much as the procedure time and the dissection speed. In the colorectum, procedure time, en bloc resection, as well as complete resection, all of them show a significant improvement. That is what it has been shown. And in the stomach, again, the procedure time and en bloc resection rates again show a significant improvement. So that is what is important. Then the next development which has happened and which has improved our ability to perform ESD is these combined injector knives, either the hybrid knife from Irby or the dual knife J from Olympus. These have the ability to inject and cut, which reduces the number of instrument exchanges and reduces the procedure time and simplifies the procedure significantly. The next thing is these special retraction clips. Now, as I mentioned, as you saw in one of the previous slides, that this clip has a spring-loaded attachment over here. So when we have attached the clip to the ESD specimen and then fix the spring to the opposite wall, dynamic retraction is possible. So with the dynamic retraction, the specimen just gets lifted up as the dissection progresses, and this makes things very easy. And we have some experience using these clips now. It really hastens up the procedure significantly. Then regarding the inject rates, originally normal saline used to be used, and all the Japanese are very fast with their ESD techniques, but we definitely need something much which will last in the tissues for longer. Gelofuscin is the poor man's substitute for all these others, but Muco-Up or hyaluronic acid was the first to come, followed by the Eleview or the Oris gel. But all these are fantastic in their abilities to retain the tissue cushion or the submucosal cushion, and it using these technique, these gels, we can retain the fluid in the tissue in the submucosa for almost 1 or 2 hours. So it really aids the dissection very rapidly, and one can perform the procedure very quickly as compared to what we could do it earlier. Then the next thing is regarding primary closure of the defect. And there is some data on this showing that possibly this could reduce the incidence of bleeding. So this was one study on in the upper GI where the attempted closure using a double channel endoscope and sequential closure of the defect was performed. This may be useful in patients who are high risk either on anticoagulants or antiplatelet agents. And it has shown some value, although the challenge is to retain the endoloop for a significantly longer period of time, because otherwise there is a chance that the endoloop may slip. So that still remains a challenge. There is also an endoscopic suturing, which is now available through the scope endoscopic suturing, by which one can close the defect by using a suture mechanism, and complete closure has been shown to be possible in about 73% patients in this primary study. So in this pilot study. So now coming to the last part of the discussion regarding the training, and this is a very important part, because as Matthew mentioned, ESD has become very popular, but at the same time, we all need to tread these, this path with caution. ESD can be treacherous territory for the inexperienced or the novice. And what is important to understand, and ESG came out with these fantastic guidelines. Now, the training curriculum exists, shows actually very clearly that the background for the trainee who wants to start ESD should be an advanced endoscopist, not the novice. This person should be trained in advanced imaging diagnosis, proficiency in EMR and adverse event management. Then for preparation of ESD training, there has to be a knowledge of ESD theory along with the information about the injectates and the devices and everything. You should have attended live conferences and meetings. The initial involvement should be by observation of experts and assisting experts, a minimum of 20 cases over a year. Then animal training has been shown to be very effective. At least 20 cases in isolated models, and in that what they have shown is the last 8 cases should have a complete ESD without any perforation if possible. Then the initial human experience, wherein the location selected should be the antrum or the rectum, small lesions not more than 2 to 3 centimeters, and the first 10 cases should be under supervision, and they should be mixed with animal training if the volume is low, because all this has to be acquired in a relatively short period of time. Otherwise, it does not have any effect. After that, the expert can certify this the competence, and after that, routine experience. And for that as well, a minimum of 25 cases per year is recommended to maintain credentialing for ESD and to start ESD. And after that, the person can start ESD in the esophagus and in the colon. So these are just some of the guidelines which I have just listed out, but probably we can just skip these because we can take some of these discussions during Matthew's during the panel. So to summarize,
Amol, I am getting okay, good.
So to summarize, ESD has come a long way since it was started in 2004, and it has proven to be superior to other endoscopic resections, especially EMR for en-bloc resection of early gastric cancer, early GI cancers. The challenges in technique, long learning curve, prolonged procedure time, and training issues are currently the drawbacks in learning ESD. The last decade has seen several developments to improve and innovate these techniques to circumvent these challenges. The future of ESD is bright, and it is picking up in the West as well as in other regions, including India. And the future developments will likely focus on training of ESD and simplifying the technique further. With that, I would like to invite you, this is just a preliminary announcement, but just make sure you block your dates. Hopefully we will be able to have a real conference, but in case the COVID situation is still not completely under control, we will have a virtual conference as we did this year. Thank you very much. Thank you for a patient hearing.
Thank you, Amol. It was a very good presentation. I think, can I call upon the panelists now? I know that we are running short of time, so I will try to be as brief as possible. And we have Dr. K.K. Rawal. He is from Rajkot Prime Hospital. Dr. Rawal is there. We have Dr. Amit Singhal from Jalandhar, gastroenterologist there. Dr. Shaukat Ali Sargar. He is from Sher-e-Kashmir Institute. Pankaj Desai. Pankaj, are you there?
Yeah, I'm here.
And Dr. Kartar Singh from Chandigarh. So I think, we had a very good discussion. What I'll do is I'll just go through certain issues which we think, we can have a quick discussion. Some of it's already covered by Dr. Amol. And this I'm not going. The issues which we'll look into is actually what are the prerequisites of doing an endoscopic resection. And then what is EMR versus ESD? Right colon flat polyps, is there any difficulties? Duodenal lesions, is the approach different? And if time permits, we'll have training in ESD. So what I have done is I have just grouped this panel into two. Group A is Dr. Rawal and Dr. Amit and Amit Singhal, Kartar Singh. And group B is Shaukat Ali Sargar and Pankaj Desai. And we'll come to the issue first one. What are the prerequisites of endoscopic resection? In other words, image enhanced endoscopy, EUS before ESD. Is there any role? Can I ask Dr. Rawal?
Yes, thank you, Dr. Anil and Matthew. And very nice talk by Amol.
You have to be very brief.
Yes. See, we have to first judge whether what modality of the treatment will be required for ESD. I mean, whether this lesion is having a depth of the invasion, whether this lesion is suitable for endoscopic submucosal dissection or not. For that, we require image enhanced endoscopy. So this can be done electronically, like we can use NBI or FICE or iScan or BLI, or we can use dye-based chromoendoscopy. So this is important to delineate the lesion, the marking of the lesions, because you have to know the extent of the lesion and depth of the lesion. So that's why we require image-enhanced endoscopy. Normal white light will not be able to tell us these things.
Now, why do you require image-enhanced? Please briefly tell us, why do you want that?
We want, because we have to see whether this, what will be the depth of the lesion, because there are some classification based on this imaging, like NICE classification or Genet classification or pit pattern classification by Kudo. If there is deep invasion, then this lesion may not be able to be treated by endoscopically. This may require surgery or some other therapy, in your joint therapy, before you take up the lesions. So that's why, to know the depth of the lesion and extent of the lesion, we require image-enhanced endoscopy.
Of course, agreed. You also require the line of demarcation properly. For that also you can help it. So you can have chromoendoscopy. You have got electronic endoscopy. You can have dye used, or even now you can have even a virtual histology. I mean, you can have a histology just by looking at the markers, that is endocytoscopy. And as you have told, that is by looking at the vascular pattern and as well as the mucosal pattern, you can tell the extent of invasion. That is very important. So what about ESD? Dr. Amit is there?
Yes, sir.
So what in which all conditions you do a ESD? I mean, sorry, EUS before our section. Is it really necessary? Is it really necessary?
No, if you have like Dr. Raval has rightly said, if we are doing a good image enhanced endoscopy, doing EUS in all the cases is not the must. But if the patient own image enhanced endoscopy is showing that the patient, it could be advanced lesion, and then there is a deeper involvement of more than 1/3 involvement of submucosa, then you may consider to do a EUS in patients to look for any lymphatic involvement or so. So I would say that role of EUS in ES before ESD is very, very limited in very selected subgroup.
Okay, thank you. I think we will go to the next issue, that is how to choose a case for EMR versus ESD. It's already partly covered. And can I ask Dr. Pankaj Desai? We have Dr. Pankaj Desai is there?
Yes, sir.
And Saukat Ali Sarga. So Pankaj, can you just briefly tell me, suppose you see a lesion like this, what will be your approach?
Yeah. I think as Dr. Raval has already told, that we will just put narrowband imaging on this or chromoendoscopy, and then we will see the pit pattern and the classification. And if it is not a high-grade dysplasia, then my preference, because this is a very large lesion, it is granular, but we have a very big component, which is a proliferative component to this. My take would be to do a ESD for this lesion, because it might be harboring a lot of cancer somewhere. Plus, the more the larger the lesion, we always have a good amount of fibrosis.
Yeah, agreed. It is ESD. There is no doubt regarding that.
Right.
Suppose you see a lesion like this, what will be your approach?
I think I'm not seeing it. It's a flat lesion. I think I just saw a glimpse of it. I could not see it properly.
Okay, Dr. Shaukat is there?
I'm not seeing him.
Okay. So, Shaukat?
So Dr. Shaukat is
No,
not there.
anyway, this is actually a polypoidal lesion, which actually you can see in 2008. And that time we were doing actually a EMR, and it is actually, it can also do well. Suppose you see a lesion like this.
Yeah.
What will be your take? I am sure you will go, Amol, any opinion on that? Because our panel, most of the people are interested in ESD. I think EMR is.
Yes.
Yeah. Amol, any comment on this?
Yeah, Matthew. I would look to see how this lesion lives. It is pretty large, and also I would want to see in the center of the lesion, because I just momentarily I saw a few depressed areas. So I would prefer to do an ESD in this. But
yes, it has depressed areas. So naturally, this is ESD. There is no doubt about it. So we will go for the issue number 3. So we have Raval, we have Amit, and Dr. Kartar Singh. So this is, we generally, people say that right colonic flat polyps, especially the cecal one, are difficult to handle. So what is your take? We'll start with Dr. Amit.
So definitely right colonic lesions are considered to be the most difficult among the difficult lesions to handle, because there is a poor scope maneuverability in the right colon. The scope length, which is inside the colon, and it's already bent at various places. So you can't maneuver your scope that well, and hence there could be a difficulty in doing
There is a technical aspect. And other than that, of course, I agree that. Other than that.
The colonic wall tends to be more thinner towards the right side of the colon. So there are more chances of complications, including perforation. So one has to be very careful about it. So but still people are doing it, but it has to be done in a very, very expert hand, those who have got a good experience of doing ESD lower down.
Thank you. So what about Pankaj?
Right colonic.
Any quick comment on that?
Yeah, right colonic lesions. I think if you see a pit pattern which is not high-grade dysplasia, EMR is a good option. But ESD, if it is involving the appendicular orifices and area, I think ESD would be a better option. The most important thing would be I would try to close these defects in the right colon. That is important.
I agree. The two common complications with the right colonic polyp, especially seeker, are one is the perforation, second is actually the coagulation syndrome. And most common site for perforation in the colon is actually the sigmoid colon, because it is actually redundant and all. But second is, of course, it is cecum. And so now people are trying to do EMR, especially underwater EMR. So I would like to get an opinion from Dr. Amol. What is your opinion regarding that? After that, the panelist could comment. This is a lesion in the right colon, flat polyp near the ileocecal valve. Amol?
Unmute, yeah.
Yeah, sorry, yeah. So this lesion, you mean to say, should we do an EMR or ESD? Or?
Yeah.
Well, I would prefer to do an ESD in this, because although ESD, I do agree with Pankaj that ESD in the right colon is more tricky. And if there is no abnormal pit pattern, then an EMR is always a good option to go back.
Amol, you are an expert. You have got a hammer, so you want to tap on all the nails. But you know what I'm telling is that in a patient on the right colon, a polyp like this, would you entertain EMR at all, or straight away ESD?
No, I would definitely entertain EMR. I would not do an EMR in this case. Now, if suppose this patient also is quite a high risk for anesthesia. Now, if I don't want to prolong the procedure too longer, all these possibilities also come into the picture. So we have to look at the patient as a whole. Now,
agreed.
If I have to do it, and only because if I do an ESD in this case, I will need probably 1.5, 2 hours.
Yes, exactly.
If I do it quickly, then probably I have to do an EMR. If the patient is 85, 90-year-old,
And see, the advantage shown is that actually this is actually a picture taken from Birmola study. What they have done is they underwater, what they have done without even injection. You can see that when you do an EUS there, you can see the muscle layer remains same. Only the mucosa actually hangs into the water, and there is actually an evidence of magnification do happen in the water medium. And so actually the lesions, you are unlikely to cut the muscles. So it's actually a good technique. So underwater EMR is an evolving technique, and the complications are practically nil. And they said the perforation was nil on that, but delayed bleeding do occur. So it also enhances the optical imaging. So in coming to the issue number 4, and that is actually not a very common thing, but nowadays we come across that. And dual flat polyps. How do you approach? This is to Sargar and Pankaj Desai. This is a dual polyp. It's the infraambulary level. You can see that. And I will show you the video. Pankaj and Amol, few comments on this.
Yeah. This polyps, I think in duodenum, though there is a high risk of converting these polyps into malignancies, around 5%, which has been described. But ESD would be a preferred method, but very high chances of perforation and delayed bleeding. So in duodenum, I would see if it is in the descending duodenum, then it is always, we would try to remove it en bloc and then close. That is very important. EMR is an option.
That is a very strong comment. In the other areas, the closure of ESD is not very important.
Yes.
Here, the mucosal defect is has to be closed. Why?
Definitely, because of the pancreatic juice and the bile juices, they will erode and they will cause, there is a very high risk of delayed perforation and delayed bleeding in duodenum, which is much more than in other areas. And plus the wall of the duodenum is very thin, muscle is very thin. And therefore, I think it is mandatory to close the defects as far as possible in duodenum.
I agree. Amol, any comment?
Fully agree with Pankaj that closure of defects in the duodenum is mandatory. The descending duodenum is a retroperitoneal structure. So even if there is a perforation, peritoneal signs come in very late, and it becomes very difficult to manage these patients once there is a perforation over there. So primary closure, and unless one is not confident of doing the primary closure, I don't think these patients should be subjected to any kind of resection.
I agree on that. I think closure on this area is very, very important because of the reasons what he has told, and also you have to keep Nilorally for these patients for a little long time.
Yeah,
so I
people
think
have gone to the extent of doing in the ERCP and putting nasobiliary and nasopancreatic drains for a few days to avoid contamination when you are doing in descending duodenum.
What we can do is you put Ryle's tube, but you put the patient on close it properly. That is the most important thing. So coming to last session, only one sentence answer from each one of you. Can I ask Amit? Suppose you want to start, or you want to tell your younger colleague to start ESD procedure. Which site of the body organ? Upper GI, lower GI, stomach, esophagus, or rectum, or right colon? Which is the site?
Rectum will be the safest, I would think.
What about Amol? You are training a lot of people, Amol.
Rectum or antrum. In India, we don't get many antral regions. So
I think rectum is good. Rectum advantage is that because if it is below that in the lower portion, the chance of perforation is less.
Almost
but blood bleeding can occur. And another thing is Dr. Kartar Singh is here? No. So suppose you want to motivate a younger colleague from your department for taking up ESD training. So how do you select that candidate? Now, what are the qualities he requires to become a third space surgeon or a person who is going to do ESD? This is going to be our last question. So I think I ask Amol.
Well, it's there are two aspects to this. One is the technical skills, as I see it in my junior colleague, and the second thing is the temperament and the commitment. And both these things, mind you, are important. So a person may be technically very sound and very dexterous in his endoscopic skills. But if the temperament is not there, then probably ESD is not the right subspecialty.
Agreed. Pankaj, on quick comment on this.
Yeah, I think the person should have a good technical skill. He should be good at his other therapeutic endoscopy, and plus he should be able to manage his complications. Once he has these skills which are acquired, I think we can ask him to go a step ahead and get trained in ESD. I think that is the prerequisite.
1 minute.
I think the most important goal is the technical skill. Second is good observation, and third is the temperament as well as his perseverance on the procedure. Because you should not be in a hurry on that. So with this, I think we should conclude this session. Thank you so much.
Thank you.
And I'm not showing this because Amol has already shown this. The only thing is that they have suggested that ESD guidelines shown that the US has a role in esophagus as well as in the rectum. So we'll come to the conclusion. Thanks a lot for the active participation. I thank Anil Arora, Dr. Amol, and all the participants for the active participation. Thank you so much.
Thank you, Dr. Matthew. Thank you, Dr. Anil.
Thank you. Thank you.
Thank you, Dr. Matthew. I'm extremely grateful to Dr. Matthew for moderating the session very well. And kudos to Dr. Amol for making a difficult task look easy. But believe me, a person like Amol does not need an EUS, he doesn't need an NBI. If he has a polyp, it will be easier for him to do an ESD rather than keep debating about EMR in ESD. but such people are rare, and I'm sure anybody who wants to learn, you must visit his center. You need to have a cool, competent, and authoritative head on strong shoulders, when he has all the attributes for that. Thank you, Amol, and also I'm thankful to all the panelists for making the session lively. Coming on to the last but not the least session of the day, this is the GI perforations. Upper GI endoscopy and colonoscopy are the routine bread and butter procedure for all gastroenterologists all over the world. But with increasing usage of other modalities like ESD, EMR, therapeutic and diagnostic, EUS, and venturing into what was something a forum and the fort for surgeons, were likely to have more incidental and accidental perforation of GI tract. And to talk to us about that, we have one of the most eloquent speakers from India, Professor Mahesh Goenka, who has so many first to his credit, especially the closure of the GI perforation. And to take us through the journey of GI perforation, may I request my senior and the teacher and my mentor, Professor Manu Tandon, to take over the proceedings. Manu Tandon, please.
Thank you, Anil. And I think we would like to thank you for this privilege. We are come to the last of the sessions of the 4-day meet, which was very well attended, very well spoken, and active participation. I think Mahesh has already been introduced, but just for you, he is currently the president of SGI, besides being the head of the unit at Apollo, Calcutta. I'd also at this time talk to you about the panelists who are with me with us are Dr. Bhargav. Bhargav sir has been my teacher and been a mentor for many of us here. And he, besides being the head at AIMS, now he is at Apollo. We have Dr. Sameer Mahendra, who's a consultant as SGPGI at Lucknow. Dr. Ajay Jain at Chaitram, Indore. And then we have the next generation, Dr. Prashant Solanki from Anand Hospital, Meerut, and Dr. Sameer Taneja from Synergy, Agra. With this very, mixture of the blend of the experienced and the new talent, we are going to ask Mahesh to talk on his views on management of, most of them are iatrogenic, as Anil has said, perforations of the GI tract. Over to you, Mahesh.
Thank you, Manu. Am I audible?
Yes, yes. Go ahead.
So thank you, Manu, and thank you, Dr. Anil Arora, for asking me to present this talk. I know I'm a tail ender today. Can my slide be seen?
Yes, yes. We can see all the tail
ender. So I'm the tail ender and I am the last day, last talk. But I think you are aware of some of the very good tail enders who did miracles as a tail ender. Particularly, I would like you to remember Balaji.
Yes.
This is Balaji as a tail ender in 2004 against Pakistan and hit 6 boundaries in 1 over. 3 of them were boundaries, 4 runs, and 3 of them were sixers.
Mahesh, your screen is not coming on the main one. It's coming to the side.
Can you see now?
We got your screen. Yeah,
right.
yeah.
So,
we got your title.
So I'm a tail ender today, but let me see if I can score some runs, if not a boundary. The topic given to me by Dr. Anil Arora is to talk to you about recent advances in endotherapy of perforations. I purposefully added leaks and fistulas because these 3 terms are often used interchangeably. Dr. Anil Arora asked me to concentrate on any 8 recent publications on this subject, and as an abiding speaker, I will do only that, but I will try to build up a story. Before I go into the presentation, let's define these 3 terms. A perforation is an acute full thickness defect in the GI tract, often created by us as endoscopists. Leaks are usually created by a surgeon. This is a disruption at a surgical anastomosis resulting in a fluid collection, whereas fistulas are mostly because of underlying etiology. They are abnormal communication between 2 epithelialized surfaces. Having said that, these terms are often used interchangeably in the day-to-day practice. However, I must say that perforations have the best results for endotherapy compared with leaks and fistulas. Fistulas has suboptimal results in general. This slide gives you an overall feeling about the etiology of various mucosal defects. As shown, Most of them are endoscopic procedures, dilatation, polypectomy. We just heard about ESD, foreign body, PEG, endoscopy, sphincterotomy, biliary stent, and ampulectomy are some of the prominent ones. Now, there are two alternate approaches to closure of the mucosal defects. One can be endoscopy and the other one can be surgery. And whether one to choose one of them will depend on a number of factors, most important being size of the mucosal defect, location, and presence of associated contamination. But whichever one of the two techniques which we follow, we must give bowel rest at least for some time, appropriate antibiotic, drainage of the collections, and maintain the nutrition. So when you deal with a mucosal defect, it is always good to have a water-soluble contrast study or preferably a CT scan, except in the situation where you detect the perforation at the time of endoscopy. And if you do a CT scan, then you will find out whether it's a contained leak, whether there is contamination. If there is mediastinal abdominal contamination and there is uncontained leak, then you should prefer surgery. Moreover, if the leak or perforation has been detected more than 48 hours after the leak or perforation has happened at endoscopy. In other cases, you may try endotherapy. However, if the endotherapy fails, surgery is always an option. Now, there's a considerable change in the trend in the treatment of mucosal defects, whereas in 1990s, none of them were subjected to non-operative treatment including endoscopy. Mostly they were managed at surgery. In the last 10 years, 75% of them are managed at endoscopy. And this has led to reduced complications and reduced hospital stay. So what are the various endoscopic devices for controlling perforations, leaks, and fistula? Broadly, I can divide them into closers. That means you're closing the defect directly by either endoclips, suture devices, or sealants. You can divert the secretions from the defects by putting a covered stent. And more recently, we have endoscopic vacuum therapy, which has come in a big way. If you look at the overall practice, I think that it's endoclips, covered stents, and more recently, as I said, EVAC, which are mostly used for controlling leaks and fistulas. Sutures, sealants are less commonly used, but I'll touch upon some of these subsequently. So in around 1960s and 70s, we published a series of articles which were comprehensive articles on the management of leaks and fistula. And as Dr. Anil Arora asked me, I'm going to talk through 7 or 8 articles, what have we learned in the last 3 years. So I searched at PubMed, and I found in the last 3 years, there have been 104 publications for endoscopic management, and I chose only 8 of them for today's presentation. So what are endoclips? Endoclips, as all of us know, are either through the scope, so-called TTS clips, or over the scope clips. The TTS clips are available. These are the 3 main manufacturers. We all use them routinely: Cook, Boston, and Olympus. These are the clip names: Quick Clip or Quick Clip Pro, Resolution 360, and Instinct from Cook. Presently, most of these clips are rotatable so that you can precisely put them in the proper alignment, and they're mostly reopenable so that if you're not satisfied, you can open it again and again fire it. There are endoclips which are available from various other companies. Almost every endoscopic accessory manufacturers make the endoclips, but we do not have much of their use in our country. This is one of my patients way back in 2013, presented with Borhap syndrome with pneumothorax. And this is being managed by through the scope clips. The technique is almost the same as we do for the poem closure of the mucosal incision. And with about 8 or 9 clips, we could close this defect. We drained the pneumothorax, and the patient went home after 3 to 4 days. Now, the other clip which I'm very, very fond of is over the scope clip, and the one which is commonly used is over scope clip. This is, as we all know, is just like an EVL cylinder. It's attached to the tip of the scope, and then you fire. Multiple types and varieties of endoscope clips are available as per the design. They are type A, type P, and type GC. The diameter 11, 12, and 14 millimeter, and cap depth of 3 and 6 millimeter. And depending on the purpose, you choose which clip to use. So these are some of our cases. This is one of esophageal perforation caused by a blind severicular dilator in one of the medical colleges in Supura. And this is a patient in which a lateral perforation happened while we were performing in the US, one of my colleagues. This was a large perforation. It could be controlled by over-scope clip, and the patient could be discharged in 2 days' time. Now, we also have some accessories to help in the OTC clip. These are anchors. which can pull the tissue inside the cylinder and twin grasper to approximate the edges. Now, this is my first paper which I'll be discussing in brief. This is choosing the right PTS clip. As I said, there are multiple types of clips available. So this paper from USA, published in GI Endoscopy in 2018, compared 5 prominent clips. And they looked at the rotatability, overshoot, precision of opening and closing, tensile strength, and strength of tissue compression by various in vitro devices. So this is various configuration of the scope. This is how to measure the tensile strength, the amount of tissue grasp, and rotation of the clip. These are some of the parameters. If you look at the jaw length, the quick clip is 10 millimeter, short clip is 11 millimeter, where the other clips are slightly smaller. Open width, if you look at the short clip and the instinct clip has higher open width compared to others. If you look at the material, most of them are stainless steel clip, except the quick clip from Olympus, which is another alloy. Now, there are many figures given in this, but to summarize what they found in this study is the rotatability of the clip was best with resolution 360. Least overshoot was again seen with resolution 360 as well as with short clip and dura clip. Opening precision was mainly with these two clips. Tensile strength was best with the Olympus clip, but the closure strength was again very good with resolution as well as instinct. So if you have to choose one clip, and if the cost is not a limiting factor, then based on this study, possibly resolution 360 is a good clip. Of course, we use other clips for various reasons, including the cost issues. Now, the second paper which I'm going to present is on OTSC clip. This is published in 2019 in Minimally Invasive Therapy and Allied Technology Journal. This includes 12 series, 191 cases. These were the location of defect, and these were the underlying etiology, mainly polypectomy, EMR, ESD, US, ERCP, and EFTAR. And this is the forest plot. This gives you the homogeneity of the data in 12 series, and this is the funnel plot, which indicates that since every study is within the funnel except one, this shows that there is no publication bias. And what the results show that the technical success of over the scope clip was 89.1%, and clinical success was 85%, which is pretty good. So this is a good study, a good meta-analysis of over the scope clip published a few months back. Now, this is an article published 3 years back, but I have put this as my third article. This is a new type of clip, which we have also used in about 8 patients, and this was the first series of cases published in Endoscopy International in 2017. So this is padlock clip, which differs from overscope clip in the sense that this attachment is going outside the scope. So the working channel of the scope is available for using the instruments through that, which is not available while you are using the overscope clip. So this is the advantage of padlock clip. We do not have any head-to-head trial between the two clips, but this is the clip which we should see as a future clip, which may be better than the other clips which are available. So we talked about the endo clips. Let's now talk about some of the covered stents. And these are some of the designs of the covered stents made by various companies, various designs, various diameters, which are available. Now, for closing leaks and fistulas, sometimes we use a stent. This unfortunate patient had a leak after duodenojejunectomy, and we used a covered stent in this particular patient. And fortunately to us, we could control this leak after putting the stent. However, the main challenge when you put the stent in a situation like this is the migration of the stent. So either you can use a large diameter stent. So we have mega stents, and this is the Danish stent, which is primarily used for variceal bleeding, can also be used to control fistulas and leaks. The other way is to use a modified stent designs, and there are various types of stents available. Dumbbell-shaped stent, there's an extra layer here, which can be used to reduce the migration, and these are some of them available from Korean companies. What people have been using till recently is either using these clip devices to stabilize the stent, but what we have been using till about a couple of years back is using our own basic method of putting a wire, putting a thread around the proximal end of the stent and externalizing it through the nose and keeping it inside, keeping it in place for about 3 weeks, by which time most of the perforations would seal. This is article number 4, which I wanted to present. This is an article published in Endoscopy in 2018, where they have combined endoluminal vacuum therapy with stent placement. I'll be talking briefly about endoluminal vacuum therapy later on, but come to this article, they said 13 patients, 12 of them had an anastomotic leak, and see what they have done. So this patient had a sponge therapy, so there were 2 perforations and 2 sponges had been placed on the 2 sides. This was a very difficult case, and then they combined it with a stent placement, and this healed. So you can see that this was a very successful procedure. Overall success rate in this article was 75%, with none of them had any adverse effect. Now let's talk briefly about endoluminal suturing. I think we have all heard about it, mainly for bariatric endoscopy, but it can also be used for leaks and fissulas. And this is a study published last year, September 2019, in surgical endoscopy, a retrospective study, only 20 patients. But I put it as a 5th article of interest for me because you can see that for the first time they categorized the defects into 3 categories. So this is one where the tissue, where the defect is not very large. This is one with a moderate defect, and this one is with a very large defect. This cannot be possibly sutured. So they have used SEMS with anchoring alone. So they have used the suture device only to anchor the stent. Whereas in this, they have used only endoscopic suturing. And in this, they combined endoscopic suturing with a stent which was anchored. And they found that by using this stratified treatment, success rate was more than 80%, or 19% did develop short stenosis, which could easily be controlled by endoscopic therapy. This is one of their patients where after LSG leak, they put a stent and they've anchored the stent by using Apollo device to put it, and this is possibly better than putting the clips, which was practiced earlier. Now, let's talk a little bit about endovec therapy. Somehow, this therapy is more popular with the surgeons. We endoscopists don't use it, but there are systems available by Braun company which can be used. And this can be particularly very useful because if you put the sponge and produce a negative pressure, then it takes away the pus and material. For infected cases, this may be very, very efficacious. So there are 2 articles I'll share with you. One is on the lower GIT EVAC therapy and one on the upper GI tract. This is my 6th article. And this is published in colorectal disease in 2019. Overall rate of colorectal leak rate after colonic surgeries, anastomosis is around 10 to 11%. So in their series, their meta-analysis, there were 19 series, 295 cases, mostly in the rectal cases, 5.6 centimeter from the anal verge. There was an abscess of a median size of 6 centimeters. Most of them had stroma. They used multiple sponges up to a median of 7. Negative pressure of 150 millimeter mercury on average was applied, and the device was kept for almost 30 days. Now, this is the results. Success rates, while there is a little variability as can be shown from this meta-analysis, complication rate is shown here. As you can see, the overall success rate was 85%. Ileostomy could be closed in 72%, complication rate was 19%, and 15% did require surgery, which failed with endoscopic therapy. The most important predictor for a success at endoscopic therapy in this series was presence of ileostomy. So those who had ileostomy had much better success with endoscopic therapy. Now let's talk about EVAC in upper GIT. And this is a study published in Surgical Endoscopy in later 2017. This is 77 patients, mostly post-operative 59, iatrogenic 12, spontaneous 6. The average duration of therapy, endoscopic therapy, was 11 days. Number of sponges used was 2.75 median. And they did put additional stent, and this I talked about, a combining sponge with stent in 21 out of the 77 patients. So the EVAC can be placed in 2 places. If there is not a large cavity, then you put it intraluminally at the site of the leak. But if the large cavity, you can put it inside the cavity, and then you can combine this with stent if required. So they succeeded in 60 out of 77 patients to close the leak perforation by using EVAC therapy. To complete my talk, let me talk about sealants. One can use fibrin and cyanoacrylate. I don't see much of a development in the last 3 years, so I'm quoting the study of 2015, where they used fibrin in 47, cyanoacrylate in 8, and a combination in remaining 8, either through the oral route, rectal route, or into the fistula combination, and they recorded a success rate of 96.8%. However, in my own experience, a small number of cases, I haven't found fibrin and cyanoacrylate to be very, very useful, and I do not practice this technique. So do we have a consensus? Very difficult. I think so. This is an article, and this is my article number 8, which looked at international multi-center expert survey of endoscopic treatment of upper GI tract, published last month in Endoscopy International. So these people sent a survey to 163 endoscopists. Half of them responded. Majority of them were doing 10 to 19 such procedures per year. Look at the results. Almost 97% using stents, 89% were using OTSC clip, 76% with using fibrin glue, 79% were using some endoscopic internal devices. So these were the main 3 procedures: stents, OTSC clip, and fibrin glue, which was used. This study also showed that metal stent was the first option in 56% of the patients. 80% of the endoscopists used some technique to reduce the migration of the stent, and mostly the stents were kept for 4 weeks. For OTSC clip, 60% performed some marginal ablation by using APC or some other technique to have better results. And then for EVAC therapy, 56% would dilate the tract if the defect is small and then put the vacuum sponge inside. So the approach was variable. My last presentation, I had taken one more extra slide liberty from Dr. Arora, is the 9th presentation, which is a systemic review and a meta-analysis of endoscopic management of leaks and fistula after bariatric surgery. They had 493. They had a number of series. So stents were used in 40 series, 493 patients, success of 92%, migration of 23%. Clips were used in 98 patients in 17 series. Ovesco was mainly the used clip, 67%, and PTS also was used, and success rate was 69%. Fibrin, interestingly, was used in 10 series, 63%, with good success rate. But as I said, our personal experience with using sealants, either fibrin or cyanoacrylate, is not very, very satisfying. I think till now, dosers of leaks and fistula has been more on experience based. We do whatever the experts tell us to do, but this is a time when we move to evidence based, where we should have more and more randomized trial where we compare endoscopy with surgery, we compare one device for endoscopy with another device, and maybe a combination, and then only science will move forward. But till that happens, let me summarize that as of today in 2020, the take-home message would be that try to do endotherapy early in the course of complication, preferably within 24 to 48 hours, if not at the time of endoscopy itself. For a small leak, less than 10 millimeter, TTS clips are good enough. For large leaks, more than 10 millimeter, either OTSC clips or stents. I prefer OTSC clip. If there is associated distal stricture, stent is always preferable. If there is leak with infective cavity, we should use more and more of endovac with or without combination stent. Thank you very much.
Thank you, Mahesh. As usual, a very elegant presentation, good summarization, and he also went beyond the limitation, also talked to us about leaks, which are mostly post-surgical, and spontaneous perforations. Now, I have a very intelligent and experienced panel. There are just 2 instructions from the organizer since we are lacking late. I'll ask each one of you a couple of questions. Some of them Mahesh has covered. Mahesh, you are welcome to comment anytime, but I'll ask, and I'd request everyone to be very brief because of the limitations of time. And since Dr. Bhargav, for 2 reasons, he is my mentor and he has seen 2 eras. He was one of the pioneers of therapeutic endoscopy. In fact, sclerotherapy, I think, started with Sir, and he has seen the present era. I'd like to ask Dr. Bhargav, what is the difference he has noticed from the era in the 80s to now in the rates of perforation with more and more aggressive procedures?
Thank you,
Dr.
Manu.
Bhargav, please. Yes, sir.
I'm also thankful to Anil. Anil is also like you to me.
Yes, sir.
And,
He is a junior. I was somewhere, I managed to teach or unteach him for a few times.
Okay. And then I started doing endoscopies from 1974 onward when I was in the States and doing fellowship. So it's a long, long thing. And at that time, I tell you, the only thing was endoscopy, upper GI, and colonoscopy. And ERCP was just coming in United States, though it was seen in England, but it was coming in the United States. So we were trained with that, and I got good experience of colonoscopy because I was involved in early detection of colon cancer, a federal research project. And after that, then all these screening procedures occur. So I was doing 8 to 10 colonoscopies a day during my fellowship. So that was the system. So naturally, you are seeing I have students, and then I have grand students also now, that you people are having students. So we are, I'm actually third generation. So at that time when it was started, so a lot of endoscopic perforations were occurring because nobody was expert and everybody was doing it. Seemed like I also seen first perforation at gastroesophageal junction in the fundus by expert endoscopists in the US. So the things, but with the passing era, the more and less perforation occurs during the diagnostic endoscopies. But the iatrogenic perforation started occurring more once the therapeutic endoscopy started, which we also did lot of therapeutic because we invented the first polypectomy in India in 1978, which was a large polyp. So, but there was no complication. And then subsequently we had all these foreign body removal and all those things. And we completed our system of doing therapeutic endoscopies between 1977 and 81. Then we were doing all the therapeutic endoscopies which are existing today. Then, so it was only in the first space endoscopy. Now, after that era is coming as second space and third space endoscopies also, and which you people are discussing now about the poem and dissection of bigger polyps and leiomyomas and lipomas and so on. So these are the newer things which are coming in last 5 to 6 years only. So the era is definitely increasing day by day, and more new procedures are coming. And I am thankful to my next generation like Manu and Anil and Mahesh Goenka also, that they are doing all the second and third space endoscopies, for which I'm not doing that, but at least I'm very much satisfied that India is progressing well in these techniques also. Now let us see the iatrogenic perforation, and I just collected data from meta-analysis of two studies, and the things are that more and more complications are occurring in endoscopic mucosal resection as well as endoscopic submucosal resections. So these are the two areas. But we also see iatrogenic perforation by doing balloon dilatation in cardiac achalasia, then difficult strictures in the esophagus, then removal of foreign bodies which are pointed and irregular shape. So these can also create problem in upper GI tract. Then the next thing will come when we go to ERCPs, because at our time we were doing mostly diagnostic ERCPs, and subsequently we came out to do the therapeutic also. But now with the more and more procedures which are going on, so naturally the more complications are occurring by putting the sphincterotomy, by doing sphincterotomy and putting the stents in this, and then doing dilatation of the common bile duct, etc. Then, so what we concluded is that the risk of perforation increases significantly from 0.6% in diagnostic to 6% for surgical procedures like EMR and ESD. So the range is very thin, and more complications occur during second and third space endoscopy rather than the first space. Now, cardiac achalasia can lead to 0.4 to 14% and gastric polypectomies from 0.5 to 1%. For ERCP related procedures, the complication rate is 1 to 3%. Now, the risk of iatrogenic perforation due to diagnostic colonoscopy and the therapeutic colonoscopies, including polypectomies, etc., occurs between 0.5% to 2% cases, and with ESD, it is about 4.2%. So the incidence increasing with the second and third space endoscopy. Now, the common site of perforation in the upper GI tract is the upper GI tract is in the esophagus.
I want a reminder that we must finish faster, sir.
Okay, so in the esophagus and in the stomach less, and then in the third part of the duodenum. Then colonic perforations occurring mostly in the sigmoid colon, because especially in the diagnostic procedure when new persons are doing, because it's a tortuous thing. And then what is happening is that it is also more common in the right colon because of the thin wall, and we are putting more and more air, so iatrogenic perforation occur more over there. So incidence of perforation depends upon the expertise of the endoscopist. That is one thing which is very important. It can occur more with the persons who are learning and without under the expert hand, but it is very less once you acquire the expertise.
Thank you, sir, for a very nice review. You heard that from an experience lasting over 45 years. Thank you, sir. I'll request Samir Taneja now to take up the next question. Of all the modalities discussed, Mahesh discussed everything. What do you prefer depending on the case? Samir? Can I have Samir on the screen or audio, please?
Samir, I cannot see him.
Oh, then I'll ask Samir Mahendra to give that. Since both of them are Samirs, I'll ask the other Samir to take it.
Yeah. So first of all, I must congratulate Dr. Goenka for an excellent talk. He always sets the standard higher and higher. I don't know what to do. So regarding the question, it depends upon the type of lesion we are dealing with. That is the kind of leak which we are dealing with. For example, if it's a leak which is up to 1 to 1.5 centimeters, then through the scopes are the best modality to block the leak. Advantages are it's easy to place, easily available, and the most important thing is you can do the procedure in the index case itself. That is, you don't need to remove the scope. So there is minimal chance of contamination. Now, if the tissue is necrotic, non-viable, then application of through the scope clips are difficult. Lesions which are bigger than 2 centimeters over the scope clips are the best modality if we can get an in-face vision of the lesion. Stents are generally becoming very popular, especially when the lesion or the defect is more than 3 centimeters. Endoscopic vacuum therapy, as sir had discussed, it is very good for chronic leaks or chronic fistulae, where the results of clips are not that good. So a combination of endovacuum therapy with stent is the best modality in those chronic fistulae and chronic leaks, which are detected late in the course.
Thank you, Samir. Ajay, you are on the screen, Ajay?
Yes, sir. I'm on the screen.
Okay, Ajay, anyway, your number is very difficult to get, Ajay. You must have changed. Just to tell you, you are using OTC or TTS clips mostly, and suppose cost is not the issue, which one do you prefer and where? Because that's the second. You saw Mahesh he told us about OTC SC being one of the commonest modalities used. What about your center, Chaitram?
So what we do is, if the perforation is detected right at the time of a procedure, it is always easier, because these are the iatrogenic perforation which are done either during the colonoscopy or during the polypectomies or during the esophageal dilatation. So if it is a colonic perforation or it's an or a polypectomy perforation, it is easier to use the TTS clip because they are easily available, they are cheaper, and the defects are usually about a centimeter or 1 to 1.5 centimeter. But the problem arises when you are looking at the esophageal perforations, especially post-corrosive esophageal strictures, where you have a lot of fibrosis already happened, where these clips, even the OTS clips may not be very successful. So one of those things is again the size, the estimate of underlying fibrosis, whether these clips will hold at the site for a long time for the clips to stay. But if the leak is of a 2 centimeter, 2.5 centimeter, then obviously it will be over the scope clip. But over the scope clip are much more costlier, and they are not easily available in tier 2 and tier 3 cities. And then the more availability is of the covered stent, which can be kind of a rescue therapy in these leaks at the time of a perforation.
Thank you, Ajay.
Manu, can I make a comment? Manu, can I
Yes.
make a comment?
Yes, yes.
See, I would totally agree with both Samir and Ajay, but then I think it's not what Samir told was correct, that when you're finding a perforation, you go with the same index endoscopy, you go with the TTS clip and do it. I think the important determining factor will be the nature of the perforation. So if I find a sigmoid perforation which is 2 centimeter in size, I would rather come out, put an OTS clip and go in again rather than trying with the TTS clip. So I think there are multiple factors in a given case. You have to combine all of them to decide which one we'll do. In general, I will agree what Samir and Ajay said.
Point
But
taken.
most, can I just make a comment?
Add on, Ajay.
Yeah, because what we feel is that the most of the perforation which are done during the endoscopy, they are by and large less than 2 centimeter or less than 1.5 centimeter.
Yeah, it's small and
very
no contamination has occurred. No contamination has occurred.
Yes.
Okay, since we are talking of covered stents, Prashant, I saw you some time back. I'm not seeing you now.
He's there.
Mahesh told us about putting the indigenous thread therapy to prevent migration. What else can we do, and what do you do at your center, Meerut? Prashant?
Can you hear me, sir?
Yeah,
yes, we can see you now and hear you.
We follow the same thing that Dr. Goenka suggested. We are using threads to hold our esophageal stents either for dilatation purpose, or when we are using it for a perforation associated with a stricture dilatation. So these are the other. We have used clips also at times, but clips would not hold for a longer time, and some of the times they tend to slip. So I would always use threads to hold these stents there.
Mahesh also showed us the overstitch, the endo stitch. Do you think if it becomes easily available, one single stitch and later on you cut it off? What do you think?
It is an exciting modality, but it is very costly.
Yeah, I know it's mighty, but we are first ignoring now costs. I know it's a cumbersome device, mind you. Anyway, if it comes, so you also use. Any other comments from any panelists? What they do to prevent migration? Anyone?
I use
quick.
So hemoclip is one of the another safe option.
So use an endo clip, TTS.
Manu, my experience with hemoclip is very, very poor, that I never find it to be successful. After a day or two, they just move away. So Ajay has been lucky.
Good.
But they hold for about a week or so. And by that time, these leaks of the fistulas, they heal.
Okay.
Another important thing what we have done in these Borov syndromes is to prevent the migration. We have put stent in one of the case, and then it hold it very nicely for almost like 2 weeks. So this was just one single case where we had stent to prevent the migration.
Manu, can I comment on that?
Quickly.
Yeah. Dr. Vikas Singla from our department has thought of 2 techniques, and we tried it in few patients. That in patients with no problem of holding on to the lower end of the esophagus, that stents do tend to migrate if there is a leak. So what he has described is, if you create a submucosal tunnel, expose the muscularis propria, and if you put a clip between the tip of the stent and the muscle, it holds on. So rather than having a thread which is coming out of the nose for a 2-week period, this is what we have been trying for the last few days. In addition, Vikas has also described a new technique in patients with pyloric benign obstruction of corrosive origin, in which using a loop of the thread, this thread of the loop is stapled onto the edge of the stent in the antrum. It holds on. So this, and on both these occasions, he has received the first prize in the endoscopy.
And how do you remove the staple thing at the end? You cut it
At
through?
the end, you have to just pull it.
Okay.
Once you want to remove the stent, it just gets pulled off easily. So you can prevent the cumbersome process of thread. And luckily, it's got the first prize in endoscopy conferences at national level.
Okay. Thanks. I think we should follow, Vikas should publish a series, and we'll probably, as Mahesh has said, evidence-based. Now, Samir, ERCP perforations, how often do you see at Lucknow? And what do you do? Type 1, we know Peter Cottons, where you perforate through. Mahesh has shown that. But what about the minor perforations, iatrogenic?
So as for the Stafford classification, there are 4 types of perforation. Number 1, duodenal perforation. Number 2 is periveterian because of the extended sphincterotomy. Number 3 is if there is injury to the bile duct or the pancreatic duct. And 4th is where you have a retroperitoneal microperforation with leakage of gas.
2, 3, 4, you tell me. 2, 3, 4. 1 Mahesh has commented already.
2 is basically what we need to do is we need to do 2 things. We need to close the rent and divert the bile. So for that, we have 2 options. One is fully covered metal stent or placement of ENBD or a plastic stent. Studies have shown that fully covered metal stents are the best. They compared to ENBD, less prolonged hospitalization, less chances of retroperitoneal abscess formation, and less pain. So if available, fully covered metal stent would be the best option. Second best option would be a ENBD placement. And in type 3, which is the second commonest, what we do is we simply need to bridge the leak with a stent. We can use plastic stent, you can use a metal stent. And in type 3, we don't need to do anything because 95% are self-limiting. We just need to give antibiotics.
Thanks.
And monitor.
Dr. Bhargav sir, clinically, what do you do when you identify, how do you identify there was a perforation in, let's say in the early eras? Was CTs also were not available?
Yeah, early eras, the most important is when you perforate, and I have seen a lot of perforation during colonoscopies. And what is there that the person will complain of pain abdomen, which may be localized or it may be just generalized pain in all over the abdomen. And it may be very severe pain and followed by abdominal distension. And when you palpate it, then it becomes a tender abdomen and vowel sounds become absent. So these were the clinical things. But we were always doing the plain X-ray abdomen, which were showing the leak of gas under the diaphragm and at other places also. Then subsequently the era of ultrasound came, and then the final is CT scan, because with CT scan you can possibly identify the site of perforation also. So that were our things.
Thank you. Ajay, since we are Ajay, since we are speaking of CTs, suppose you identify a perforation when you are doing it. Do you think a CT is needed in all cases, or you only where you are dodgy about yes, no, yes, no?
Yeah. So, sometimes when you do not identify, but you are strongly suspecting, then only. But if you have identified as perforation right during the ERCP, then there is no need for a CT scan. The CT scan is only needed to make the complete set of investigation for your medical legal purposes and other things. So that you do a complete sealing of the perforation, you do a CT scan, document that there was a perforation, there is no collection inside the abdomen, or there is a minimum collection, keep the patient NBM for next 2 to 3 days, follow up with an ultrasound that there is no collection, patient is improving. The other problem which I have seen with ERCP is some of these micro perforations. When you do a CT scan, you see a little bit of air here and there, you don't find any collection. You do a contrast CT scan, you don't find any leak. And there you need to do a follow-up CT scan maybe after a week or so to demonstrate that everything is fine. So it's a case-based situation whether you want to do a CT scan, but not in all cases.
Also said type 4, you hardly need to do anything.
Yes.
Prashant, you work in a center. Suppose, what about the surgeon here, Prashant? When will you bring him into the loop?
Whenever we encounter a large perforation in endoscopy or colonoscopy, Then we always think when we are not able to close the perforation, we do not have a OTBSC clip available, or where the contamination is too much. And at times in esophageal perforation, where there's a lot of fibrosis and corrosive induced strictures, there also at times we would consider getting in the surgeon. But it is always a case-based approach.
From Kedarnath, you get a patient, Meerut, you get a patient from Kedarnath, there's not much contamination, but a delay of 24 hours. Do you attempt or you call the surgeon?
Yeah, I would call the surgeon. At my place, I would call.
Even if there's a delay, you will call the surgeon.
Definitely, because there is going to be contamination.
Okay. Okay. So you keep him in the loop right from the beginning, I hope.
Yeah, yes. It is a procedure to get a GI surgical call to be done for all these perforation cases. Even if we are doing it in the operation theater, an endoscopy, and we encounter a perforation, we definitely give a call to our colleague to come over and have a look.
Manu, if I have to make a comment there, Manu, can I make a comment? I think there's no rule as such that you can't do an endoscopic procedure after 24 hours. But I agree
that's
that
what I said.
later,
You get it.
later
You get from Agartala, one fellow with a colon will be contaminated. Let's say an upper GI perforation.
Yep. So I think this patient had a pneumothorax, which could be easily controlled. So we just put we put clips and we clip and we drain the pleural cavity. So I think it's a case-to-case variation, but earlier the better.
So like Borja syndrome also, you can put a stent or you can close the fissure even after 3 days or 4 days with a proper mediastinal drainage. You don't need to have a surgeon in the picture at the point. Surgical consultation is always welcome because you need to have a multidisciplinary approach. But most of these leaks, even after 3 days or 4 days in this era, with good stent placement and a good mediastinal drainage like Borja syndrome. Recently, we had a rectal perforation and we closed it with the Ovesco clip after 4 days of a perforation.
Thank you. I think we have come to the end of our time. If there are no more comments, I'll thank Mahesh for his excellent talk. All my 4 panelists, Dr. Bhargav, Dr. Prashant, Dr. Samir, and Dr. Ajay, for a wonderful discussion. And Ajay, I'm handing it back to you in case you have to take questions, or we'll close the session. Thank you very much.
Thank you.
Thank you.
Thank you, sir. Thank you very much.
Thank you, sir. Thank you. Thank you.
Can I tell Mahesh, you did a very good job, and we learned a lot from the lecture about various types of stents and various types of clinics and so on. So thank you very much.
Thank you, sir.
Thank you, Dr. Manu, for excellent moderation of the session. Let me remind Dr. D.K. Bhargav that the first series of upper GI polypectomies we had done under him, and we are presented in the national ISD conference. So that was the first publication of India. I was his resident at that time. That was a collection of 15 cases of upper GI polypectomy. That was the first attempt at therapeutic endoscopy from India. May I also remind Dr. Mahesh Goenka, he claimed to be the tail ender without realizing that his own colleague and the compatriot Saurav Ganguly also started as a tail ender. And he was the guy who changed the scenario of winning habit for India. Nobody knows, and today we know he's the BCCI president, as is Dr. Mahesh Goenka, the president of SGI. And everybody knows that Saurav Ganguly is heading towards the president of ICC. We wish tomorrow,
if I have to give you some news, he's not only looking at the ICC, but he's looking to become the chief minister of West Bengal.
So we wish that you also become the president of World Association of Gastroenterology, GI Endoscopy. With that, we formally come to the end of the presentation of today's session. As is the customary tradition with our department, may I request Dr. Vikas Singla to please give us the summary of the day. He'll take 5 minutes to have a recap of what we have learned today.
Good evening, everyone. I think we had a wonderful day. We had very informative lectures and a wonderful discussion. Dr. Anil just mentioned about the technique we are using for the holding the stent. I just want to share with your permission. Dr. Neil, can you see?
Yeah.
So here we can see the stent. So what we do now, we are using the endo loop to prevent the migration. So we are dropping the endo loop inside the lumen. Then we are fixing the one end of endo loop to the stent with the clips. Then we apply multiple clips on the other end. We apply 6-7 clips, and that works very well. And there is no discomfort of bringing the thread outside the nose. So this loop and clip technique, it works very well to hold the stent. In some patient, we also make the mucosal flap, like in POEM technique, we make a mucosal flap. Then we use the clips to fix the flap with the stent. And these two clips work really well to prevent the migration of stent in benign diseases. Now coming to the summary of the day, I think it was a wonderful learning day. There is so much to learn today. First, Dr. Vedo mentioned the role of image and
stop the slide sharing.
Yes, sir.
Then you can see the full screen.
Yeah. So the first session was regarding the role of image enhanced endoscopy in upper GI. I think the message is very clear. If we want to detect more lesion in the esophagus or the stomach, we have to spend more time, and we have to sedate the patient well. Patient should be well sedated, and we should spend at least 10 to 20 minutes to detect more lesions. And patient should be prepared well. There shouldn't be any mucus or food inside the stomach. And with the NBI, we can detect more lesions in the esophagus as compared to white light endoscopy. And with the NBI, depending on the vessel pattern, we can stage also. We can predict the depth of early esophageal cancer. In the stomach, as compared to white light endoscopy, we can pick up more lesions by using NBI, but it will be difficult to stage the lesion using NBI only. Then Dr. Mohan has excellent deliberation on the colonic polyps. So the pedunculated polyps, they are mostly resectable because mostly the stroke is free of tumor. They don't require much workup for the invasion. On the other hand, sessile polyps, which are more than 1 centimeter, they have definite risk of neoplasia. So first we should do the Paris classification based on the gross morphology. So the Paris 2C, which are depressed, and Paris OS3. 3 means there is ulcer on the polyp. If there is ulcer on the colonic polyp, it indicates it's a deep cancer, patient requires surgery. On the other hand, if it's type 2C, means depression is there, but no ulcer is there, 50% of the lesion can be resectable. I think now the NBI is the gold standard to define the resectability. With the known magnification NBI, we have NICE classification. NICE 1 and 3 are quite accurate. NICE 3 means it's a deep cancer, 1 means it's a hyperplastic, and the NICE 2 is equivocal. So we have to do the magnification NBI in NICE 2, which, where we have JNET classification. Then Dr. Mike Wallace discussed about the therapeutic diagnostic EUS. Dr. Wallace mentioned in pancreatic masses, FNB is the order of the day. We should stop doing FNA. All the pancreatic masses, we should do FNB, because many such lesions, they will require immunohistochemistry because of suspicion of autoimmune pancreatitis or suspicion of neuroendocrine tumor. And few patients may require targeted molecular therapy in the future. For that, we will require genetic studies. So FNB gives better sample for IHC and the genetic study. Role of elastography is emerging in differentiation of malignancy in patients with chronic pancreatitis. Chronic pancreatitis with the head mass is a difficult situation. No imaging can tell you whether it's inflammatory or malignant. Even the FNA yield is low. So the elastography may be crucial in discriminating between the malignant and the benign lesion in a patient with the chronic pancreatitis. Then Dr. Wallace mentioned about the EUS hepatology, a new dimension of the endoscopic ultrasound. He mentioned about the role of liver biopsy in the obese patient, where it's difficult to do the percutaneous biopsy. One can do the EUS FNB in the obese patient. Then one can puncture the portal vein. One can measure the portal pressure. So in the future, we may be measuring the portal pressure by the EUS only. And EUS guided coiling along with the glue injection is likely to become the first line of treatment for the fundal varices. Then Dr. Vinay Dhir discussed about the therapeutic EUS. EUS guided biliary drainage is better than the PTBD in terms of clinical success. as of today, USBD is as good as primary USBD is as good as ERCP. In the future, with the change in scope and with the better instrumentation, US guided biliary drainage may get the first preference over the ERCP, but as of now, they are equal. For percutaneous fluid collection, EUS is for peripancreatic fluid collection, EUS is better than the conventional endoscopy. It has lesser complication. For the pseudocyst, plastic stent alone may suffice. On the other hand, if the patient has walled off necrosis and there are chances of future necrosectomy, LAMS is better than the plastic stent, and there are high chances of disconnected duct syndrome on MRCP once we have drained the walled off pancreatic necrosis. 60% of patients, they can have DPDS once you remove the stent, but out of 60, only 15 to 18% will develop the recurrence of fluid collection. So the LAMS should be removed at 4 weeks. Then Dr. Amit Madhav discussed about the third space endoscopy. As of today, POEM and the lap halar myotomy are equally efficacious, but yes, there are serious problem of the GERD with the POEM that has to be looked into. We have to see the patient which are more prone to the reflux in the future, and these patients should be offered FPOEM directly. Dr. Amit mentioned about the STIR technique. It's an excellent technique for the submucosal lesions with excellent efficacy and very few side effects. With the JET POEM and the D POEM, we can achieve the complete septotomy for the Janker and the esophageal diverticulum. Dr. Amit touched upon the new dimension, fourth space endoscopy. We can go outside the esophageal lumen. We can do the F POEM for the reflux disease after POEM, or one can remove the peritoneal tumor also. This will be very interesting to see the future of fourth space. Dr. Amol discussed about the ESD. He discussed about the indication of ESD in the esophagus, stomach, and the colon. In the colon, up to 2 centimeter lesion, they can be removed by EMR or ESD. The lesion size is more than 2 centimeter and there is risk of high grade dysplasia, the en bloc resection should be done. And Dr. Amol discussed about the various techniques of traction. So he discussed about the pocket traction, which can make the ESD easier, faster. And he discussed about the special clip SO ring for application of traction during the ESD. And he discussed about the various solution for the ESD. And he also mentioned that geloflution is the most commonly available in India and it can be used. Last was the excellent lecture by Dr. Mahesh Goenka. He discussed about the perforation, leaks, and the fistula. Dr. Goenka mentioned that the small defects can be closed with the through the scope clips, but for the larger leaks, we require the either over the scope clips or the stent. So Dr. Goenka mentioned we have another 2 type of clip. One is the through the one is the padlock clip, and another is the Ovesco clip, and both are comparable. But with the padlock clip, we have the channel of the scope free to pass the accessories. And Dr. Goenka also mentioned that if there is a stricture along with the leak, one should prefer putting a stent, because if there is a downstream obstruction with the leak, then until we handle the stricture, the leak will persist. So in case of stricture with the leak, stent should be preferred. And if there is a cavity, infected cavity, the sponge can play a very important role. In this patient, sponge along the stent can be used. So I think we had a wonderful day today. There was so much of learning and it was difficult to mention in 5 minutes. I just made an attempt about that. So yeah, over to Dr. Anil. Yes.
Thank you, Vikas, for very aptly summarizing the day's proceedings. And with that, I am pleased to inform that over the last 4 days, that is 2 consecutive weekends, we had 10,000 participants listening to the excellent deliberation by the learned faculty. So we all learned a large number of lessons from the celebrated faculties, and we continue to hope that we'll be learning in near future also. With that, may I ask Dr. Ashish to please propose a vote of thanks before we finally sum up.
Thank you, Dr. Anil. So we have come to the end of our 4-day academic feast of clinics in Hepato-Biliary Disease 2020 edition. And all the 4 days were very well attended and very well appreciated. And all credit goes to all the speakers, moderators, and panelists So formally, on behalf of the organizing committee of clinics in Hepato-Biliary Disease 2020, which is organized by the Gangaram Hospital as well as Delhi Liver Foundation, I thank all the speakers for delivering very lucid and very informative lectures and summarized all the contents in short time. I thank all the panelists and moderators for making each session very interactive, very informative, and very lively. And also, I would like to thank the participation of all the delegates from across the world. Each of the 4 days were very well attended. About close to 3,800 participants on the second day. And today also we had similar about 3,000 participants. So total overall 10,000 participants. And we hope to meet soon again. My special thanks also goes to international delegates and participants because of the odd times also they participated. I would like to thank Microlabs as our academic partner for their excellent logistic support. And I would also like to thank Pranav Viswas and his event partner, MyProvide, for providing the platform for this meeting and for the excellent flawless management. And I would also like to invite you for next year's, and hopefully by that time Corona will end and we'll have a formal conference, and Dr. Anil Arora will soon announce about that. Over to Dr. Anil.
Thank you, Ashish. I am thankful to all those who participated actively and make the discussion very lively, useful, informative, and authoritative. With that, I'll again request you to join us on the next time. And it's easy to remember that we almost always hold our meeting in the first week of September. Let's hope the corona goes away, even though the news from US is not good. The earliest they can hope to have any meeting is the early part of 2022. So maybe if we are not able to hold it, we'll certainly get back to the E version, and we look forward to see you all again. Thank you so much. Goodbye and good night.
Thank you, sir.